Good morning. Welcome to the third hearing of Portfolio Committee Number 2, Health for the Inquiry into Budget Estimates 2025-26. I acknowledge the Gadigal people of the Eora Nation, the traditional custodians of the lands on which we're meeting today. I pay my respects to elders past and present and celebrate the diversity of Aboriginal peoples and their ongoing cultures and connections to the lands and waters of New South Wales. I also acknowledge and pay my respects to any Aboriginal and Torres Strait Islander people joining us today. My name's Dr. Amanda Conn and I'm Chair of the committee. I welcome Minister Jackson and accompanying officials to the hearing. Today the committee will examine the proposed expenditure for the portfolios of health, regional health, water and mental health. I note that the committee has determined to examine these portfolios concurrently, which is a somewhat unconventional choice. To explain the rationale of the committee, in the absence of Minister Park, we had a witness list for health and mental health with a significant number of witnesses that overlapped, and the committee elected to examine all of these portfolios together in one day rather than have a separate hearing for health on a different day, which hopefully explains the very large number of people in this room. I ask everyone in the room to please turn their mobile phones to silent. Parliamentary privilege applies to witnesses in relation to the evidence they give today. However, it does not apply to what witnesses say outside of the hearing. I urge witnesses to be careful about making comments to the media or to others after completing their evidence. In addition, the Legislative Council has adopted rules to provide procedural fairness for inquiry participants. I encourage committee members and witnesses to be mindful of these procedures. Welcome to all of our many witnesses today. Thank you for making the time to give evidence. All witnesses will be sworn prior to giving evidence. Minister, I remind you that you don't need to be sworn, as you've already sworn an oath to your office as a Member of Parliament. Witnesses who have already been sworn before this committee during this inquiry do not need to be sworn again. So I'll now call on only those who have not yet appeared to be sworn. I note that there are witnesses in the overflow seating area, and I'd like to remind you that if you come forward to answer a question, to please bring your nameplate with you and place it in front of you at the table. This assists Hansard in ensuring the correct witness is identified in the hearing transcript. So I'll read out the list of witnesses remaining to be sworn in, and after I read your name, could you please restate your name and position title and then swear either the oath or affirmation. We'll start with Jennifer Black.
Hello, yes, Jennifer Black, Mental Health Commissioner for New South Wales. I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth.
Thank you. Ms Emma Schoolander.
Morning. I'm Emma Schoolander, the Chief Executive of Health Infrastructure and the Deputy Secretary of Infrastructure and Asset Management at New South Wales Health. I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth.
Thank you. Amanda Larkin.
Amanda Larkin, I'm the Acting Chief Executive of Western Sydney Local Health District. I swear that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth, so help me God.
Thank you. Jill Ludford.
Jill Ludford, Chief Executive of the Murrumbidgee Local Health District. I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth.
Thank you. Anthony Shembry.
Anthony Shembry, Chief Executive, Northern Sydney Local Health District. I swear that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth. So help me God.
Thank you. Mark Dycraft. My apologies if I've mispronounced that.
Mark Dycraft, Chief Executive, West Local Health District. I swear that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth, so help me God.
Thank you. And Jeremy McAnulty.
Jeremy McAnulty, I solemnly, sincerely and truly declare and affirm that the evidence now and about to be given by me shall be the truth, the whole truth and nothing but the truth.
Today's hearing will be conducted from 9:15 to 5:30. We're joined by the Minister for the morning session from 9:15 to 1 o'clock with a 15-minute break at 11 o'clock. In the afternoon, we'll hear from departmental witnesses from 2 o'clock to 5:30 with a 15-minute break at 3:30. During these sessions, there'll be questions from the opposition and crossbench members only, and then 15 minutes allocated for government questions at 10:45, 12:45 and 5:15. And we'll begin this morning with questions from the opposition.
Point of order, Chair. I'd like to take a point of order before we start. And the point of order goes to the sticker on your laptop. It is an overtly political sticker, designed obviously to be provocative. It is seen by everyone in this room, plus those that are joining the telecast. If I can read it, it says health workers, I can't quite see it, but it was clear on my screen before we went off the screen, deserve raise and not just praise. The implication there is that the government is providing only praise to health workers and not raise. Now, the reality is the government provides both, raise and praise. Now, you are in the very honoured position of being the chair of this committee. You are chairing this committee and you are taking advantage of that chair position to clearly demonstrate or place before this committee and the population at large an overtly political sticker, and I take a point of order in terms of you doing that. It is deliberate, it is conscious, and I'll be looking for a ruling and guidance from the committee secretariat in regards to the use of that sticker. I know there's one over there which says Nationals, but there is no implicit or explicit political message. But yours is not just implicit.
Are you going to allow me to rule on the point of order?
No. It's not just implicit, it's explicit. And I'll be looking for guidance from the committee secretariat in regards to the display of that sticker.
Well, can I make a submission on the point of order?
Sure.
As much as I may agree or disagree with the statement that is on your laptop, it's always been, I guess, the practice that our devices may carry symbols or stickers that we support. Now, in relation to your sticker, I note that was a phrase that was used by the government when they were in opposition. So I don't think there's any offence that can be taken from that. They used to use it against our side of politics, so I don't see a problem with it. It's clearly annotated with the Greens logo. I think if we go down this path, then any number of issues, I would oppose any censoring of people's devices, Chair.
Thank you, Mr. Fang.
To the point of order.
No, can I rule on the point of order?
No, I've got to the point of order.
Well, the Chair can.
No, well, to the point of order, the reality is that political messaging is political messaging. It can be used in the political domain writ large, but to deliberately use it in the context of budget estimates hearings as the chair of the committee, is just unacceptable. Now, the fact of the matter is political slogans do get used in political campaigns. This is not a political campaign. This is a budget estimates. And I'll be asking for the committee secretary to provide advice.
Mr. Donnelly, to the point of order, I disagree with some of the inferences you've made about the intention and what should be drawn from the sticker. In response to your request from guidance from the Secretariat, this issue was discussed at length at the most recent meeting of the Chairs Committee, which determined not to make any resolution in relation to stickers. And I would also add that this particular sticker has been on my laptop for more than 12 months during not only budget estimates hearings, but a variety of unrelated inquiries. It's never before drawn the attention of the committee. So on both the basis that the Chairs Committee did not make any ruling about stickers on laptops or other types of slogan during hearing, and the basis that this is the first time this sticker has been a problem in more than 12 months that it's been there, I will rule against your point of order and like to get started with the questioning. Thank you. To the opposition.
Thank you. Good morning, Minister. Good morning, everyone. Thank you for being here. Minister, one of the greatest challenges in mental health, especially for our young people, is what they encounter in the online environment. And you'd be aware of federal moves in this space in terms of the social media ban. Are you supportive of this? Is New South Wales working together with the federal government on this initiative?
Oh, yes. So I think you'd probably be familiar with the fact that the New South Wales and South Australian governments co-hosted a social media summit to inform the views of the New South Wales government on this matter. I mean, it's fair to say that as part of that summit, one of the roles that I played as the Minister for Youth was to facilitate the Advocate for Children and Young People hosting a specific youth engagement opportunity, and in that forum different views were put by young people, and I've always acknowledged that, but on the basis of the overwhelming sort of weight of information and evidence provided both in Sydney and in Adelaide, the view of the New South Wales government is the delay in accessing social media is in the interest of young people. Not that it's not complicated, not that it's not going to be challenging, but that, it's worth having a crack at trying to delay young people's access to social media because of some of the negative mental health implications. So obviously the Commonwealth is leading that, but the New South Wales government, is supportive of giving that a go.
And you'd be aware of the work done by a Legislative Council committee recently in relation to pornography and its effects on children and the online issues that present there, and the need for us to look carefully in that space as well.
Yeah, I am familiar with that Legislative Council inquiry.
Yeah. So, Minister, I'm just curious, is the South East Sydney Local Health District website, is that covered by the social media ban?
I don't think so. My understanding is that the social media delay covers a limited number of social media platforms, of which I don't think LHD websites are included.
I'd like to table a screenshot of a Google search in relation to that website. The material is so distressing that I have previously made copies. I've put them in envelopes because I don't expect the Secretariat to have to look at it. It's available for people should they choose to look at it. I am not prepared to read out what's there, only to say that it very clearly lists a number of sites accessed and apparently hosted through the South East Sydney Local Health District, dealing with a range of pornographic interests. And I ask you, Minister, I am sure that as a parent you are concerned about your children's web searches. How do you as Minister address the concerns of mothers and parents who believe that their children would be safe searching on a New South Wales Health website and could be exposed to explicit pornographic links?
Well, I haven't seen anything that you're referring
Perhaps. And I apologise for having to put this in front of you, Minister, and I only do that because I know it's been publicly available, accessible through Google site searches and Bing searches, and has, I believe, been available since about July, and it is material that certainly if a child stumbled across, frankly, if most adults stumbled across, they would see it as very concerning.
Chair, just for procedurally, it'd be great if the members of the committee could have a copy.
Thank you. Sorry. So I've just agreed for the witnesses
to
be provided with a copy of this, and for members, the committee will have to deliberate later about the publication or tabling status of this. Noting, in particular, Mrs. Cotter, it's not dated, but to facilitate the questioning, I'm very happy for the witnesses and committee members to have a copy of what you're talking about.
Sure. I mean, as I said, I've not seen this before. I can't verify it, but I think Secretary Pearce was just commenting to me that she has some knowledge of this issue.
Yes. Look, it is something that we are aware of, Ms. Carter, and what I can advise you is we've advised media outlets, like all websites, there is a risk that bots can infiltrate websites, so it's not something that's specific to New South Wales Health. Certainly not something that was facilitated or generated by New South Wales Health. And the files were indexed and discoverable via search engines, but they couldn't be accessed via the website. Our Chief Information Officer has confirmed that.
Can I just confirm what you just said, that they could be discoverable? So a 10-year-old on Google could discover these pages, and any careful parent would think, oh, my child is searching on Google, we could have safe filters on that would admit South East Sydney Local Health District, and even if they can't access the sites, they can access the words describing
but the word,
sites.
I understand. I mean, the word is sex.
Yeah.
The word is porn. Now, I mean, I don't necessarily want...
There are other words that I do not choose to use that describe...
Please, Chair, to answer the question, if that's
Mrs. Carter,
okay,
could you please allow
before
Mr.
this
Listow?
becomes something that it's not. It's a common issue for anyone who runs a website. So this is not something that is specific to New South Wales Health. I think we need to be very clear about that spam bots can be used to trawl the internet for
excuse me, Mrs.
misconfigured web
Pearce.
forms. Can I just finish, please, Ms. Carter? It's not an example of a data breach, and no sensitive information was impacted. As soon as the district became aware of it, it responded to appropriately remove the files and disable the ability to upload of it as soon as they became aware, as I said, in July. So all I'm saying
with respect,
is
Mrs. Pearce,
yeah.
I'm not asking about standard data protocols. In fact, I hope to come to those later because there are significant questions that are raised by this. And yes, it is a known risk, but since it is a known risk, what is, I mean, Minister, as a female leader in this government, what's your responsibility to make sure that the government is part of the solution, not part of the problem, with our children being exposed to what we acknowledge can be very harmful material?
I mean, I assure you male leaders in the government take these issues very seriously.
I know,
too.
I hope they do too.
But,
I hope they do too.
Our obligation is when things like this occur. I mean, as Ms. Pearce said, I mean, there are thousands and thousands and thousands of New South Wales government web pages, not just in health, across the entire New South Wales government. If you're on the internet, you know, you are exposed to these kind of bots. Our response is when these issues are brought to our attention, we deal with it swiftly and expeditiously, and that's exactly what we've done. There's no the only way to avoid this happening in any way, shape or form is to not be on the internet, is to not be in that occasional cesspit of the online world. But there's a lot of good that comes from the online world because we're able to share information freely and accessibly for people. So yes, we want to be out there, we want to be providing information to people, we want to have good systems in place to identify these issues and deal with them, and that's exactly what's happened. But just to reiterate, as the Secretary said, you couldn't actually click on these links, you couldn't actually access this information. Yes, it was available in this searchable form, and as soon as that was brought to the attention of health, they've responded to that.
I think there are questions that we can explore later about the promptness of any response to this. And I suppose my concern is what I'm hearing today is, oh, well, this is inevitable. What do you expect? This is going to happen. And I wonder, frankly, whether this is part of a pattern, because you would be aware of the New Street Services and the Safe Waste programs that are run through New South Wales Health, through the Child and Young People's Sexual Safety Unit, and they provide services for children and young people who have displayed problematic or harmful sexual behaviours. Well, Professor Dale Tolliday has said that they are so hopelessly under-resourced, and to quote him, that we cannot come close to meeting the demand. In fact, there isn't even a waiting list kept for children seeking to access these services or needing to access these services, often as a result of exposure to pornography. So is your government simply not concerned about our children being exposed to pornography? There aren't the resources for the support services afterwards, and it seems a very cavalier approach to, oh, well, they see what they see, it's part of being on the internet. Where is your concern for our children and what they're being exposed to?
I mean, of course we're concerned about that. As I said, I mean, this is a particular instance where a bot has been able to create unaccessible links on the Southeast Sydney LHD website, as the Secretary said. I mean, we run thousands, tens of thousands of websites. Okay, this issue occurred. It was identified and addressed, as you identified in your preliminary questions.
Sorry, with respect, Minister, the question really went to this, coupled with the fact that New Street Services and Safeways are under-resourced and cannot meet the demand to deal with children who need these services. This seems to be part of a pattern of not treating exposure to pornography and its harm seriously by your government.
I mean, as I said, I'm not that the administration of that service is the responsibility of Minister Park. So I'm not specifically familiar with the demand for it, but like many of our services, I'm sure that it is under pressure and, doing what we can to ensure that it's accessible to people. Is your suggestion seriously that accessibility of that service, there's a direct link between a bot that infiltrated the South East Sydney LHD website and for a short period of time generated inaccessible links? As soon as we identified that, we dealt with it. I mean,
no, the
Ms.
question
Carter,
is, Minister.
Honestly,
the question is, Minister.
Yes, our government takes young people's access to pornography seriously. Of course, we're concerned about that. That's why when you started this line of questioning, I indicated that we were supportive of things like the federal government's delaying access to social media, because that can be another place where young people are accessing inappropriate information. So, yes, we do, although
Minister, with respect, of course, is not an answer. Resources in programs is an answer. Prompt action in relation to this is an answer, and there are real questions as to how promptly that action was taken, but we can explore those later. And perhaps if I can turn to something else. In June this year, you said that if somebody walked into a Sydney hospital, you could guarantee that they would get the mental health help that they needed. Are you prepared to repeat that guarantee today?
yes.
And you acknowledged at that same time that people were waiting days for urgent psychiatric care in emergency departments. What's your definition of getting help within an acceptable timeframe?
Well, I mean, we do have guidelines that we follow in relation to what the acceptable timeframes of accessing care in an emergency department setting are. We do our best to ensure that those are met. Currently, I think it's around 70% of people who access an emergency department for mental health care are met within those timeframes. I mean, is 70% good enough? No, I've never in any of my comments sort of suggested that what we're doing is meeting the needs of everyone, but we'd like that to be 100%. But, we are doing decently in terms of giving people access to the timely care that they need. I mean, it's cold comfort for people who wait in emergency departments, and Minister Park and myself have always called out that challenge. But New South Wales is actually the best performing jurisdiction in the country in terms of wait times for accessing care in emergency departments. I only make that comment not to suggest that, for example, 70% is an acceptable threshold, but just to say this is a national challenge. Right across the country, there is pressure on emergency departments, and the issues that we face in New South Wales, and I'm not trying to shy away from them, but are actually indicative of the best performing system for ED wait times for accessing care in the country. But because we still do hear instances of people who wait beyond those acceptable timeframes, we're going to keep going with all of the work that we're doing to try and take pressure off our emergency departments. And I'm happy to talk about what that looks like in mental health, because that's an area that I'm particularly leading in. Examples of that are things like...
Can I just ask you a question? Sure. So the ED figures you were talking about, were you separating those out? Because we were talking about response to needing psychiatric support in the emergency department. Are you talking ED generally, or you have specific figures for psychiatric care response times in ED?
No, my understanding is that the figure, I think it may be, it is either 70% or just below 70%.
For psychiatric care?
Is for mental health presentations in emergency departments. Now, as I said, and I'm not defending 70% as the end of our work. 100% is the end of our work, but 70% is a decent effort in the context of the national pressure on emergency departments.
And the guarantee you made was with respect to Sydney hospitals. Can you make the same guarantee about timeliness and adequacy of care for people presenting outside of Sydney?
Well, I mean, of course, as we've discussed previously, not every regional hospital delivers the high level of specialist care that may be required in the context of a mental health crisis. And that's not just the case for mental health, as we know. not every regional hospital offers the full suite of specialist care. They don't all offer birthing and maternity. They don't all offer
Minister,
oncology.
thank you for the tutorial about the difference between regional and Sydney hospitals. I'm simply asking, can you guarantee that people who live outside of Sydney can get timely access to the mental health care that they need? It's a yes or no question.
Yes.
Thank you. There was no allocation for the pay rise in the most recent budget for the increase of 20% to staff specialist psychiatrists. How will that be funded?
New South Wales Health have made arrangements to fund that 12-month temporary boost from existing resources.
So are any programs going to be cut to fund it?
No.
Will positions be left unfilled to meet those salary costs?
No.
So there was just a hollow log sitting in health that could be tapped?
In the context of what is the health budget, $30 billion? $35 billion budget, a 12-month temporary contingency for that is able to be managed.
So if it's so easy to find that money, why did you fight so hard so that psychiatrists actually left their positions rather than meet their pay demands earlier?
Because there's a massive difference between finding a 12-month temporary contingency to cover a 12-month boost than baking in a 25% increase per FTE over the forward estimates and the planning years. And if that difference is not obvious to you, then I don't know how else to explain how budgeting works.
Psychiatrists hear that your government sees this as a 12-month one-off rather than as a permanent increase in salary going forward?
Well, the psychiatrists should hear that we've agreed to meet the findings of the Industrial Relations Commission. Now, obviously, the further finalisation of the Asimov Award is something that is as yet unresolved, and we will work...
So you're budgeting for a 20% one-year one-off and poof, it could disappear next year. Is that what I'm hearing?
No, I mean, you're hearing that we have made arrangements to fund the Industrial Relations Commission outcome and then to engage in the finalisation of the broader Asimov Award for staff specialists. But of course, we can't make budgetary decisions about what that might be yet because we don't know what it is yet. But just like in this instance, when we had that finalised by the Industrial Relations Commission, we were able to make that work. Once the Asimov Staff Specialist Award is finalised, we will revisit what that looks like and make that work too.
So is one of the hollow logs you found to tap the super profits that you're making from increased parking charges on the people of Western and Southwestern Sydney?
No.
So what are you happy that, for example, if you look at the increases, I mean, a whopping $20 million in parking revenue from the people of Western Sydney. How do you explain taking that money with what your own government was calling a sick tax before the election?
Well, because we've increased the number of car parking spots. So when you increase the number of car parking spots, you're going to increase the revenue that you get from car parking.
And so even though you condemned asking sick people and their visitors to pay for parking before the election, you're now happy to just say, oh, well, it's parking, you should be paying for it.
Well, I mean, of course, what you're referring to is the fact that under the previous government, user pays for hospital car parking was the case across every single public hospital in New South Wales, and we called for that to be suspended in the context of COVID, which occurred.
Yes.
So the comparisons that you are referring to are between a particular point in time when COVID occurred.
No, with respect, Minister, the comparisons and the uplift of $6 million in Western Sydney alone last year is not from pre-COVID to now, is not from COVID to now. It is from last year to this year.
That's because
$6 million increase from the people of Western Sydney just for parking.
That's because
how do you justify that?
Because we increased the number of car parking spots. So there's two fundamental questions here. Do we have a user pay system for hospital car parking? Is there a framework?
It's the frontline workers that are paying for it. It's nurses, aren't they? It's you're charging nurses for this. Hi.
I think that was a comment rather than a question, but regardless, before we come to crossbench time, it's been brought to my attention that we did miss swearing in one witness this morning. My apologies, there are a lot of you. The Secretariat's really done their best. The remaining witness to be sworn in is Jennifer Hayes from Hunter Water.
Thank you. Jennifer Hayes, Acting CEO from Hunter Water Corporation. I solemnly and sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth.
Thank you very much, Ms Hayes. We'll now turn to crossbench questioning, and I'll start with a few questions from myself. Good morning, Minister. Continuing on from the line of questioning around the psychiatrists, following on from the excellent IRC determination, what's happened? Are psychiatrists returning to staff specialist positions?
Yeah, they are. We've seen a net increase of 6 FTE in the last few months. So, you know, I'm obviously pleased to see that there has been some FTE increase. I mean, the overall numbers are relatively low, and so 6 may not sound much, but in the context of overall numbers being relatively low, I'm pleased to see that. So, you know, and that is not necessarily, that's 6 FTE. I'd have to check the number of individuals. I think that's more than 6 people that have come back into the system. So I guess what I'd say, Dr. Con, is I think it has been well received. I think you can see people coming back into the system, but it doesn't really avoid the fact that there are still ongoing challenges with the recruitment of staff specialists, not just in psychiatry, more broadly, and we do await the finalisation of the ASMOF award for those kind of more fundamental long-term solutions.
Thank you. Look, while it's positive that some people have come back, I'm sure you'd agree that 6 FTE is a very low number when we were talking about 2/3 of staff specialist psychiatrists being involved in either threatened or actual resignations. What's your understanding of the barriers to more of those psychiatrists coming back to permanent positions?
Well, just again, to be clear, my understanding is that since this sort of process, since the dispute commenced, the number of FTE separations that have been finalised is 56 FTE. So yes, I mean, I'm just trying to give you some context there. So 56 FTE separations finalised as a result of this dispute, and you know, that's a shame, and we don't want to lose anyone to our system. And you know, since this issue has been resolved, we've seen a 6 FTE net increase. So you know, I'm not trying to avoid the fact that there's still gaps there, but positively people have responded well. My understanding of some of the barriers are that in some circumstances people's roles have been filled by others, or that there are VMOs who are performing that work, and districts are making decisions at the district level about how to put together their workforce. But we have met with the College of Psychiatrists about some of those barriers that people who do want to return might be facing. As I said, it's very much at the district level. And we've done work through myself and Dr. Wright and Dr. Flynn to try and work with LHDs to encourage them to have people who wish to re-engage be able to do that in a straightforward and expedited way.
Thanks, Minister. I'm particularly interested in that last part in terms of what you're doing to support LHDs to bring people back. 6 FTE out of about 56, you know, that's nearly 90% of people not coming back. Could you speak in more detail to what you're doing to actually support LHDs to bring people back to those roles where they want to come back?
Sure. Well, I mean, working with them on best practice. I mean, I'm not responsible for individual employment at the LHD level, and nor should I be. In fact, quite inappropriate, I think, for the Minister to be case managing individual employment pathways. So whilst, you know, I am more than happy to provide clear leadership on our expectations, to talk about best practice, to work with LHDs to show them what other LHDs are doing and is working, and encourage them to follow similar models. other than that sort of leadership to demonstrate to them our expectations and what best practice looks like, I'm not going to get involved in individual employment decisions. And so I think that work that we have done is a good example of how we can be encouraging them to follow through on the opportunity that this presents.
I'll just come to a different topic that I'm sure you anticipated that I would ask about. Health-led response to mental health emergencies has seemingly been in the works for a year or even 2 years now. I note that there's been a community consultation process since our last budget estimates hearing. Where is that work up to within government?
Yeah, so the community consultation process is still ongoing. The time period for that was extended. I understand, Dr. Con, that may have potentially been based partially on your representations, but others as well, to make sure that that was adequate. So I appreciate, and we have talked before at both of the other budget estimates that I've done this year, about your interest in this area and your enthusiasm to see it progress quickly, and that's my interest too. But we do have to make sure that these new models are put together properly. So the progress that we have made since the last time we had this conversation is that community consultation process, bringing those stakeholders and concerned community members into this conversation. And that is occurring. And I don't have it on me, although perhaps Ms. Woods or someone else may have information about how many people have participated in that process. We are encouraging them to do that. That work is ongoing. Once that is finalised, obviously we will take all of the work that we did internally with government agencies and complement that with the feedback that we received from the community and from stakeholders, and look to finalise the model next year.
Thank you. The consultation is certainly welcome, and it's my understanding that that actually closes today. So what are the next steps for this work?
Do the work to analyse what that consultation brought to our attention, do the work to go through those survey responses. We had online surveys, but we also did one-on-one dialogue, roundtables, focus groups with key concerned individuals and stakeholders. So take all of that information, bring it together, see the key themes, the key messages that dialogue puts in front of us. And then, as I said, once we've done that, complement that with the work that we did internally from New South Wales government agencies, and finalise a package, finalise an approach. And that's work that we'll be doing next year.
Okay. What's your anticipated timeline for that work now, noting, I think you told us in September 2024 that there would be a new model going through Cabinet by the end of last year?
Well, what I intended to convey with those comments was that the decision to do this work was to go through Cabinet, the decision to engage in this dialogue. And that has happened. We wouldn't have done all of the work between the government agencies with the community consultation if there had not been a decision to engage in this process. So that is what I was referring to with those comments. And as I said, that has occurred. My anticipation is that we will need to, I don't want to give a specific time frame on when next year we will come out with a finalised model, partly because that's not a decision that I'll be making on my own. There is obvious and significant interest from police and from ambulance, who are more directly the responsibility of Minister Park. There are budgetary implications that will have to be worked through as part of the budget next year. So those things, will take some time in 2026. But it is my expectation that myself, Minister Catley, Minister Park will work together on that next year, engage in the budgetary process to support this reform work, and that we will have that finalised in 2026.
Thank you. I understand there's been significant work underway in the transition of the mental health line, and certainly in areas where that was previously privatised or outsourced, you have my enthusiastic support to bring that in-house. What are you doing to make sure that that transition doesn't result in additional inefficiency or duplication? So, for example, people having to tell their whole story to a mental health line worker and then having to be re-triaged or reassessed by the local team they're then referred to.
Yeah, who is the best person to talk? The work that you are referring to, the single mental health front door, was a budgetary commitment and is something that I agree with you has a lot of potential. Who's best placed? Brendan, are you able to give an update on that work and specifically answer Dr. Con's question around ensuring that it's an efficient trauma-informed system?
Thanks, Minister. Thanks, Matthew. Morning, Dr. Cohen and committee. The whole point of the new single front door, and it's got a working title of Connect MH, is to achieve just what you outlined, which is to minimise the number of times that people would have to, or a carer would have to tell their entire story as part of a triage. But it does go to the really important question around what are we doing around the clinical service, and so that's some work that is underway with Health Direct as our delivery partner, but specifically the triage policy for New South Wales Health is being revised, and clinicians who utilise it will need to make sure that they're adherent to the new triage policy as a part of that. So there is significant work to do, but it's progressing well.
Thank you. I'll come back to this later today. In the meantime, I'll go to my colleague, Ms. Fairman.
Thank you, Chair. Good morning, Minister, and everybody. Minister, I just want to turn first of all to the PFAS issues in the Blue Mountains, and I'll go straight to the Cascade water filtration plant there. So how much of the water for Blue Mountains residents does the Cascade filtration plant filter currently for
Darren,
PFAS?
Do you have a percentage of how much the Cascades water treatment plant is providing, how much water it's providing for the Blue Mountains catchment area?
So regarding the filtration, so we do have our plant that is coming to remove PFAS. And I'll have to get the percentage of exactly how much that treats of the overall supply that's provided to the customers. Yeah. But I can say that the water that is provided to customers does meet the current Australian drinking water guidelines.
Yeah. So thank you, Mr. Cleary. So to be clear, when you're talking about the mobile treatment plant that was brought in?
That is correct. Yes.
Okay. And does it vary according to any given day and what water supply is brought in, or can you get me an exact percentage overall? Does it vary?
I'll take that on notice and provide the information.
Because I do understand. So just to at least get this on the record today. So it's not all of the water that's being filtered for PFAS.
That's my understanding, that we do provide a treatment to ensure that the water that is provided to customers meets the Australian drinking water guidelines.
So, Minister, can I also just get an update then? Around this time last year, there was an ABC media story in relation to I think it was $80 to $100 million being spent on a water treatment plant for the Blue Mountains at, I think, the Cascades filtration plant, expected to come online in 2026-27. What's the update on that? How much has been spent on that this financial year, and is it on track?
Darren, do you have an update on the broader redevelopment of the Cascades?
So we are certainly delivering that ongoing upgrade. It is on track. I'll have to take on notice the amount, exactly the amount that is spent this financial year today.
When you're saying, so the ongoing upgrade, the report was that it was going to be, I think, a new water treatment plant.
Yeah, the entire water treatment plant at the Cascades facility is being rebuilt. So we have bolted on a mobile treatment unit as a temporary solution, but all of our public commentary has acknowledged that that is a temporary solution, and we have a broader, much more expensive plan to upgrade the entire water treatment facility there. And as Darren has indicated, we don't have an exact figure of how much was spent this financial year on that, but that work is occurring, it is ongoing, and it is on track.
Thank you, Mr. Cleary. If you could perhaps ask whoever is in the back rooms sending you information for this budget estimates to perhaps get that figure, because I assume that's quite easy to to obtain today.
Yes, we'll provide that for you
Thank
today.
you.
Yes.
Who's responsible for remediating Medlow Dam and Greaves Creek Dam?
Is that
Water New South
you,
Wales, I
Mr.
assume,
George, or is that the EPA, or?
So it's an open question as to whether or not the dams themselves will be remediated. The detailed site investigation is now underway, as recommended by the EPA. That investigation will provide recommendations to government as to what the options are for remediating or isolating the PFAS.
Yeah.
That investigation you just referred to, Mr. George, sorry, who's undertaking
The
that?
EPA.
What's the time frame for that?
That has just commenced. It's about 12 months. We are coordinating that on behalf of the New South Wales Government, working closely with a number of agencies, including the EPA, New South Wales Health, the Cabinet Office, RFS, multiple other agencies.
So an investigation led by the EPA into...
Sorry, apologies. You're coordinating that, are you, Andrew?
We're coordinating that on behalf of the agencies.
So the primary objective of that investigation is to assess whether the dams can be remediated or to assess where the contamination is coming from?
The source of the contamination, so recognising the earlier findings that the source was on the highway from those tanker accidents, finding those drainage paths, noting those drainage paths do cross land and properties that are not owned by Water New South Wales. They're outside of the catchment, including private land. That's why it needs a multi-agency response and a coordinated approach to exploring the remediation options that might be available.
Is there a reason why that's taken so long?
So long, sorry?
You're saying that's just commenced, that investigation?
The next stage of investigation. That's right. So that was a recommendation that came out of the initial work that was undertaken last year and earlier this year. We adopted those recommendations and that's been coordinated. We undertook a tender to find the experts to assist the agencies in undertaking that work.
Who won that tender?
I'll take that on notice exactly who's won that.
So, just to be clear, so this is going to take another year, is that correct?
That's the expectation at this stage.
So another year to make recommendations to the government or to Water New South Wales around whether or not Medlow Dam and Greaves Creek Dam can be remediated and what the source is. Can I just check, because I thought the Jacobs report was actually undertaking the work to identify the source. What did the Jacobs report do if it wasn't that?
So it identified the likely drainage path being Adams Creek that led into the catchment area. We also traced it back to the location of the accidents on the highway that caused the initial PFAS to enter the catchment area. This detailed investigation will go further into actually identifying beyond the catchment area where those drainage paths are, looking into the soil samples, looking into the groundwater, better understanding the concentration of PFAS in the sediments at the bottom of the dams, and what, if any, whether there should be remediation. For example, with the sediment at the bottom of the dams, it might be better to leave it inert, not to try and touch it, because it's that the sediment is not contributing to the PFAS in the water. But we need to better understand the contribution of surface water and groundwater to what's causing the elevated levels of PFAS in the dams.
Minister, do you know, does it concern you that this was, I've got the Jacobs report here, that it was presented to, the date here to Water New South Wales PFAS Advisory, 31st of January 2025. We're here on the 2nd of December 2025, and we're just hearing about another investigation into the sources of that. Shouldn't Water New South Wales' staff, other agencies have been out on the ground from the day that report was released, if they needed to verify that report, to do the work then?
I mean, they have been doing work. So, I mean, I think, as Mr. George has indicated, and based on what Mr. Cleary has said as well, we've managed to isolate that contamination site so that there is no longer any water that is being provided to the Blue Mountains that is outside the Australian Drinking Water Guidelines. And so in those circumstances, the detailed work that Mr. George has outlined does take time. I mean, this is a large area. It crosses over, as he has indicated, public land, private land, multiple New South Wales government agencies. I mean, yes, we want to do that detailed examination, but rightfully we also don't want to rush that. In circumstances where the contamination is now isolated, there is no water that is outside Australian Drinking Water Guidelines, I'd rather we got that process right than rushed it and made decisions that were not informed by the evidence on the ground. And just to be clear, it's not as though that work has not been occurring. There has been work that is occurring. I mean, it's just that it has been informed by that preliminary investigation. It's been finalising what the scope of other research and investigations needs to be. But
so can I just ask specifically then? So in response to the Jacobs report that identified particular areas, potential source of contamination, there's a map here. There's different points of potential contamination, including the 2 known vehicle accidents, Medlow Bath, RFS, and the secondary source contaminated sediment. Since this was released, what work has Water New South Wales done in relation to the findings of this report in particular?
Well, I mean, they have been examining the implications of those findings, working with other New South Wales government agencies to explore what is a meaningful next step.
Goodness.
Do they need to do immediate remediation work? Are they able to isolate those water sources so that the drinking water in the Blue Mountains is within the Australian Drinking Water Guidelines? I mean, I make no apologies about the fact that the primary focus of our work has been to ensure that the drinking water that has been provided to Blue Mountains residents is within the Australian Drinking Water Guidelines, and it is. But that does mean that some of that more detailed down the line examination work on soil composition and those matters has not been our immediate priority, because our immediate priority was what do we need to do right now to fix the issues in relation to drinking water, and then that's what's been occurring.
Thanks.
I'll go back to the opposition.
Okay. Just a quick follow-up about parking, if I may, Minister. You indicated that there'd been an increase in parking places. My understanding is Nepean Hospital's multi-storey car park opened in 2019. Blacktown Hospital's car park opened in 2018. How many more car parking spaces have come online in the Western Sydney Health District this year?
Ms Pearce, do you have that information?
Look, perhaps I'd be very happy to take that on notice, and perhaps we could have a list of how many car parking spaces have come online this year in each of the health districts where parking is charged, and in each of the health districts where parking is not charged for people visiting hospitals. Sure. If we could get those today, by this afternoon, that would be very helpful. Thank you.
Thanks. Could I just follow on from that just briefly, just to get an idea? Is it the case, Minister, that you're asserting it's an increase in the number of parking spaces that are available that has resulted in the increase in the revenue, not an increase in the price that's charged, or is it an increase in the, turnover and use, that there's more use?
Well, I mean, my understanding is that the cost per use has increased by CPI only. So no, there has not been a significant increase in the cost per use. A standard CPI increase is the only increase that has occurred there. I don't know whether or not there has been a change in the number of instances of use, as you have referred to again. We could see whether that is something that we tracked, whether we have information on that. But fundamentally, it is my assertion that, yes, a decision was made to not charge hospital staff for car parking during COVID. It is now the case that in the Sydney metropolitan area, there is a user charge for car parking, although heavily subsidised for health worker staff and registered carers. But yes, there is a user pays charge.
Yeah.
That is not the case for rural and regional hospitals, as I'm sure you know, Mr. Fang.
Very well aware.
And again, very proud that my government revised the hospital car parking policy to exclude rural and regional hospitals, but that the increases in the overall figure that Ms. Carter referred to is a result of an increase in the overall number of car parking spaces available. But we've taken on notice trying to provide that detail.
Because I would assert that it's more likely that the increase in the revenue that you've generated is from frontline workers, and you're removing the free parking that was provided to nurses under our side of politics when we were in government, that you've now removed. So you're effectively, making revenue off frontline workers.
Well, your
Would that be a fair assertion?
Your assertion is wrong.
Okay. So how much are you making from staff parking?
I don't know if we have a breakdown of the revenue that is generated from staff vis-a-vis other users. Is that something that either we have or could take on notice?
We can take that on notice.
Okay, so
but just to be clear,
yep.
Staff are heavily subsidised
Understand
when
that.
they access car parking.
I noted that from your earlier answer, but in the circumstances where we have seen massive increases in the revenue that's generated in parking, it's got to come from somewhere, and it's either from additional parking spaces, an increase in the fees, or an increase in the charges and the usage. So in those circumstances, we know you've removed free parking for frontline workers such as nurses. That is most likely going to be where you're generating that revenue. Is that correct?
Well, as I said, that decision to pause user charges, car parking fees for staff was during COVID only. So it is not the case, as seems to perhaps be the basis of your assertion, that there was a long-running policy from, say, 2011 onwards that health workers did not pay. That's not the case, Mr. Fang. During COVID,
Minister,
specifically, the staff were provided with a pause on car parking fees.
I'm aware
we have
of this,
now
Minister.
reverted to a heavily subsidised model. The increase that you have been referring to is primarily as a result of a larger number of car parks being available. But as I said, I am acknowledging the fact that during COVID, health workers did not have to pay for car parking. We are now post-COVID, and they are once again, except I should say, in rural and regional hospitals, where we specifically
you've already
revised
said
the
that,
policy
Minister.
to
Look,
exclude them.
I want to move on from that. I want to now
Well, of course
touch
you
on.
do.
Right. Minister, what is the total cost to the budget for the IRC, to implement the IRC changes for psychiatrists?
So the cost, including the 3% wage increase, which was obviously part of the government's government wages framework, the 10% onerous duties allowance that we had prior to the IRC dispute already agreed to pay and were paying, and the 10% recruitment and retention allowance for the 25-26 budget period is $22.6 million.
$22.6 million. Now, can you recall the figure you gave in an answer around what the projected cost was in the forward estimates had you provided the psychiatrists with what they asked for in relation to their pay rise?
I could look up what those figures
Well, I'm
were.
asking you the figure that you provided to in answers previously.
Well, as I said, I'm happy to, I don't recall everything I've ever said on the record, but I'm happy to look up what the information that I was provided as to what those cost estimates were.
We might do that a little bit later, but I just want to and I'm running out of time, so I just want to move on if that's okay. So we're looking at $22.6 million, and you said that since that time you've had 6 FTEs rejoin as staff specialists within the psychiatry cohort. Is that correct?
That's since June 2025.
Since June 2025. Are you able to tell me how many of those 6 FTEs were previously employed as staff specialists, or are they new psychiatrists which have either, say, entered Australia if they're overseas trained, or are they just newly graduated?
I don't have that, but I'm happy to take that on notice and see if we have that information.
Okay. In terms of the, I'll say there was 56 separations. That's the answer you gave my colleague
FTE, yes.
earlier. Even if we're to assume that those 6 that have joined since June 2025 have been returning staff, there's still 50 of those psychiatrists that are not within the staff specialist system. How many of those have become VMOs? How many are on locums and providing services back to the hospital?
Look, I might have to take that on notice. I do know that there is a corresponding increase in VMO hours equivalent to 114 FTE. So, as I've indicated, whilst we would love people to work as staff specialists in our system and want to facilitate that outcome, it's not the case that care is not being provided. Care is being provided by psychiatrists using VMO models.
That's not
I don't have in front of me the exact breakdown of what pathways those those individuals have chosen to use, and I'm happy to take on notice
not
if we
the
are able to
assertion I was
provide that.
making. I'm purely looking at the numbers and breaking it down. So in circumstances where perhaps the 56 psychiatrists have separated and may be still providing services, albeit as a VMO or on locum services, how much increase to the, how much are we spending for VMOs and locums compared to say the 23-24 and the 24-25 financial years?
I'm happy to take that on notice and try and provide that breakdown for you. I would note this, there is an increase in VMO and locum costs. I don't have those exact dollar figures. I'm happy to try and get that for you. But the point you are making is valid. I would say this though, Mr. Fang, that increase is not merely as a result of the dispute that we've had with psychiatrists over the last 12 months. This is a trend that has been going on for some time within New South Wales Health. I mean, my understanding is since 2019, 2020, yes, and up to and including 2025, 26, that there are steady increases in the costs of locums and VMOs year on year on year.
Yeah, Minister, I appreciate that. Can you now admit that you should have just paid the psychiatrists what they were asking for initially? It would have been cheaper, it would have been a lot less stress, and we would have had a lot better service. But you dug your heels in, and now it's going to cost us more in the long run to try and implement what has been effectively a second-rate service, and you've alienated pretty much half the workforce.
Well, allow me to assure you that whilst I really value our psychiatrists, there are around 400 FTE psychiatrists in our system, albeit a number of those positions are unfilled. I think there are around 18,000 people who provide mental health care in the system. So half the workforce is not entirely accurate. And no, I don't admit that, Mr. Fang, because, well, first of all, I don't even know what your government's policy is, considering your position was a 2.5% wages cap.
We're not in government. You are in government, Minister. This is on you.
We are trying to negotiate with our valued nurses, with our valued peer workers, with our valued allied health professionals, with a range of our valued frontline health workers and other public service workers. We need to have a meaningful framework that we can use to engage across all of those valued disciplines. Our nurses are just as valuable. Our peer workers are just as valuable.
That's not what I was asking, Minister.
And so to say to them, let me finish. To say to them,
you're now transversing into areas that I didn't even ask about.
Point of order, Chair. Point of order. The member makes various political points laced in with the question, which is fine, and the Minister addresses those points, and she's got a right to do that without interruption. If the member wants to stick purely to questions and answers, that's fine, but he's not doing that.
To the point of order, there's a requirement for procedural fairness on both sides. The Minister needs to be given a reasonable opportunity to answer the question, and the Minister is also required to answer the question that's being asked.
I appreciate that. She was traversing into nurses that I wasn't asking about. I was asking about psychiatrists. So
I've given that reminder on both sides, so constant interruptions that don't allow the Minister to answer the question are out of order, and the Minister is also required to answer the question that's been asked in a reasonable amount of time.
Well, the question was, do I admit that it was a mistake not to agree to a 25% wage increase with no negotiation that was a demand of our psychiatric staff specialists? And my answer to that is no, but the context for that answer, Chair, is that rightfully, our nurses and our peer workers and our allied health professionals also have aspirations for fair pay and not just praise. And the government is trying to engage with that in a meaningful way that respects their claims and works through them. And that doesn't look like giving a 25% pay increase to a small group of relatively highly paid compared to some of the other health workers that I just mentioned, workers with no negotiation and no dialogue.
So, Minister,
and that's why
I want to draw you back to the figure you gave me, which you said the 3% wage increase plus the 10% onerous plus the 10% increase that the IRC granted. You said that for this financial year, that cost is $22.6 million. Now, the figure you gave previously in answer in the media and also to the Parliament was $700 million in the forward estimates. Now, if I was to roughly multiply $22.6 million over 1 year by 4, I don't even get to $100 million. Now, add double that and say we're at $200 million. Where did $700 million come from when, at best, a 23% increase that's been granted costs $22.6 million.
So that figure was over the forward estimates and planning years, and that included the full cost of the...
How many years is in the planning years?
I understand that's 6 years. So
even then, Minister, how do we get to $700 million?
Well, I'm trying to explain that. The figure that the way that we calculate the cost of that claim is not on the existing workforce, it's on the full FTE, because we have to assume that the full FTE would be paid at that level. So that cost of $22.6 million, that is the cost right now to people that we have working as staff specialists in the New South Wales health system. Admitting, as I have repeatedly, that we have a high number of vacancies. I'm not trying to hide that. There are a large number of unfilled positions. We're working through trying to fill them. But we don't assume that the costs of wage claims will only be at a point in time. We assume that the full FTE will be beneficiaries of that increase. So we have a much larger number of FTE that we are applying that across. Of course, we also apply it to on costs and superannuation and leave and all of those matters. And yes, it was applied over a longer period of time. Now, I'm happy to provide and in fact table the information, I don't have it on me, that was provided to me by New South Wales Health that outlined those figures. I'm not trying to hide it. It is information that I was advised by New South Wales Health, and I'm happy to provide it to the committee.
Perhaps by the end of the session today, that would be much appreciated.
I think, if Ms. Fang, if that's okay, we'll provide it on notice.
Okay.
We'd like to give it, but I can confirm that the Minister was provided that information by New South Wales Health, and it does take into account the range of factors the Minister's outlined, but we'll certainly provide you more detail on notice. Thank you.
Were you, Minister, when you were providing that figure, were you clear to make, making it clear that it was over 10 years, not 4?
Well, I'm happy to make that clear.
Okay. Ms. Black, by my calculations, and I know that you were sworn in today, is this the first budget estimates that you've appeared at?
It is, yes.
Okay. When were you appointed?
In September 2024.
Okay. Just doing a quick count back, you've missed at least 3 budget estimate sessions in your time as the Mental Health Commissioner. Would that be reasonable?
I think it is two, Mr. Fang.
Plus, there was a supplementary hearing, much like we're having now, for last year, health and mental health.
I don't recall that.
Okay.
I recall there have been two hearings this year.
Mhm.
One of those hearings was rescheduled because of ex-tropical cyclone Alfred, and I suppose I thank the committee for that. Although my recollection, Ms. Black, is that you were able to attend the initial hearing as scheduled, but that when the date changed, it conflicted with pre-arranged annual leave.
Yes, that's correct.
Okay.
Yeah.
It's unusual for somebody in a senior position as yours to miss that many budget estimates. I'm curious, how much work did you have, and how involved were you in relation to the psychiatrist issue that the government's been facing recently?
I think that's a matter for the government. We weren't involved in that decision making or any of those negotiations.
Okay, so you were effectively hands off. You didn't have involvement?
No, I guess our role is to really look at setting strategies and plans for improvement in systemic issues relating to mental health and suicide prevention.
Yep.
And so we look to work constructively where we can to do that.
It would be a fair assumption, would it not, to say that in circumstances where the government was potentially and subsequently did lose quite a number of their psychiatry staff specialist workforce, that potentially would have an impact on the mental health services in New South Wales? That would be a fair thing to say?
But that's not really for me to comment on.
Why would you say that? Why is it not for you to comment on?
Because our role is to set the strategy for mental health and wellbeing and suicide prevention.
Yeah.
And since my time in office, I have been involved in a consultation with the community around that. And whilst we've heard some feedback about the impacts of that, we're working with the government to think through what that means for the strategy going forward.
You would accept that at the time and even now that there was clearly a high amount of media coverage and exposure about the fact that the government was potentially losing quite a number of psychiatrists. You don't think that, as the Mental Health Commissioner, you had a role in working with the government to try and resolve that matter, to ensure that the provision of mental health services and suicide prevention was adequate in New South Wales?
Like I said, my role is in working on plans and strategies and working with the government. The issue of the pay dispute was not something that I was involved in to do that.
Minister, I asked you a couple of years ago now about the sexual safety policy for New South Wales mental health facilities. That was particularly in the context of a really distressing ABC investigation that shone a light on people's experiences of sexual assault as inpatients in mental health units. At that time, you advised that the policy directive, which is very out of date, or it's back from 2013, was being reviewed, and I understand that was due for publication last month. What work's been done to update that policy?
Yeah, I might ask Dr. Wright to comment. That's been slightly delayed, that work. It is ongoing. You are correct that you asked about it and that I indicated that it would be reviewed, and that work has been ongoing. We are just wanting to make sure that all of the different perspectives, the voices of clinicians, lived experience, and other stakeholders are included comprehensively in that. But Dr. Wright, did you just want to provide a little bit of an update as to where that's up to and why there has been a slight delay in finalising that updated policy?
Yes, certainly. Look, we have talked about this before, and I think that we all agree that it's an important update of the existing policy, and there are a number of kind of stakeholders that have been really important to participate in the development of the guidelines and also the consultation. As I understand it, the revised timeline is to finalise it. It was due in November this year, and to revise it to March 2026. And the reasons for that extension is as the Minister suggested, to really enable very broad and meaningful consultation. The proper consultation takes more time than you anticipate when you put it on paper, and you've also got to respond to the issues that are raised in the process of that consultation, and to then respond in terms of the policy. There's also the issue of engaging and resourcing within the ACI and within our PARVAN services, and they're both very significant contributors to the process. So my expectation is that it will be delivered in March next year.
Thank you for that update. Are you able to let me know who are the people that have been involved in that consultation?
I'd have to take that on notice.
Thank you. Minister, I've got a few questions for you about Albury-Wodonga. I wrote to you about a year ago about the issue with the lack of eating disorder coordinator for people who live in Albury-Wodonga as a result of our unique cross-border circumstances, and you very kindly wrote back about a year ago to say that you were actively working with Albury-Wodonga Health, including consideration of a co-funded eating disorder coordinator position. Has that work progressed at all?
Yes, I did do that, and I recall having a dialogue with perhaps Dr. Flynn about that, although I have not very recently asked him for an update. Are you able to provide that?
Thanks, Minister. We certainly have been involved in correspondence with Albury-Wodonga Health. My understanding, and I can come back and check this later today, is that the funding arrangements have been put in place. What I don't know is whether Albury-Wodonga Health have recruited to that position, but I should be able to get that advice today.
Okay, thank you. Thanks. I'll come back to this today, Dr. Flynn. While we're on Albury-Wodonga, Minister, I've previously asked you about the design of the Nolan House inpatient unit that's part of the Albury Hospital redevelopment, and I've had a look at the most recent design for that unit, which is now on level 8 of the new building. Some of the stated goals of the design are connecting with broader views and connection to nature as part of healing. The two large courtyards, one for intensive care and one for general care, are actually fully internal courtyards with no connection to views, and the two external courtyards appear to be entirely concrete with an ornamental tree. Does that meet your expectations for best practice design, or I suppose even for its own stated aims of connecting with nature and connecting with views?
Look, I haven't seen those updated designs, Dr. Connor, and you know, look, to be perfectly honest, you know, we're spending, the New South Wales government alone is spending $700 million on updating mental health infrastructure. That doesn't even include the Albury-Wodonga Health project. I don't want to pretend to you that I go over the design specifications of each of those facilities. However, it is the case that I was advised that one of the reasons that the new facility at Nolan House was not on the ground floor, was in fact, you know, as you say, elevated, was so that there could be courtyards and open space that were not viewable from above. And so if that is not what the final designs have delivered, they have delivered open spaces that are fully enclosed. I'm not sure how that is even possible. I will have to take on notice looking at that. But my expectation when I was advised as to why these decisions were made is that there would be outdoor space, open space that was available. It would not be able to be viewed or looked down upon by others. And so if that is not what has been delivered, then no, that doesn't meet my expectations.
Thank you, Minister. I appreciate your attention to that on notice. I've also previously asked you about the membership of the lived experience working group, and since our last conversation I have been made aware of at least one individual who was explicitly rejected from taking part in that group because of their stated comments that they don't agree with the approach of the redevelopment. What action have you taken in response to this limitation on the working group?
Yeah, I mean, you're correct that you have raised it before, and I've indicated that that does not seem consistent with my understanding of best practice of lived experience engagement. I did write to Albury-Wodonga Health, but on your behalf, but also on my own behalf, to raise those concerns that I didn't want to see, in particular New South Wales residents who would be using these health services, who had lived experience and a perspective to bring excluded, simply because they had a different view about some of the decisions that were being made. So I did write to the management of Albury-Wodonga Health. They wrote back, sort of acknowledging my correspondence, not particularly responsive to the concerns that I'd raised. I continue to be of the view that, as you know, New South Wales Health is not running or responsible for those groups. It's not as though I'm in a position to say, as the Minister for Mental Health, my expectation is that individuals are included, or that it's run along these terms, or that these are the policies that are implemented, and then there be an agency response, as there would be in other areas of the state. And I readily accept that from your point of view and the point of view of the Albury community, that that's a problem, that that's a concern. So in light of that, we have had some dialogue around some of the limitations that the governance model provides in Albury-Wodonga. The finalisation of that more broad conversation is a little bit above my pay grade, merely to the extent that, Minister Park has to be intimately involved in that. It's not just a mental health issue, but he is aware of it too. And so we've put our concerns in writing. We've now sort of commenced a little bit of a process of dialogue about how we might overcome some of these governance challenges where we're just not seeing the kind of responsiveness and accountability for decisions made impacting New South Wales residents that we might expect and see in other districts.
Thank you, Minister. I appreciate your really genuine consideration of this, and I'm very confident that Minister Park's also aware of my concerns around Albury Hospital. Just can I specifically clarify my understanding regarding that lived experience engagement piece, that the response from Albury-Wodonga Health didn't indicate any change to their current approach in response to the concerns that you'd raised?
Yes, that is accurate. That is their response. They acknowledged my correspondence, but no, I'm not going to pretend to you that there was any agreement to revise their approach.
Thank you. I know that you have a very strong commitment to consultation and engagement in your role as Minister for Mental Health. There's a long-standing community concern in Albury-Wodonga about the way that Albury-Wodonga Health has engaged, and New South Wales Health Infrastructure as well, about the redevelopment process, which resulted in a whole chapter of the Special Commission of Inquiry report about Albury-Wodonga Health's criticising, amongst other things, the consultation piece. The board chair and CEO have issued an invitation-only, they have an invitation-only event that, and I'm quoting from their invitation, it offers a unique opportunity for local industry leaders to gain first-hand insights into the redevelopment project. They've called this the boardroom briefing, while at the same time refusing to meet with various representative groups of staff and the broader community. Does that meet your expectations for engagement?
Well, the existence of a boardroom briefing, for a targeted number of local industry leaders, I think is, potentially a meaningful way to bring those people into the conversation. It's the contrast point that you have identified, I have to say I'm not clear on, where others who may want to be part of a dialogue are excluded, that raises concerns for me. So, not all consultation is going to be open forum, all in, come one, come all, sort of town hall type dialogue. You are going to have smaller groups with particular individuals, who want to talk about particular elements of a project, and I'm fine with that. But I do think that everyone who wants to be part of that conversation should have their opportunity for input. So if it is indeed the case, and look, I just don't know Dr. Con, but I I take your word for it in a way, because I know how embedded you are in that community, that there are people who want to have a say and want to be engaged, and they just don't have a forum for that. Well, that's not particularly acceptable to me. And I do think that everyone should have their moment and their opportunity to have their say.
Thank you. I'm out of time. I'll go to Ms. Fairman.
Thanks, Chair. Minister, I just wanted to turn to environmental water, if we can. In a fact sheet released by DQ on in August 2025, a couple of fact sheets were released in relation to environmental water deliveries, and in one of them it talks about the fact that as of August 2025, 56 sites where environmental water would normally be delivered don't yet meet metering requirements. It goes on to say that the department has a metering implementation plan. Just wondering whether that plan is going to be released.
I don't have any objection to the plan being released, Amanda. Is it currently your intention to publicly release that work?
I'll take that on notice. We can come back to that today. I'm not aware if it's released at the moment, but
I don't think it's been released. That's the point. The question is, will it be released?
Can you check, Amanda, whether it is the intention to publicly release it?
Yeah, we'll do that.
And as I said, I don't have any objection to that occurring.
Okay. So it also mentions the fact that out of those 56 sites, there are works were starting early September to install meters at 11 sites in the Millua and Werrai forests. How's that going?
I don't know, although that may be work that the environmental water holder is doing, and as you probably know, Ms. Fairman, that is the New South Wales environmental water holder sits within Minister Sharp's portfolio. So again, we can take on notice to ask our colleagues in the CPHR division of DQ how that work is progressing, but that is work that they are undertaking.
Okay, so the flows, the delivery they're undertaking, the installation of the meters, is that their work as well?
Yes, it is, yeah.
Okay. Ms. George, I just wanted to go back to something that you promised during, I think, the last estimate, which was around the legal advice in relation to the, when we talked about, I think it was the legal advice from the Crown Solicitor regarding the objects of the Water Management Act. I think you said that would be released. I'm not sure whether that has, or in fact, it was something like a plain English version would be released. Have we seen that?
Well, I think if I can just clarify, my recollection is that it was information in relation to the legal advice that led to the pause on environmental watering. Is that the legal advice that you are referring to?
That's right.
Yes. Well, I mean, as you know, in general, we don't seek to just permanently and categorically waive our legal privilege by releasing publicly all of our legal advice. That puts us in a pretty difficult position. So we did, I understand, provide some, as you say, plain English or try to provide a version of what occurred and the advice that we received as a sort of fact sheet or an update. My understanding is that was provided. Is that right, Ms. Jones?
That's correct. I think it's the fact sheet you're referring to was the explanation of the circumstance.
Okay, so I think my question, last estimates, was in relation to the objects of the Water Management Act. I'm not sure whether the fact sheets that I have before me really talk about the objects of the Water Management Act and clarify.
Apologies, Ms. Fairman. We may be, because we're referring back to previous estimates, I can't recall. We did talk about the legal advice that we received that led to a pause on environmental watering. We also potentially talked about legal advice more broadly in relation to the interpretation of the objects of the Water Management Act.
Which I think was
is that
the same. That was
yes,
the same.
Right. Okay. Well,
that is the same advice.
No, there's two separate pieces of
Okay.
advice. So there was some specific legal advice that was provided in relation to the quite technical interpretation of taking water from one water source to another that led to the pause on environmental watering by the Commonwealth Environmental Water Holder. That particular decision that was made based on particular legal advice. There is also in existence broader legal advice that speaks to the way that the department interprets the Water Management Act and provides advice to me in the creation of water sharing plans and other instruments. There's two separate pieces of legal advice,
so I'll just
neither
clarify.
of which
Let me clarify.
Neither of which we're really particularly willing to just release publicly whole as bolus.
Sure.
As I said, they're covered by legal professional privilege.
Sure, that's fine. I've got a question about that. So the last time it was basically asking the NRC in relation to did they get legal advice regarding the water management principles. I was told by the chief scientist and engineer that advice was initially given to the water department. They subsequently shared it. I asked whether that advice had been made public. Chief scientist said no. It was referred to you, Ms. Jones, and you said what we've done is actually ask the Crown Solicitor to draft a guidance so that could be made public. So my question is, I understand the fact sheet, that's being done, but my question is, can you confirm that advice by the Crown Solicitor, did it clarify the objects of the Water Management Act for you?
It did.
Okay,
yeah.
Minister. So can you confirm, did it clarify that the objects of the Water Management Act give primacy to the protection of the water source and its dependent ecosystems?
Yes, that's clearly stated in the Water Management Act.
So that's what the Crown Solicitor's legal advice confirmed, not the other way around?
Yes.
Okay.
Did you want to add anything, Ms. Jones?
It does confirm that. It also confirms that there are also other considerations to take into account.
Which are also clearly listed in the Act.
Yeah. So in sections
Other
9
considerations
and
taken
5.
into account, but just to be clear, because that's the whole point of the legal advice, that the legal advice said the primacy must be given to protection of...
There is a need to consider a range of principles, including that protection of water sources and the environment. And the guidance that you referred to, Ms. Verman, that we were seeking from the Crown Sol so that we could publish, we've just received. So we will be looking to publish that guidance shortly.
The guidance being the legal advice?
Well, guidance on elements of the legal advice that we're able to publicly release.
Use the legal advice.
So I just got some conflicting responses there, just to be clear. I asked the Minister whether the legal advice confirmed from the Crown Solicitor confirmed that the objects of the Water Management Act 2000 give primacy to the protection of the water source and its dependent ecosystems. I do think that was an emphatic yes.
And
Ms. Jones, you
the
then
minister's
jumped in,
correct,
just to be clear, and added additional principles. So in your view, are you saying that it doesn't give primacy?
It does when you're looking at water sharing, and then there's also other principles that you need to address, other objectives that you need to address in addition. So it's not, I'm not countering what the Minister says, it's just that the entire consideration is that.
You do know what the word primacy means, though. In terms of objects, primacy, one, is the most important. Is that right?
It's the most important in looking at water sharing. And then there are other principles and objectives that you need to take into account as well.
Of course.
So the advice from Crown Sols does look to that balance.
Thank you. When will the government response to the NRC's review of the GWIDA regulated water sharing plan be published? Is that published yet?
I'm not sure, Amanda. Has that been
The-
published? GWIDA regulated.
Those recommendations, I understand, have this corrected if it's not the case, is that they are being considered at the moment and will be ready probably in the next few months, but I'll confirm the timing.
Okay, so it's currently before you, considering the recommendations?
That's what I understand.
Okay. In just going back to legal advice in the last couple of seconds I have you considered or received advice on the possibility of, in terms of the lapsed plans, possibility of a legal challenge on those lapsed plans when they're remade?
No, I haven't received any advice on that.
No.
You're seeking legal advice about it? No.
Well, I mean, our focus is finalising those plans.
Thank you.
Are there any questions from the government?
No questions, Chair.
Reserve our position.
Thank you. There being no questions from the government, we'll now break for morning tea and we'll recommence at 11:15. Thanks, everyone. Thank you. Thanks,
Sorry.
Minister, if you'd like to go ahead with
Yeah,
that
I just
additional
wanted to
information.
provide some additional information that went to a question that I think Mr. Fang was asking. So, of the 56.9 FTE psychiatrists who had their resignations finalised, the head count was 106. Of those, 42 have returned. The 6 FTE increase was only referencing the start of this financial year to October 2025. Of the 42 who have returned, 10 have returned as staff specialists in their former district, 7 have returned as staff specialists in a different district, and 25 has returned as VMOs in their former district. Just to provide that clarification.
Okay. So, sorry, just so I can make sure I've got the figures right. The 56.9 that's separated, those were FTE, but
Yes.
the head count of those was 106.
Yes.
42
have returned.
Head count came back?
Yes, head count.
Head count came back, okay. And of that, of those, there was 10 head count in the same district?
Yes.
7 head count in other districts?
Yes.
And you said there was how many?
25 as VMOs in their former district, the same district.
Okay.
Do you have the FTE for those headcounts?
I don't. I'm happy to take that on notice.
Thank you.
We hadn't started the clock.
Sorry.
I was about to ask if you had follow-up questions. We'll resume opposition time in any case.
Okay. Thank you. The other follow-up question I have for that, if you can take on notice, it was my understanding that there was an opportunity for people who separated to have a VMO contract, and I'm wondering whether any of those 25 headcount VMOs had been working as VMOs during the period of the dispute.
I'll take that on notice.
Great, thank you. Minister, if we could just turn to Northern Beaches Hospital. It's currently a public-private partnership, and it is going to be taken over by the government. Will there be any reduction in the current level of mental health service provided there?
No, that's not my expectation, and in fact I would hope there might be an opportunity for increased mental health service provision, but obviously the details of that are still being finalised.
And when will the details be finalised?
Susan, are you able to provide an update on the timeframes?
Yes, the team are working on this, Mrs. Carter, day and night, to be honest, and we expect that those details will be finalised, at least insofar as the contractual arrangements in the next week or two.
Mm-hmm.
The clinical services planning associated with the Northern Beaches is obviously something we're very keen to continue to work on with the clinicians and obviously community, and that will continue to flow. But to Minister Jackson's point, there is no expectation on my part either that there will be any reduction in mental health services, and in fact we would like to see an increase in those in the coming period.
And so how exactly will the mental health services which are currently privately provided be retained at the Northern Beaches Hospital?
Well, the entire hospital, as I'm sure you're aware, will be transitioning back to the New South Wales public health system over the coming months and into next year. And that will mean that the services that are currently provided in the hospital, and there are obviously public services and private services, in the hospital will transition across to the public system. We are also working through...
sorry, can I just clarify that?
Yeah.
So just to make it easier for me to work out the maths, assume there's 20 hours a week public mental health services, 20 hours a week private mental health services currently provided. Is it your advice that after the transition is completed, there will be 40 hours a week of mental health service provided publicly?
I won't speculate on hypothetical numbers, but Matthew, are you able to perhaps comment on this?
Perhaps we can come back to the details this afternoon, but the question really is, will the private capacity be retained in terms of the services available to patients? And perhaps we can come back to that this afternoon in detail. That'd be
it is
useful.
our expectation, to be clear, that the range of services that are available in the hospital will continue to be available to that community.
And the same quantum?
We can come back this afternoon on detail.
Okay, quantum's not really a detail though if we're talking about service provision.
Well, we've
is it?
already, both myself and the Secretary have already indicated that it's our expectation that there will be no diminution of services, and that in fact there may be the opportunity, as the public system takes over the provision of all of the services in the hospital, for them to be enhanced. But the contractual arrangements have not been finalised, as the Secretary has said. We're hoping to do that soon.
Okay, wonderful. Currently, Northern Beaches Hospital offers 61 mental health beds across 4 specialised wards, and this includes 20 public and 20 private beds and 6 beds for short-stay crisis health admission. Can you guarantee that there'll be no reduction in those bed numbers when the transition is complete?
Well, I mean, as we've said, yes, it is our expectation that there is no diminution in services that are provided.
Okay, so I hate to quibble, but is an expectation the same as a guarantee?
Well, I mean, the details are being finalised. Ms Carter, I assume you're asking these pointed questions because you object to the bringing back of this service.
No, I am asking these
privatised
questions
into
on
the public
behalf
health
of the
system.
people
And
of
that's
the
okay.
Northern Beaches.
You are entitled to defend your government's position.
Minister,
that the
thank
private
you for the
provision was
editorial.
preferable.
It's not helping, and I'm sorry you're so defensive about what's happening. With respect to youth mental health beds at Northern Beaches, the Coalition Government committed to provide 4 of these at Northern Beaches Hospital. You scrapped these. Now that you're planning to take over the hospital, will you commit to reinstating these youth mental health beds at Northern Beaches Hospital?
Well, I mean, just to be clear, the reason that we couldn't provide those beds is because a privately run hospital could not be directed to provide services to the public health system in the way that we expected.
Could you clarify that? Because, Minister, in your announcement when you said that you were scrapping those beds, you didn't mention that as a reason at all. In fact, what you said was that you were redirecting the funding for those beds into mental health in the community.
Yes.
And that other reason that you've just given us now wasn't mentioned, and part of this mental health in the community was the Brookvale Safe Haven. What happens if a young person needs emergency psychiatric support at 8:30 at night?
I mean, Ms Carter, I was extremely clear in all of my public commentary at the time that we redirected that funding into the community mental health service provision, that the reason that that was happening is because despite numerous meetings between myself, New South Wales Health, Mr Shembry, and the team, the private providers who ran Northern Beaches Hospital, they would not provide the service that we were asking them to provide. We said to them, here is the funding, will you please provide this service for adolescent mental health patients in your hospital? And the answer was essentially, no, we will not. It blew my mind at the time.
Well,
I
then,
couldn't
Minister,
believe we were in this position where money was being put on the table to provide a service.
Minister.
And because of the decision
Minister.
to privatise the hospital, our hands were tied.
So, Minister, does that mean that now the hospital is coming back into public hands, that those beds will now be provided?
We will explore that. That's the potential enhancements that I've referred to, although unfortunately we have already redirected that funding
So
into
with respect
community
to that
mental health.
redirection, I don't believe you've answered the question I asked. What happens if a young person needs emergency psychiatric support at 8:30 at night?
Well, I mean, they are able to access care in the Northern Beaches Hospital, and as I said, we are we are ensuring that the care that's provided at the hospital 24/7 through the emergency department is of course still there. But it is true that there are no dedicated adolescent acute inpatient beds in the hospital, and that is not because we did not want to deliver that. We did, and we put the money on the table, but your decision to privatise the hospital made that impossible, leaving us with no
Well, we look
choice
forward to
but to
those
redirect that
beds
money
being
to community
available
mental
when
health.
it's back in public hands. Now, in February this year at the same time, you announced that you'd be opening a youth mental health hub on the Northern Beaches. 10 months later, consultation for that hub is still ongoing. When will it open?
Mr Shembry might be able to provide an update on that timing. To come to the table.
Thank you. Those capital works at the Brookvale Community Health Centre are currently underway.
So excuse me, the consultation's ongoing, but the capital works have started?
The consultation for the design works has been completed, and the contracts have been issued.
So what's the consultation that's still ongoing?
Around the ongoing model of care with some of the community mental health
and
providers.
When will care commence?
I believe at the middle of the year, next year, but I'll confirm that today.
If you could confirm that today, thank you.
Thank you.
Great. And while we're talking about confirmation, do we have those parking figures available, the number of new car parking spaces added this year?
I don't think we have that yet, Ms Carter.
Okay, so, but they were the justification for the increased revenue from parking. So if...
Well, I was able to provide the figure, I recall, of 850 new car parking places available, which is a not insignificant increase.
No,
we do not have the district-by-district breakdown at our fingertips.
Okay, but so those parking spaces available across every LHD or only certain LHDs?
Well, as I said, I don't have a breakdown of that. And
Okay, so Minister, do you want to amend the answer you gave earlier that the reason for the revenue is because you've increased car parking spaces?
Absolutely not. The increase in individual per use cost has only been by CPI. That I've been absolutely clear on that.
Well, Minister, I understand from a quick look at the annual report, and I'd be happy to get further detail, that there have been 2 parking stations that have been open in LHDs this year. One of those was at Concord. Is that in the Western Sydney, the South-Western Sydney, or the Nepean Blue Mountains local health districts?
No, I don't believe it is.
So that one cannot. It might explain the 185% change in revenue for the Sydney Health District, but it can't explain revenue increases in those Western and South-Western Sydney districts. I believe that the Dragonfly parking was open at Westmead. Is that in the Western Sydney Health District?
Yes, it is.
So could that explain the $6 million increased revenue from parking in that local health district?
Well, I mean, it could potentially have contributed to that.
Okay. And there's no others that have been open in that district that you can tell us?
Not that I'm familiar with.
So is the Dragonfly parking, is that staff parking for nurses primarily?
I'm not familiar with that car park.
Can anybody else help us? Is Dragonfly for nurses, or is that for
Mrs.
visitors?
Carter, we will certainly provide as much information to the committee as we can. If you could give us some time to collate this around some of the questions you've asked this morning.
Well, Mrs. Pearce, you'll understand that we're being told we are looking at massive increases in revenue
But what,
for
are you
parking.
suggesting that I'm lying, that we haven't increased per use charge by only CPI?
Well, Minister, you're telling us that
that's a
they've
huge thing
increases.
to say about my answer. I am telling you
I'm
that
asking
per
for the
use
facts to
charge has increased by
substantiate your answer.
CPI only.
And then you were also saying that the reason to explain this massive uplift, we're talking about increase in revenue, 58% for Western Sydney LHD, 49% for South Western Sydney, 60% for Nepean Blue Mountains. That is way above CPI, I think you'll
I
admit.
agree with that.
But these are the year-on-year increase in revenue figures, and then you're telling us it's because of increased parking spaces, but can't tell us where these parking spaces
Mrs. Carter,
are.
if I may, through you, Chair, we will certainly provide further detail, but I wish to be categoric with you about this point. There has been an increase in car parking spaces. The figures that you are comparing are not equal. So in the 23-24 financial year, 7 months of that year, there was still free parking available to staff.
Can I stop you there, Mrs. Pearce, because the figures I'm using are the 24-25.
That's right, but compared to the previous year, the 7 months of that year, there was free parking for staff, which was associated with the tail end of COVID. They are not equal years to compare.
Okay.
So there is that factor.
Thank you.
There is the factor of the CPI increase. There is the factor of an increased number of car spaces. And I can tell you categorically that any suggestion that there has been a dramatic increase in the cost of parking for staff compared with, say, 18-19 pre-pandemic is not true.
All right, well, I look forward to getting those figures.
Happy to provide it.
Great, thank you. Perhaps we could turn to eating disorders. So, Minister, the first 5-year plan for eating disorders was established in 2013. this was evaluated, served as the foundation for the current service plan for people with eating disorders, which runs 21 to 25. What work's underway for a new 5-year plan?
We just finalised the evaluation of the most recent plan that you referred to. My understanding is that that has now been finalised and will be used to inform the development of a new plan in the coming year.
So what's the timeline on that? When can we expect that?
I mean, I think next year, 2026, I don't have an exact time frame. I don't know if someone's able to provide a more detailed time frame on the finalisation of that plan, but that's, as I said, the evaluation has just been completed, and so that will commence.
And the evaluation will be made public?
I don't have an objection to that, so we can take that on notice, but it's not something that I have a problem with. I mean, either the evaluation is positive, in which case we will be continuing with service models similar to those that we've used in the current service plan, or the evaluation will indicate that there were gaps or shortcomings, in which case I think we should just be open about that and make revisions.
Are you aware whether the evaluation has looked at differences across LHDs?
I'm not aware of the detail.
Okay.
Is someone else more across the detail of whether it looked at LHD comparative information?
Yeah, just a quick yes or no would be great. Thank you.
My understanding is yes, and it's particularly looking at access to tertiary services. So, yes.
Great, thank you very much. I think that'd be very helpful. Minister, is Justice Health part of health, DCJ, both? Where does Justice Health sit?
It sits within New South Wales Health.
Okay.
And although obviously it has a very close relationship with DCJ.
Yeah.
Through the corrections portfolio.
And what's the designated number of mental health staff employed by Justice Health, and how many of those are psychiatrists, staff psychiatrists?
Oh, I'd have to take that on notice, or ask if someone might look that particular figure up so that I can provide it to the committee.
Okay, that'd be helpful. Do you know how many staff specialists employed in Justice Health resigned, and how many may have rejoined? Do we have figures about that?
There are figures that are available. I mean, I can look that up. That will take some time for me to find it. I can ask the team to look it up and provide it to you. So yes, there are staff specialists employed as psychiatrists within Justice Health. Yes, a number resigned. My recollection is that it was a small number and that a number have rejoined, but exactly what those numbers are, we will get for you.
Okay, because my question, I think, relates directly to Justice Health, but because of the particular forensic specialty which those staff psychiatrists had, but also more broadly, when I look at these figures of 106 head count leaving as staff psychiatrists, and then, was it 40... I can't do the maths quickly, but...
around 40% returned.
Thank you, around 40% returning. What work is being undertaken to develop the specialist knowledge and skills that were lost during the resignations? I'm particularly acute in Justice Health, but I'm sure just as relevant across eating disorders, juvenile psychiatry, a whole range of other areas.
Yeah, we've had a couple of conversations with the college around some of those specialisations, and our desire to, in particular, ensure that that's not lost. Dr. Wright has really been leading on that. Do you want to comment, Dr. Wright, on some of the work that we have been doing to ensure that specialisation is retained in the system?
Certainly. I think that some of the strategies that we had to put in place in the early parts of this year to manage the loss of the workforce, some of those have proven to be transformational in terms of where we want to go to the future. So, for instance, the setting up of the virtual psychiatry hub, which provides in-reach into emergency departments across the state, initially was there to support in the loss of workforce, so that people would still get access to care. That's that we believe is is an initiative for the future.
I'm very grateful for the general description, but the question was quite specific, rebuilding specialist capacity that's been lost.
Yeah.
Well, one of the additional things that we've done, Ms. Carter, is identify the areas where that specialisation is particularly relevant. You've mentioned justice health. Another example would be perinatal mental health, and we have identified where those facilities are available, are delivered, and then worked specifically with either those districts or networks to ensure that they have particular plans to bring back online those specialties. So an example would be Justice Health, an example would be Sydney LHD, and you know, as Dr. Wright said, there's been a range of other initiatives that have been undertaken.
In terms of specialist skills, I'm wondering what input Justice Health has had in the development of programs in Moree, just been announced in Kempsey and Tamworth for young offenders.
I'm not familiar with the direct engagement of Justice Health on that. That piece of work is being coordinated by the Premier's Department as a whole of government priority. I don't know whether any witness here would be able to provide information in relation to Justice Health engagement, but we could take that on notice.
Okay, thank you. And a question about Junee Jail, which I believe has come back into public hands. How many additional staff did Justice Health employ in connection with the reacquisition, if you like, of Junee Jail?
Again, I'm not sure if we have that. I'm happy to take that on notice.
And perhaps you could take on notice what the wait time is per jail for an inmate to be able to see a psychiatrist.
Sure, happy to take that on notice.
Thank you. Minister, you've employed 5 mental housing liaison officers. Are they clinical or administrative staff?
Well, my understanding is that the skill set that we were looking for was varied. They're largely clinical staff, so people like social workers and other allied health professionals were the bulk of the staff that were employed in those roles. But I could take on the exact skill set and qualifications, but that was the purpose and intention of those roles.
Yeah, look, if it is possible to provide more information and where each of the 5 is located, I'd be very
We definitely
grateful.
have the information about where they're located.
Okay.
Again, I can look that up and provide that. But as I said, my understanding, having met with a number of those staff, is that their backgrounds are allied health, social work in particular.
Okay, thank you.
I've got some questions about the New South Wales Health social media policy, noting that the final policy's now been released and that there were some changes made between that document and the earlier draft. My first question, and I'm happy for the Minister to take this, or Ms Pearce, the definition of social media under that policy includes programs such as WhatsApp and iMessage that are commonly used for people to communicate directly with one another on their using a personal mobile number. Why was it necessary for New South Wales Health to seek oversight of people's private communication on those platforms?
I might, if it's okay, Dr. Can I ask Richard Griffiths to come and respond. I will say, though, we have done a lot of consultation around this policy. It is not a new policy. It is a whole of government position with respect to the use of social media. I am aware, and we have had some concerns raised with us from staff who are part of WhatsApp groups, that some of the commentary in them at times is less than desirable. And that people are exposed to those things through their workplace. So we're not interested in personal WhatsApp arrangements. What we're interested in is our staff who are at times exposed to those types of communications. But Richard, did you wish to add to that?
Yeah, thanks. Morning, committee. In terms of the use of WhatsApp, some of those WhatsApp groups have numbered into the several hundreds. And so it was appropriate that we build that into the definitions of the policy, simply because the reach of those groups was so wide. And we wanted to ensure that we gave guidance to staff around how to appropriately use it. So the intent of the social media policy is not to restrict social media, it's to give guidance around how to ensure that they protect both themselves but also the reputation of New South Wales Health.
How do you differentiate then, in a WhatsApp chat that might have 2 or 3 people who are on a shift together and one that's got 700 people on it? There's obviously a subjective assessment here of what you're deciding is social media.
I think that's exactly the point. Dr. Connor is quite subjective, and so we put it into the reach of the policy as general guidance.
Okay. Does that mean it's your intention for that to then apply to all WhatsApp communication, including those smaller groups?
From our position at New South Wales Health, we think it's wise for everyone to apply the principles in the use of WhatsApp groups that is associated with the work environment.
The policy includes carve-outs, for example, for union delegates to speak publicly, which is extremely welcome. Does that mean that employees have to be members or delegates of their union to be able to advocate for improvements in their workplace?
It was a very extensive consultation process, as I'm sure you're aware, and we did take on board feedback from a range of stakeholders, including the unions. So yes, there is a carve-out in relation to union participation and comment, but the principles apply to everyone, not just to union members, around the appropriate use of social media.
I appreciate the consultation was extensive. I suppose you would be aware that extensive consultation also resulted in a reasonable amount of pushback from some staff and their representatives. We debated the draft policy in the Legislative Council, which I'm sure you're aware of, and the government took the position at that time that employees should be able to share their personal views about social and political issues, provided this is done respectfully and in a way that doesn't breach their existing obligations under the Code of Ethics and Conduct for New South Wales Government Sector Employees and the New South Wales Health Code of Conduct. In that context, why was it actually necessary to bring in a social media policy in addition to those existing codes of conduct for government sector employees and health?
So the principles in the social media policy are long-standing principles in the government and government policy. The Public Service Commission put out some updated guidance mid this year, and our policy replicates the guidance associated with the Public Service Commission. And everyone's, I'm sure, aware that we've had some issues with unfortunate commentary on social media. The intent of this is to reinforce to people that it is not a restriction, it is not a ban on social media, it is guidance to protect everyone. And importantly, it's designed to ensure that the public know that they can come into New South Wales Health facilities and receive apolitical service that is, and that they feel welcomed, that there's no concern in terms of accessing our facilities around views held by our staff.
Without getting into the issue that you're alluding to, there's obviously existing protections against hate speech or discrimination against a wide range of groups of the community for good reason. If this isn't a ban and it's not a restriction, I suppose what then happens to a staff member who's breached this guideline by expression of their social or political views, particularly if they're not in breach of those other existing guidelines or legislation?
So the other policies you're referring to, things like our conduct, code of conduct and the disciplinary policies will provide guidance around actual process for addressing breaches of the policy. But the intent of this is case by case. So we know that there's an element of subjectivity in terms of use of social media. In terms of reasonable use, that's in itself rather subjective, and so we can really only address it case by case.
I think if I could add, Dr. Con, to what Richard's already said, is that there is also a different view of this, and that is that our staff have been targeted at times because of their views, and we've had various elements of society, media, trawling social media pages, and then asking questions of our staff in respect of their views and also then in respect of their position within New South Wales Health. So there are a number of elements that we need to take into consideration. But the other thing I really would like to be clear with you about is that in the almost 40 years that I've been working in the New South Wales health system, there has always been the opportunity for people to raise their issues through their unions, through many mechanisms, and the annual report's been referred to here this morning. In the annual report, I made it very clear once again that we want our staff to speak up. Social media is one element of that. It is not the be-all and end-all for how people should raise their issues, and there are many other ways for people to do that, and including coming to me, and many people do that. So we really encourage our staff to speak up. This is not about restricting their views, but we really do have to maintain the trust of our community in the institution that is the New South Wales public health system. And at times that has been challenging, and it has been particularly challenging, as you know, earlier this year with a video that was circulated widely on a social media platform that created enormous angst across our system in regard to this. So we are balancing the need for our staff to have that opportunity to raise their views by whatever means, simply providing guidance, but also advising them that there are other avenues and mechanisms for them to do so.
In my last couple of minutes, Ms Pearce, I wanted to ask you about the situation at Calvary-Marda with the mould, particularly in the ducts on the cancer ward. It's my understanding that questions that were directed to Novacare were directed back to the state government, and previous questions that have been asked of the local health district have been bumped to Novacare. Who's actually responsible or accountable for fixing this problem?
We always take very seriously, of course, our responsibility and the elements that we're responsible for in any situation where there are patients receiving care and there are public monies going into that care. But Emma, are you able to comment about Calvary? We are working, the local health district is working very closely with the providers there. We are also looking at the cladding on that building, which has been a substantial part of the problem, and we did have some difficulty with some of our partners in respect of that, but we are working through that. And Ms Schoolander may be able to give some further detail, and we can perhaps also take anything else on notice because it's a rather complex issue. But over to you, Emma.
Yeah, I think just the complexity of the arrangements with the PPP provider does mean that we don't have the direct control over the fix as required in relation to that. So the Hunter New England Local Health District is absolutely working very closely on the ground there, in addition to working very closely to manage with Novacare, how that issue gets resolved. I think that at the present time we're comfortable that the risk on the ground is very minimal, and that is allowing us the time to make sure that we effectively work through that problem for a long-term solution and not a short-term fix that isn't effective.
Thank you. I'll come back to this later. I'm out of time. I'll go to Ms Fairman.
Thank you, Chair. Mr Cleary, so Sydney Water, I'm just wondering about the impending changes in relation to PFAS in biosolids, and just would like an update in terms of what Sydney Water is bringing on in terms of technology to treat biosolids better. Is that what you're doing, firstly?
So yes, we are working with the EPA, firstly, providing advice to the EPA as part of their review of the guidelines and how they're bringing them into effect into New South Wales. Those guidelines haven't been finalised. Our understanding at this point is that there will still be the ability to beneficially use biosolids, and that's something certainly that, as long as it's done in a way that protects the environment and can be done safely, clearly would support. It's an important way of returning nutrients and organic matter back to productive farmland. We are constructing a carbonisation facility at Riverstone, water recycling facility, which will provide treatment for PFAS. that facility is the facility currently which has higher levels of PFAS in the wastewater coming into that facility than we are detecting elsewhere across our area of operations. So PFAS is, as everyone's well aware, is ubiquitous, so it has the potential to be across our entire area of operations, but the levels that we detect are different depending upon the wastewater catchment that we are talking about. And so we will put this technology in, and then we'll continue to evaluate the guidelines and the requirements to ensure that we can safely deal with our biosolids products.
So the technology that's going in, to be clear, is in relation to Richmond, but not elsewhere.
Riverston, sorry. Riverston?
Riverston.
Sorry.
Okay, my bad there. So in terms of where the biosolids are going, treated effluent at the moment, it seems as though, therefore, like I've seen emails where it says that Sydney Water was considering bringing in new technologies to address the need to increase treatment of biosolids. So you're saying that this necessarily won't happen across all of Sydney Water's treatment plants at this point, even though it has been identified for quite a few years now that regulation will come in terms of PFAS in biosolids.
So no, you're right. We don't have immediate plans to upgrade all of our biosolids treatment facilities. I think it's important to note that even though there has been, you're right, flagged that there will be changes in guidelines, those guideline changes are now are still being worked through. And I think our number one priority is to ensure clearly that biosolids that are beneficially used are done in a safe way. It does not necessarily follow that all biosolids we must have a high level of treatment to remove all of these compounds, and we certainly strongly support trade waste controls and treating it at the source. That is the most cost-effective solution. We are also revising or continuing to work with our commercial and industrial customers on trade waste controls, and we are seeing in a number of our catchments we have very low levels of PFAS. So we are taking an approach that's based upon the evidence we're seeing. I think it's also important to note that, so certainly our number one priority is that we will provide safe biosolids and deal with them in a safe way. The treatment technology that we're dealing at Riverston certainly is important for that facility, but it's important to note those treatment technologies do come with a significant cost. So our first priority is to make sure that the biosolids production is safe, but beyond that we certainly also want to make sure that we are not spending more than we need to safely manage our biosolids. So it's not a given that the treatment would be across all of our operations.
Okay, and is there public reporting of the PFAS levels in biosolids that are reapplied to agricultural land, for example?
Look, I'll have to take on notice exactly what has been made publicly available. So, because it is complex about where the application sites are, so I don't have at hand exactly what is made publicly available, so I'll take that on notice.
Okay, all right. Minister, this is in relation to, which we've spoken about before, water access licences for Aboriginal legal entities, if you like. So I understand that there's transfers that have either begun or being contemplated in relation to transferring water access licences to First Nations people and entities. So what consultation specific to this transfer process of water access licences have taken place in relation to or with Aboriginal people and entities and parties?
So it was contemplated alongside the development of the recently released Aboriginal Water Strategy as a practical application or implementation of that policy. So there was an incredibly detailed consultation process that informed that strategy, in particular focusing on our regional Aboriginal water committees, and I can ask for a breakdown of how many we have of them and who's engaged with them, but they're a very comprehensive network of Aboriginal people interested in water policy. We then did some particular consultation with First Nations people about how to make sure that the process for the transfer of water access licences was done in the right way, and some very prominent and well-regarded First Nations, Aboriginal policy makers and advocates were involved in that. We are now in the process, as you say, of a registration of interest from Aboriginal entities as to their interest in receiving the transfer of those licences. So it has been a process that's been subject to very comprehensive consultation and engagement with Aboriginal people.
I have heard feedback that there's confusion about who can and should legitimately apply for water access licences under this scheme in different areas, and importantly, who has primacy. There are concerns that someone could just set up a company, for example, give 51% of shares to an Aboriginal person and be eligible. There's also concerns around the assessment criteria, that there's no assessment or ranking around connection to country or the status of the group applying. I'm no doubt understand how complicated it is, but there's concerns that there wasn't consultation wide consultation with a lot of groups around how this transfer would be undertaken. So is there any way that
I'm happy to take that
improved?
on. I'm happy to take that on. I think one of the challenges here, Ms. Fairman, is, my view is we have to do something to actually transfer ownership to Aboriginal people. And we're not about to make the transfers. We're in a registration of interest process. As you rightly identified, things like the New South Wales government ranking connection to country of Aboriginal people is highly fraught. And I know that's not what you were suggesting, but those kind of decisions are complicated. To be honest, there was advice that I received not to do this, that it was too hard, that trying to actually practically implement this policy was going to raise all these questions and all these objections, and it would be easier not to do it, not to wade in to this challenging and contested space. And I made a call that actually this was worthwhile doing. Now, that doesn't mean that as an entirely new process that there won't be some bumps along the road, and some of those concerns that you raised are entirely valid. But I want to assure you we have a very comprehensive process to work through those. There was a lot of consultation that was done and continues through the registration of interests process. But I don't apologise for actually trying to finally set up a system where we might be able to transfer some water access licences to Aboriginal people, despite the fact that that could be a complicated and contested space.
So in the time I've got left, I understand also that during a webinar, an official maybe confirmed or indicated that the government would pay the New South Wales Land Registry Services for the cost of registering the water access licence to the successful applicants. This is the cost of registering specific purpose water access licence is $350 per licence. Has that been confirmed that that will be the case? The government will do that?
Yes, I understand that is confirmed, that we have indicated that we will cover those costs.
Thanks.
Back to the opposition.
Thank you, Chair. Minister, there's been a lot of speculation about the Commonwealth Environmental Water Holder having taken water illegally from its licence that holds at Tooral Station. Can you confirm if the Natural Resources Access Regulator has treated its investigation in exactly the same way as it would treat a private entitlement holder?
Yes, I can confirm that, and I can ask Mr Barnes to confirm, as the Chief Regulatory Officer of NRA, to confirm that as well.
Thank you.
I can confirm that the operations of Tooral is compliant with New South Wales water laws.
So there was nothing found that was of issue?
Well, there clearly was something that was found that was of issue, which is why NRA took the step of issuing the stop, stop work order, or whatever that particular regulatory action that you took was.
Yes.
So clearly that was the case,
Yep.
but NRA has then worked with the water holders in that at Tooral to resolve those issues.
Okay. What penalties were applied?
We've worked with the approval holder, who has the legal obligation to record, report and debit water diverted from the western access into the western wetlands in accordance with the principles of the Act. We've also found, though, that the way they operated those works were in accordance with the licensed approvals. So one can't move into an enforcement and therefore application of sanctions when there is no finding of wrongdoing. What we have, however, is in concluding our investigation, identified matters that might be of interest to the Inspector General of Water Compliance, and we will be making a referral to the Honourable Troy Grant in the coming weeks.
So, in answer to the question that I asked, what penalties were applied?
No penalties were applied.
No penalties were applied
because
Thank
no
you.
laws were broken.
Thank you. You understand that in circumstances where private water licence holders feel as if the Commonwealth environmental water holder has escaped sanction here, that there's a two-stage penalty enforcement system where...
No, we would completely reject that. I mean, many of the questions that we receive are about how NRA's initial investigatory activity should focus on education, on ensuring compliance. That is what they do for everyone. I completely reject, and Mr. Barnes would completely reject any assertion.
Mr. Barnes can speak for himself,
that,
Minister.
I will allow him to speak in a minute. I would completely object to any assertion that water holders have been treated differently in the application of their licence conditions. However, NRA does always rightfully focus on ensuring compliance. They don't come in heavy-handed. They don't come in with a big stick.
Are you sure
with
of that,
anyone.
Minister?
Absolutely.
Are you sure of that?
Yes.
Okay.
I am sure of that because I talk constantly to NRA
Okay.
about how our focus is ensuring
What about the
compliance
people on
with
the
water
ground,
law.
Minister? Do you speak to them as well?
Absolutely, I
Okay.
do.
And what do they say to you?
What do they
Has nobody raised with you that they believe NRA is over regulating and comes in with a, and what's trying to find remember the word you used, with a heavy hand in effect when looking at issues of compliance?
Individuals who've been subject to NRA regulatory action often aren't particularly big fans of that.
So people have raised it with you, is that correct?
Well, as I said, individuals who are subject to regulatory action often aren't particularly big fans of that. But by and large, Mr. Fang, the vast majority of water users do the right thing, and they are extremely
I agree with you,
supportive
Minister.
of having a strong cop on the
agree
beat.
with you that, which is interesting that you say that you don't believe that NRA acts in a certain way. That's okay. I'm going to move on now. So does the Water Management General Amendment Water Returns Flow Rules and Exemptions Regulation 2025 exempt any prescribed licence holders from metering or otherwise measuring and reporting the take?
Amanda, do you want to provide information on that?
No.
No?
That's the answer.
No. Okay. So what about when a licence holder takes, or moves water around, such as the Commonwealth Environmental Water holder?
No, that they are required to meter that. That was the issue.
Okay. So have they been doing that at all stages now, Mr. Barnes?
The mechanism here is by the approval, not by the licence. It's an important distinction to make. So the work is approved, and then associated with that will be water access licences. In some cases, they are not the same entity. So with respect to Taral, it's an investigation of the approval holder, not the Commonwealth Environmental Water holder. When it comes to moving water around the landscape for the purpose of e-watering, it is through works. Those works are approved. Those works are not licensed. So what we do is ensure that the works approval holder understands their rights and their obligations, and we assist them into compliance. That is not a matter for the environmental water holder, whether it's the New South Wales Government or the Commonwealth. They are the works approval holder. In this instance, that means NRA's worked very closely with my colleague Andrew George at Water New South Wales, who often holds those approvals.
A lot of different answers there from three different people, but I'll ask it in plain language. Is all the water that's being moved around Terrell being metered?
As a result of a lengthy investigation by NRA, my assurance to you is that the water that's diverted is recorded, reported, and now debited against a water access licence. That is an obligation that's long-standing and has been imposed across most water users in the state of New South Wales, unless it's BLR
Mr. Barnes,
or unless
I
it's
asked, was it
excluded.
metered?
Not all environmental water is metered. That's what Ms Fairman was referring to earlier. There are specific carve-outs that reflect the differential nature of water that is taken for environmental purposes.
So now we're going around in circles
and
because I
consumptive use.
specifically asked, was there exemptions? And the answer was no, Ms Jones. Is that right?
That's correct.
So then how is it that water can be moved around, environmental water can be moved around without it being metered? If you can't measure it, you can't...
It is, that doesn't mean it's not measured. It's measured. So would you like to talk about
So
the
can
methodology?
we not then apply the same measuring requirements to everybody else? Why does one
it
licence
depends on
holder get one?
It depends on the physical conditions and the topography and just how you can form that measurement. Sometimes, if you've got a pump, a meter works. If you've got an expanse where a regulator might release water onto an open floodplain, then you need a methodology to measure that water because you can't meter it.
So you understand, though, that this is part of the issue of why people have concerns around the water space. The Commonwealth Environmental Water Holder is allowed to do one thing that private water holders aren't.
Well, because, Mr Fang, if you can't understand the difference between a public
No,
and
Minister, don't try and patronise me. I'm asking you if there are no exemptions in place, why are you allowing one government body to do something that you won't allow private citizens to do?
Because government bodies manage environmental water, which is not water that is intended for profit-making productive use. It is a different thing. There is a difference between environmental water and water taken for private consumptive use. There is. And as Ms Jones has indicated, our effort is to have maximum metering and measuring. That is what we would like to see. But there is a difference between a giant pump that is pumping water to make profit for private consumptive use and can be easily metered, and water released through a regulator over a wetland expanse that it is almost physically impossible to meter. That is the reason for the difference.
Almost physically impossible? So it can be done?
It cannot be metered in the same way as water through a pump can be metered. It is physically impossible to meter those two things in the same way.
It is still measured, though, using different methodologies, not a meter.
Pending the 2028 delivery of new funding for a funding model for local water utilities, has the government indicated or sought any advice or additional funding needed for the Safe and Secure Water Program?
No, because we are pending that review.
Okay. Is the current policy to refer to Newtown Water and Wastewater Works fundings to the National Water Grid Fund with co-funding from local water utilities and no co-funding from New South Wales?
Well, some projects we support and sponsor for National Water Grid funding, but others we fund directly. I mean, we want the Commonwealth to contribute as much as they can through the National Water Grid. So
you're engaging with the Commonwealth Government in relation to the budget that they should expect they will need to set aside for those programs?
No, of course we are. We have a ministerial council meeting on water coming up at the end of next week, where we will be strongly advocating for Commonwealth financial support for New South Wales water utilities.
Excellent. Minister, how much will we be asking for?
I will not be providing that kind of detail to this committee. I'll be reserving that for private dialogue with the Commonwealth Water Minister and my colleagues from other states.
I mean, as much as you sort of laughed when I asked the question, this is budget estimates, and I'm seeking to understand what you'll be asking for from the federal government in relation to their budget. I mean, this is quite literally the place to tell and ask these questions. Minister, how much will we be asking for from the federal government?
It's quite literally the place to ask me about New South Wales government budgetary allocations from the recent 2024-2025 budget. This is now the third budget estimates that I have appeared at this year, and happy to answer those questions. I would hope that you could understand that the advocacy that states do to the Commonwealth on behalf of, in this instance, myself and the people of New South Wales for local water utilities is not something that is aired blow by blow in public budget estimates committees. I can assure you I will be seeking maximum Commonwealth contribution from for New South Wales local water utilities, but I'm not going to go through the details of that advocacy.
Do you think it's unreasonable that I ask you how much money you'll be seeking from the federal government in relation to this program?
Yes, I do, because as I just said, how I do that advocacy is a matter for me and the Commonwealth. I'm not going to be foreshadowing that blow by blow in this forum.
Minister, this is the forum where I ask you what it is that you're asking for from the federal government, and then...
No, it's not the forum for that. It's the forum where you ask me about the 2024-2025 New South Wales budget.
Well, Minister, I'm also asking about the forward estimates. I'm seeking to understand how much money you'll be asking for from the federal government in relation to that budget.
A very large amount. As much as they can possibly contribute.
Minister, do you know how much you're going to be asking for? Or are you, like, is it the fact that you can't give me a figure representative of the fact that you don't know how much you'll be asking for yet?
I don't, Mr. Fang, I have been clear to you that we have the first ministerial council meeting in a long time on water next week. The subject of the future of the Commonwealth National Water Grid, the future of the National Water Agreement, the future of the Murray-Darling Basin Plan, all contentious topics, interjurisdictionally and between the states and the Commonwealth, are on the agenda. And I'm not going to be airing all of the details of my negotiating strategy here a week before the meeting. That's
Minister,
not in the interest of New South Wales.
How can the people of New South Wales judge whether you've been successful in your advocacy to the federal government if we don't know what it is that you're asking for before you go to the meeting?
Well, I think that the Commonwealth is going to make its decisions about what it thinks is in its policy interests, and we will be
I don't
putting
disagree
forth...
with you, but if you don't...
This is probably now the fifth iteration of the same question where the member attempts to extract an answer which has already been answered ad nauseum. That is, that would prejudice the negotiations period. The question's been answered. I ask that you ask the member to move on.
I think the last couple of questions were probably very cleverly just different from the previous ones, but Mr. Fang's obviously skating very close to just repeating the same questions.
I appreciate that, but I make the point that it's quite often the case that a minister will say before they go into one of these federal meetings with other ministers, we're going to be asking for $4 billion from the federal government for education, or we want this amount of money for health. Now, it's the case that you're going into this meeting, I'm asking you how much you'll be asking for from the federal government, and you're refusing to provide a figure in relation to this. This is extraordinary.
I ask you to table the transcripts of previous budget estimates in which my colleagues have provided that information. I don't consider it to be in the interests of New South Wales for me to prejudice negotiations.
How can we judge whether you have been effective in advocating for New South Wales if we don't know what you're going to be asking for when you walk into that meeting?
I suspect the point of order is going to be repetition.
I don't actually mind. I'm not for moving here. I will not be giving the Commonwealth and the other states advanced warning of New South Wales strategy in a contentious ministerial council by airing that information here. And you can ask me that question 20 times. I know what is in the interests of New South Wales, which is not to air this information, give everyone advance warning of our negotiating strategy a week before the meeting. I'm not going to do it, so keep asking the question.
Does the National Water Grid Fund have a designated budget allocation for New South Wales?
I don't know. Text one of your Commonwealth colleagues and ask them to ask Senator Watt. I don't know how the National Water Grid works.
On the 7th of October 2025, you said to Broken Hill ABC, you won't bullshit people when you were asked about the Wilcannia Weir project, saying that the government needs federal government help to fund it.
Yes.
What's the latest cost to build Wilcannia Weir as proposed by the community?
Look, the cost estimate, and this is not a cost that has been subject to a rigorous final business case, is between $120 and $130 million.
How much funding has the New South Wales Government previously allocated to the Wilcannia Weir project?
I understand that we have previously allocated up to $70 million for the project. Some of that money has been and is being expended right now on other elements, such as the upgrade of the water treatment plant and the provision of emergency bores. I'll have to take on notice exactly how much is remaining, but there is still a significant budgetary allocation that is apportioned from the New South Wales Government for the Wilcannia Weir, but as you can see from those figures that I've provided, not enough to cover the entire cost of that project.
I'm about to circulate some photos, Minister. If we could have those circulated, one to the Minister first, so she can have a look at that.
Procedurally, it should be tabled through you first, not to the Minister first, as a tabled document. It's just as a committee process. Procedurally, it should go through the chair and the committee
and then a
members.
copy to members before the questioning starts.
No, that's never been the case.
Yes, it
Well,
has.
it's always the case, yeah.
So the images had just been shown to me by the Secretary. I think all of that was sort of happening at once.
Right.
It is appropriate for things to be tabled through the chair to the members and to the witness.
Thank you.
There's very little context for these
I'm about
images,
to
and the
give the context.
committee will have
That's
to
the whole-
discuss
Yes.
publication or tabling status later, but I'm happy for members and the witness to have a copy again.
Minister, would you drink that water?
Sorry?
Would you drink the water that shown in the photos?
It doesn't look very nice, I agree with that. Probably wouldn't prefer to.
No. Minister, that's the water that is currently available to Narandra residents. Do you agree that that water treatment plan in Narandra needs urgent attention?
I think it probably does require an upgrade. I would agree with that. My understanding is that potentially it's not just the water treatment plant, but potentially the pipes. But I would agree that an upgrade looks like it's required.
Okay. Will the state government is the state government prepared to deploy a mobile or temporary water treatment plant to Narandra and assist with the cleaning of those pipes to ensure that the people in Narandra get appropriate drinking water before we hit summer?
Potentially. We can see whether some kind of mobile treatment solution would assist. My understanding is, whilst that water doesn't look particularly palatable, that it is drinkable. It's not as though, clearly aesthetically, it's less than ideal, but it is drinkable. So if there is a mobile treatment option that can improve the aesthetic quality of the water, we can look into that.
Minister, if we saw this sort of water in Newtown or Sydney City, do you think the member for Sydney would be allowing his residents to be drinking this?
I'm sure any local member who had issues with water quality would make representations to me, absolutely, and they do.
Okay. Minister, why is it acceptable for Narandra to have this sort of drinking water when you wouldn't allow it to occur anywhere else in the state?
That's just to completely reject the premise of your question.
You reject the premise of the question?
Yes.
Why is that?
Because there are circumstances across the state where local water utilities who manage water provision in regional areas have water quality challenges. That does happen. Okay. And in each and every one of those instances...
You're saying that this is safe to drink, that this water here is safe to drink in Narandra, and you've got no issue with this sort of water coming out from Narandra?
Well, no, that's not what I said. I said it is within drinking water guidelines. I also said that clearly aesthetically it's not acceptable, and that, yes, an upgrade of the facilities in order to improve that is necessary.
We're back to crossbench time. coming to very different topics, back away from the water portfolio. The Sydney Morning Herald reported a few months ago about rare occasions where children have been used in operations to investigate illegal tobacco operations, and there was a statement from New South Wales Health at that time that in very specific, highly controlled compliance and enforcement operations, our enforcement officers can coordinate enforcement activities involving attempted purchases by people under the age of 18. My question about that is whether or not New South Wales Health seeks working with children's checks for the compliance officers who are involved in working with, in this case, teenagers.
I would have to specifically look at that, but that's my understanding. But I will confirm that with the committee. There's quite a lot of procedural issues around that compliance monitoring. It certainly hasn't been a focus of our activities in recent years as we've shifted our enforcement to tackle the growth in illicit and vapes. But there is a quite significant policy framework around the use of minors.
Okay, thank you. If you're taking this question on notice, could I clarify? So I'm interested in understanding if New South Wales Health currently seeks working with children's checks, and if that has always been the case for these types of operations.
I will triple confirm that.
Thank you, Dr. Chen. Minister, are you aware of the restructure of mental health services that's taking place in the Mid-North Coast Local Health District?
Yes.
What's your understanding of the rationale for the change that's seeing the closure of the inpatient beds at Kempsey District Hospital?
That the provision of voluntary mental health services in a community or home-based setting is preferable where that is possible to be delivered in that form.
What consultation was undertaken with that community, local community or local staff before that decision was made?
My understanding is that comprehensive consultation with staff, with the local council, with the local member, with local Aboriginal health organisations and with consumers was undertaken. I know that I have a list in my notes of those organisations, so I can either bring that up now or I can provide that to you on notice. But I have asked about consultation and I have been assured that it has occurred with a wide range of relevant stakeholders.
Okay. Could you please provide that list on notice?
Yes.
I understand that there is a reasonable investment in community-based mental health services, which of course from my perspective is always very welcome. In particular, with the Safe Haven service that has relatively limited opening hours, and I know this isn't only an issue in Kempsey, how can people access mental health support outside of the opening hours of the Safe Haven?
Well, they are still able to access the hospital. What has changed is that previously voluntary acute inpatient services were delivered in a hospital-based setting, in a hospital ward. Those services are still available, but are being delivered in a home-based environment, and that to me is preferable. So people can still access the hospital, can still receive the full suite of services that the hospital was providing. Some of the setting of some of those services has changed to a home-based environment. For people who still require hospital admission, they are able to access that in Port Macquarie, which, I appreciate. If you're from Kempsey, you may not want to go to Port Macquarie, but if you're from Kempsey, you may well prefer to receive acute inpatient services in a home-based environment than a hospital environment. And in fact, as you're alluding to, my view is that moving towards those community settings is preferable where we can try that, and that is what we are trying in Kempsey.
I had a couple of questions about this proposed hospital in the home model. My first question was really, I think, what you were alluding to. I think if it were you or I who needed acute mental health care, we would prefer to receive those services in home, but it's a wide variety of people who might be experiencing homelessness or who might be transient or who might have a domestic violence situation or another reason that it's actually not safe for them to receive care at home. How are you accounting for those populations in this new model?
Well, as I said, they are able to receive hospital-based care in Port Macquarie. There is another significant group of people, Dr. Con, for whom home-based care is far more preferable, and it's First Nations people, who is a high proportion of the Kempsey community and of some of the mental health consumers there, where in particular, as you know, a hospital-based environment carries an additional layer of trauma because of some of the history of discrimination and racism in hospital-based care. And that cohort in particular has given feedback that community-based care is preferable. So hospital care is still available for people who require that for the reasons that you have identified, but fundamentally, we are trying to move mental health services into a community setting.
The proposed HIS model has talked about home visits potentially 2 or 3 times a day, so it's quite an intensive program. How can you guarantee the resourcing that's needed for that to happen, particularly in a context where existing community-based mental health services they're not resourced to do this kind of proactive or assertive?
Because some of the resources are being diverted from care that is currently provided in a hospital to care that is provided in the home. So it's not as though that hospital in the home care falls on top of the additional caseload of the existing community mental health system. That is going to be complemented and enhanced by resources that were previously in a hospital environment. But look, also, one of the things that I've been very clear about with the district is wanting to ensure that if this is something that we are going to try, that indeed those that level of care that you have articulated is in fact what's received. And if there are concerns that that is not what's occurring, well, I've also said we're open to revisiting this. I mean, I'm not interested in making this transition only to have feedback that what was articulated, what was committed to, isn't what eventuated. And in that circumstance, we'll revisit it. But I would be very hopeful. My sense is that the district really get this and are really committed to it and are trying, alongside the Agency for Clinical Innovation and other innovative work that is looking at the way our models of care work for mental health, are trying to get this right and trying to do this properly. That is my genuine sense, and that there is no resources are being taken away or removed from the district as part of this. It's just that they're being redirected so that care is being delivered in a different way and hopefully a better way.
You've led quite neatly into my last question, which was going to be about sort of evaluation of this new model. You've said that you're open to revisiting it. What evaluation framework have you put in place, or what information are you gathering? What would need to happen for you to reconsider it if it's not working?
Dr. Wright, could you talk about just the evaluation framework and the sort of monitoring that we'll be doing of how this works?
Can I preface it by saying that this model is one that we are very interested in seeing how it works. I think it's I think that the ability to have a position between ambulatory care and inpatient care, the hospital and the home, is one which is really quite exciting for mental health services. Absolutely, there is going to be a robust evaluation, not just for the local community in Kempsey and for the Mid-North Coast, but that's going to tell us on a statewide basis whether this is a model that we can look at in other settings for the future. I can't give you the specifics. We can give you that information on notice, but we are very, very interested in how this plays out, and if it's not working, we will address that. But we are also interested, and it's not a model that we've invented. It's a model that's been based on a very, very careful evaluation of the international literature, and it's a model that has quite a lot of success elsewhere. And we think it's something which would enhance the complement of services that we have in mental health in New South Wales.
Thanks, Dr. Wright, and I anticipate you'll need to take this on notice as well, but in terms of that robust evaluation framework, I'm interested to know, please, what the outcome measures are or what the performance indicators are.
Yeah, I'll take that on notice.
Thank you very much. I've only got 22 seconds. Apologies for the hospital pass, Ms. Pearce. What's the status of the review of the framework for termination of pregnancy?
Ms. Wolf, can you? Absolutely. So we're actually doing all of the revisions to the policy in line with what's come through the legislation. There's work happening at the moment on the actual requirements then for New South Wales Health Services in terms of provision of care, and also the element around conscientious objection specifically. We've done the initial work that's been completed to align with the legislative changes as they are, and the next piece of work is underway, and we expect that to be completed in 2026.
Thank you. I'll come back to that this afternoon.
Sure.
Thanks, Chair.
Yeah, go ahead, Ms.
Dr. Chant, if I could ask you about pill testing at music festivals. Has any report been released by New South Wales Health about the results and how that's tracking?
So New South Wales Health has tendered for an external evaluation. The successful tenderers for that were Sydney University. We undertake the timeline for completion of that report is to government in around March, to us in about March, and that really gives enough time to cover the summer festivals, to allow there to be significant, sufficient sample size of festivals involved to reflect on the learnings and a variety of festivals.
Does New South Wales Health, after each music festival, are there any reports provided for the public, or is that only if something dangerous, for example, has been found, that the public is alerted?
So we have embedded as part of the process for patrons of the service coming in to ask them some questions, which forms the basis of understanding the use of it, and it informs also the discussion by the peer workers supported by our scientists. We do only release information in relation to anything that's of notable that we find where there's an assessment panel. We have an assessment panel with NUA and other experts, and we decide whether there's any indication that we need to alert the community for broader public health risk. We also routinely get asked questions from the media around the number of transports and some other general information around the what's occurred after some of the major events. So at the moment, that's the nature of the reporting. It's largely only community reporting if there's something of salience in terms of the findings.
Has there been any situation so how many festivals so far have been had pill testing services there? Is it 5 or something?
I just have to confirm that, but a small, a relatively small number, and we're expecting over the summer break that there will be additional samples, additional festivals where the pill testing, but I can look that up if you
I think
would like.
the number that I got overall, I think you're aiming for 12 before the report is undertaken. Is it your expectation that the review is being given to government in the expectation that it will be continued in the way that it's tracking?
Look, I wouldn't want
the way that it's being undertaken.
Yeah. I think it's important that we've commissioned an independent review. It's appropriate that independent review takes place, and they will provide advice to New South Wales Health, who's contracted it, and then we will overlay with any additional information we've got and provide that to government for consideration.
So at any of the festivals so far, has New South Wales Health had to alert festival goers outside of the people who have had their substance tested about something being in circulation? Has that method of communication to patrons had to be deployed?
I would just have to check. I vaguely recall that there may have been an issue where there was a dissemination, but clearly there is a process whereby if there is a requirement to anything that is of concern, we can escalate that, have announcements on the stage. We can also we've worked with the festival organisers so that on the apps that the patrons have used to get the ticketing, we can also send messages. So those mechanisms are in place should we find something that would raise that threshold of concern that we needed to have that event. We also have a toxicologist or a more senior person available that can assist in making some of those risk assessments as well, Ms Furman.
Thank you. I'll come back later today if I need to on that issue. Mr Barnes, last time we spoke about the investigations, the ongoing investigations that NRA was undertaking in relation to some water compliance issues with blueberry farms on the mid-north coast. I think you said at the time there were 4 investigations ongoing. You've then clarified in an updated letter that it was 3. Where are they up to now?
Getting close. I appreciate that when I answer your questions previously, it is always a matter of progress, and that's the case in these 2. So I am confident that soon that these cases will resolve appropriately. I think in addition it's worth noting that our efforts in the mid-north coast in relation to blueberries is increasing, and we are taking a stronger enforcement stance where we are encountering long-term persistent non-compliance. So to that point, we've just commenced 2 prosecutions in relation to blueberry growing, typically where infrastructure has been constructed without approval or where water being retained on site is well in excess of a maximum harvestable right. So for NRA, it remains a focus for us to address some of this long-standing and systemic non-compliance with the industry.
When you said an additional 2, so is that as a result of a new compliance audit on top of the 2020 audit?
On top of, yes, correct.
Okay, and then the 3 though that you referred to are from 2020?
Yeah, so they remain in progress, yes.
Okay. When was the other... So a new audit, it's still a priority, so it's ongoing?
So we've got ongoing campaigns up in the mid-north coast, and the 2 that I've referenced are in relation to those campaigns. So as we're out engaging with landholders, and to the previous point, most of the engagement we do have is the preferring of advice and guidance, but in some circumstances we do encounter willful non-compliance, which in this instance, up in the mid-north coast, has resulted in 2 prosecutions being commenced, one in the Land Environment Court and one in the local court.
Now, is it similar, similar tools, compliance tools that you're using, for example, in the Northern Basin, satellite mapping surveys, for example, to assess what on different pieces of land, the 10% with how much they're taking in terms of their maximum harvestable right? Is that what's being undertaken
we
on
use
the
that
mid-north
intelligence,
coast?
yes, to identify hotspots and then to deploy our officers.
Okay, and that is continuing, which is a very good thing.
Thank you.
Dr. Chance, sorry, I do want to go back to the music festival notifications. So how long are you able to, or how soon after something is found at a festival does New South Wales Health then take to notify the general public, and by what means is that happening? I think I've raised some concerns in the past about them being on, say, the New South Wales Health's website, maybe the New South Wales Health's social media channels, but the delay in terms of notification. Are they still taking a few days?
So I think it's really important to perhaps differentiate between the range of pill testing and what information is known at a particular point in time. So I can confirm that there's been 6 drug checking events today, and yes, we have issued on-the-spot warnings. So, as you're aware, Ms. Furman, the technology...
By the on-the-spot warnings, that's not...
During the festival.
2 other patrons outside of... Yep.
So it's important to understand the limitations of the testing that is done, and that's why we also have an information and consent, so that patrons are really understanding that there are limitations to the test devices that we use. And so we do confirmatory testing. So sometimes that confirmatory testing will give us additional information that was not available to us due to the nature of the technology we use. I want to just thank the scientists at FAS who use the best machines, but there are limitations to that testing. We then take those pills and get confirmatory testing on different machines that can sometimes find substances that may be of a smaller constituent of the sample, or we might be able to get better characterisation of the amount of MDMA. So when there is a process where there has been concern raised, and that may be through the drug testing service or where patients may have presented to the medical tent, all of that intelligence determines whether we've got sufficient information and alarm to raise an issue at the event. So sometimes we're comparing, you know, there is going to be an inherent delay because we find something when we do the confirmatory testing, but really always happy to learn how we can do that more effectively. But I've really pleased working with NEWA, the festival organisers, to really refine how we get those warnings out.
Thank you.
There's a tiny bit of time left before government time. Go to Mr. Feng.
Thank you. Minister, in relation to the issue of PFAS in Wagga Wagga, why did the New South Wales Government respond to the issue by creating a 14,000 megalitre special purpose access licence, which impacts all the general security entitlement holders, when the Commonwealth identified that PFAS in other locations such as Oakey in Queensland and Katherine in the Northern Territory were a Commonwealth issue?
I mean, it is a Commonwealth issue, but we responded to it in that way because nothing is more important to me than ensuring a fabulous town like Wagga Wagga has access to water that's within the Australian Drinking Water Guidelines. So clearly, Commonwealth Defence assets are broadly responsible. That's good to lay blame. It's good to indicate that we expect them to do something about it. But my responsibility is to make sure that the town has got secure access to clean drinking water, and that's why we took that action.
No, I accept that, but in circumstances where we can walk and chew gum as well, why is it that general licensed security holders have paid the heavy price for?
Well, they haven't. That SPAL is only to be activated in the very limited circumstances where the current water sources indicate PFAS levels above Australian Drinking Water Guidelines, which has not occurred. But I am clear that it is a break glass in case of emergency. In that emergency situation, I have to be able to ensure that the town of Wagga Wagga has access to clean drinking water.
Thank you for that.
We don't intend to use the SPAL, but we will if we need to. And of course, we'll continue to work with the Commonwealth. But having identified that they're responsible, the next question is, what do we expect them to do about it?
I accept that, but Minister, where is that water? Like, there could have been other places that allocation of water came from.
Well, you tell me what they could be. Well, genuinely, I don't know what you're referring to.
Minister.
Saved by the bell, Wes.
Sorry?
Saved by the bell.
No, I think the Minister was saved by the bell.
Oh, please.
In my last couple of minutes, I'll just come
magic
back to...
Magic water.
I'll come back to...
Well, I mean, if we want to...
Mr. Feng, you're now in crossbench time. I'm coming back to Ms. Wood, please, because we were cut off before. So in your answer, you said the element around conscientious objections. Can I just clarify that you're referring to the greater clarity for conscientious objection that was recommended by the statutory review?
Yes, that's correct, Dr. Con.
Thank you. And does the review of the framework also include allowing nurse practitioners and endorsed midwives who are employed by New South Wales Health to exercise their extended scope that's now permitted?
It does, yeah. So the review will incorporate all elements that are in the legislative reform. We did a very quick update just in response to it coming down, but we're now doing a more fulsome update to include those items that you've just referenced, and also to really be very clear on the role of New South Wales Health in providing termination of pregnancy services, as well as their responsibility to ensure the referral pathways are in place at a site that may not provide that service. But in terms of the MPs and also the endorsed midwives, we're also doing a piece of work at the moment offering scholarships to provide that training. And we've had over 200 applications, so we expect that that will all come together fulsomely in early 2026.
Okay. Over 200 applications for how many places?
I'll take that on notice, but we actually we will make sure that we can actually accommodate through that process, because we do want to ensure we get as many people through that program as possible.
Okay, thank you.
No
I had one more question about the Supporting Safe Access to Abortion Care Grant Fund, which
Sure.
is an extremely welcome initiative.
Yes.
Specifically, there was a criteria around in designing the proposed service model, respondents must ensure that any eligible provider billing an MBS service, such as a GP, is not receiving money from another source for a salary or proxy salary. Can I clarify whether it's the intention of the grant program that this means any GP providing care through a grant can only be remunerated through MBS bulk billing rates, or have I misread this?
I would need to take that on notes, but I'll clarify that over lunch to come back to you. But that's not my, as you've explained it, is my understanding, but I'll clarify that for you.
Thank you very much. I appreciate it. Are there any questions from the government?
Don't you want to ask about the magic water?
There being no questions from the government, that brings us to
Give us
lunch.
your time.
Thank you
Yeah.
very much, Minister,
I'll use
for
the
your
15
time
minutes.
this morning, and we'll resume at 2 o'clock. Call get started. We're broadcasting. Thank you very much. And we'll resume with questions from the opposition.
Thank you, Chair. I'll probably address these questions to Mr. Cleary and Mr. George. Obviously, the government says it has a infrastructure plan, and it would seem that some of that infrastructure plan is being held back by infrastructure from Sydney Water and Water New South Wales. Just in relation to issues around, say, Windsor Road and properties that could be built around there, are you aware of any works that are being held up that are stopping the construction of more housing in the northwest part of Sydney?
Specifically regarding Windsor Road, I'd take that on notice. Whether there's any particular works, I'll have to take that on notice.
Okay.
I'd say broadly, we have a $9 billion capital program to service growth, $13 billion all up, and certainly focused on delivering that, and we're on track to deliver $3 billion of investment this year. So broadly, we certainly have, I think, the investment we need to service growth. With specific issues, I'd have to take on notice.
Okay. So, just in relation to the Northwest, has the Minister asked you to, examine and look at what potential hold-ups there are in relation to the release of land for housing?
I've had no specific requests regarding in any of our growth areas at this point in time from the Minister, but it's clear the Minister certainly made it clear, as the government has, that housing is a priority. And that's something that we're certainly focusing on, making sure we can work with the government and local council and developers to release as much housing as possible.
So there's Modern Proprietary Limited. There's a Sydney Water reference 181938. They're awaiting connection to Sydney Water and wastewater networks. That hasn't been raised with you?
No.
No, okay. Is Sydney Water able to exercise their right of access under the Sydney Water Act 1994 if a landholder is refusing to connect adjacent blocks to the network, and that is the hold-up for releasing further land?
My understanding is broadly yes, but I have to confirm that. Certainly, I'd say I understand that our approach is always to try and work with landholders in the first instance to try and come to an agreement. And the exercising of the Act to allow access is always the thing that we do as a last resort, rather than trying to get to agreement. Specifically, in that circumstance, I'd have to confirm.
How long does it take before you exercise the rights available to you under that Act?
Look, as you'd appreciate, this is my third week in the chair, so I can't talk historically to what has been done. And clearly, the context matters about the issue that's being spoken about. So I'm not sure I can give you a general answer in all circumstances. As I said, the general approach is to try and work with all of our stakeholders to come to agreement, and in most cases, we can.
All right. Well, maybe after your first month in the job, I'll come back to you with some other questions about that. Just in relation to the Western Sydney River swimming spots, can you confirm if the government's formally considered the 22 river spots that Business Western Sydney has in the Our Rivers report? Is anybody familiar with that? Ms. Jones, I think it defaults to you when circumstances where nobody's jumping to answer my question.
I think the Department of Planning probably has been involved in considering the Places to Swim. They run the Places to Swim program, and so I would assume that those spots might have been considered by them.
Okay. In circumstances where the Planning Department has carriage of that, surely they would be consulting with your department in relation to issues around access. Well, actually, to be honest,
not necessarily. They can be working with local councils like Parramatta Council as well, or Penrith Council. Yeah.
All right. Well, I might save those questions then for Thursday when we have planning here. How many developments across Sydney are currently unable to obtain a Section 73 compliance certificate?
How many developers are unable to?
Yes.
So
due to unresolved issues with Sydney Water.
Due to unresolved issues with Sydney Water, I think we're. Look, I'll take on notice the issues. There are, as you know, I'm aware of some areas where we are working with developers, particularly around the Greater Macarthur area, that infrastructure does need to be delivered, obviously given it's very remote. So I'll come back to you with the number of lots that are waiting on that infrastructure.
Okay. Whilst you're coming back to me with those lots, are you able to tell me, on notice potentially, of those, how many are fully constructed and sitting empty because residents cannot legally take occupancy because of the certificates not being issued? Do you know that figure as well?
No, I'd have to take that on notice, yeah.
If you could, that would be much appreciated. Can you provide a list of all developers where Section 73 certificates are overdue?
We can take that on notice. Just to be clear, we have 40,000 applications a year of developments, 80% of which are done within 5 days. So that is, and there can be, in terms of the numbers of inquiries that are overdue, it depends upon the nature of it. And there can be also issues where, for the more complex developments, we are interacting with developer on design issues and strategy issues around how they service developments. So that's important to understand, that there can absolutely be issues that need to rightfully be resolved with developers prior to them connecting.
But you said there was 40,000, but 80% of them are resolved, so that would leave only about 8,000.
Yeah,
per year.
About 8,000 per year. So,
yeah. I mean, I'm sure you can provide a list of those that are overdue.
We can provide a list. I'm just pointing. It might take some time for us to go through and do that. Yes.
No, that's right. We've actually given you extra time, given this return period will be over the holidays. So I'm sure you can certainly provide that list. What is the average processing time for the Section 73 certificate?
Look, as I've said, for 80%, they're within 5 days. Where we have the more complex interactions with respect to infrastructure having to be delivered, then we issue notice of requirements. The median time was 133 days.
133 days.
In June of this year. That's right.
Right. How many staff do you have allocated in the Section 73 assessment area? And has that number changed since March 2023?
I'll take that on notice.
Thank you. What's the longest outstanding Section 73 certificate that you have currently?
I'll take that on notice.
Thank you. How many project completion packages have been submitted but not yet assessed?
Again, take that on notice.
Thank you. How many projects are currently experiencing delays because Sydney Water has requested redesigns or resubmissions of water mains or infrastructure plans?
Take it on notice.
Thank you very much. Now, I will turn back to issues of Wilcannia Weir. Now, the Minister indicated that 70 million was the last cost that I think the Minister... when we addressed this earlier, the Minister indicated, I think, a figure of $70 million. The Minister has also said a further $30 to $40 million was needed to achieve the design the community wanted. So, in terms of Wilcannia Weir now, are you able to provide what a cost would be for the people of New South Wales if we were to deliver it?
So just to recap, the Minister this morning, I think, said that the current forecast estimate for the community preferred solution is between 130 and 140 million dollars. I think she also confirmed that the state has about 70 million available. Some of that has already been spent.
Yes.
The preferred option that was considered following the EIS process that the department has worked on is around $77 million. And the current situation is that the Minister has written to the Commonwealth Minister asking would the Commonwealth provide any additional funding to bridge that gap.
Right. So, is it fair to say that there is a budget within the New South Wales, there is an allocation within the New South Wales budget for Wilcannia Weir, and that is around $70 million?
That's roughly correct, yes.
Okay, which line item would that be sitting in?
I'm not sure that it's in a line item so much as it's rolled up probably in program reporting for Safe and Secure Water program.
Okay, so it doesn't have a specific line item, it's just captured in the Safe and Secure.
I'd have to take on notice if it has a specific line item. I doubt that. I think it's probably rolled up in program reporting.
Okay, but it is in the budget?
We have the allocation for the Weir, yes.
Okay. How much has been spent since it was announced in 2018?
About $23 million.
$23 million. And is that $23 million included in the $70 million that's, or is it an addition, $70 million is in addition to what's already been spent?
It's included in the 70 at the moment.
Okay. Yeah. How much funding has the Commonwealth already committed to? Do you know?
The Commonwealth had committed to, I'd have to check the figure, I think it was about
15 million?
15, yeah.
And how much of that has been spent?
The Commonwealth has not paid 7 million of that 15.
Okay, so they have paid 8, is that right?
Correct.
Okay. And is that 8 included in the 23? Or is that additional?
It's included in the, I think it's included in 23. I'll have to take that on notice. Yeah.
Okay. Has and when did the New South Wales Government request the additional funding from the Commonwealth Government to complete Wilcannia Weir?
I believe the Minister wrote to her colleague in Canberra, I think, last month, in November.
Last month, okay. And has there been an indication yet from the Commonwealth Government as to they're going to stump up the funds?
I'm not sure about that.
Not sure, okay. Do you know how much we asked for? Or is that a state secret like everything else that the Minister asked for the federal government?
I would have to check what was actually in the letter, but I think the position is that the state has a limited budget and the Commonwealth would be being asked to make up the rest of the funding.
Okay, so presumably if the community requirement, or the plan, if the government was going to implement the plan that the community wants, and it's somewhere around the $140 million, and the government's got 70 on the books, one could reasonably expect that they're asking between $60 and $70 million from the Commonwealth Government?
Potentially, although there is an issue of a redesign having to be tested through an EIS and be able to be actually approved. There is a concern with the community preferred option that it might not be able to be approved in that actual form.
Which is a beautiful segue, I might say, for in my next question, which is, what will the environmental offsets cost? And where is that budget?
So that depends what's constructed, and they're aquatic offsets, so it's a matter of fisheries policy.
Okay. The Commonwealth Government, I'm sure, will be extremely quick in providing us an answer in the funds. Have they given us an indication as to how quick they'll be?
I'd have to follow that up.
Okay. In the time that I tabled some photos and asked the Minister about the Narrandera issue with the water, has the Minister gone away, considered the matter of doing something for Narrandera, and has any work been done in relation to helping out our good friends in Narrandera?
So the department is already assisting Narrandera with operational support, which is something our agency does. And we are also looking at developing a business case to assist in the upgrade for the treatment plant.
Okay. The Minister spoke about magic water, and I didn't get to finish the answer in relation to the issues around Wagga. But in circumstances where there's 14,000...
it's 14 gigalitres.
Yes.
Megalitres, sorry.
Being taken out of the general security allocation. The question really is who's paying for it?
So there's a couple of points there. As the Minister said, this spell is available to the local water utility, but only to be drawn on in the case of a crisis where the aquifer providing water for Wagga is unable to provide water.
Yep.
I should point out that, just to give you context, there are 2.2 million shares in the Murrumbidgee, and this spell for PFAS only equates to 0.6% of those shares.
Mm-hmm.
It is would be a situation dependent as to whether general water security users were affected at all. It would depend on how much water was available. So there's a few things there. As the Minister said, this is a break glass option, should it be needed. And if there was an impact on general water security water users, is actually going to be a matter of circumstances at that time. And as you can see, it's a very, very low percentage of the actual total shares in Murrumbidgee.
Be that as it may, I think there is some concern in relation to the fact that where the federal government has, I guess, accepted responsibility for these matters, in other jurisdictions they have purchased the water as opposed to taking the water. And that's, I think, where some of the stakeholders have raised concerns with us that this is certainly an issue. Has the Minister sought to ask the Commonwealth Government to purchase that allocation so that there's not a take out of the general security area?
So the circumstance is hypothetical. The Minister's not asked to do that, and the Department of Defence is looking at remediating, or not just looking at, is working on remediating the site that's caused to the contamination.
Fair enough. Narrabri is currently on level 3 water restrictions with summer just beginning. Has the Shire received the $4 million in funding for a mobile temporary water plant for the PFAS in their bores?
It hasn't received the funding yet. The funding has been approved.
Okay.
Our department has worked closely with the council to assist them in being able to make sure that their water is safe, and we're continuing to do that.
Okay. When can they expect that funding?
I'd have to take that on notice.
Okay. Once the funding's received, how long would it take to have the temporary water plant up and running?
So that will be a matter of how what the council selects in terms of the provider for the plant.
Yep.
But that should be achievable within months. There would potentially also need to be some distribution network, but it depends on the option the council prefers, really.
Okay. In her media release on the 10th of November, the Minister said work had started on finding alternative PFAS-free bore sites, and this funding will support that work. Does that mean the $4 million is both a temporary water filtration plant and the initial work on alternative bore sites, or is there additional funding for the work the Minister referred to?
No, it's all part of the $4 million. So the work to find additional bores is already underway. The department also funded an upgrade to pumps in place, and that's been put in place. And so, yeah, we've been actively managing the situation with the council, with the local water utility.
Okay. I'm just seeing if I had any other further questions for you. Susan, do you have any you want to jump in?
Yeah, I just have a quick question for Ms Wood, if I may. I understand that you've been in conversation with the Shepherd Centre, and I'm just wondering where the decision making is at, what the timeline is, so that they're keen to get an understanding and to be able to plan.
Thank you, Ms Carter. I personally haven't been in conversations with the Shepherd Centre, but our
Okay.
Chief Allied Health Officer has been. We're currently looking at the information that we've just received from the Shepherd Centre around their costings for service provision to work out what we can do for future years' budget. So that is well underway.
And when you say currently looking, when might they expect an answer?
Well, I think it relates to next year's budget, Ms Carter, so I'm not sure the timing exactly.
Okay, so in terms of they should think about an answer received in the next year's budget.
Well, we're working through it at the moment, so I don't have a
Right.
timeline. I can
Okay.
take it on notice.
Right, thank you.
Sure.
Be great, thanks.
My first question's for Ms Pearce, and then I've got a few for Mr Griffiths if you wanted to make your way to the towards the hot seat. Ms Pearce,
don't call it the hot seat. Scare them.
the government announced in August the new position of Chief Midwife, which was one of the recommendations of the birth trauma inquiry.
Yes.
What's the status of recruitment for that role?
We're currently out for recruitment to the role, aren't we, Richard?
Yeah,
Or about to be. We are.
we are. We're
Yes.
out to recruitment at the moment. The role closes this week. We anticipate interviews to be held the week commencing the 12th of January.
Okay. And what's the expected commencement of the new role?
Well, it'll depend on the successful applicant and in respect of any notice periods and the like, but as soon as possible, insofar as we're concerned, we're very keen to get that position started.
Okay, great. Thank you very much. Mr Griffiths, I have some questions about the employment arrangements for medical officers, Public Health Service Policy Directive and procedures. So my questions are particularly around fatigue. So it's my understanding that under that policy, the maximum consecutive rostered hours is 14, but the policy itself doesn't refer to unrostered overtime. And it's my understanding, speaking to junior doctors, that things have substantially improved in recent years in terms of their claims for overtime being paid, which is excellent. Why is it that overtime is then not counted towards maximum hours in terms of fatigue prevention?
So you're correct in your observation. We've done quite a bit of work in terms of improving payment of unrostered overtime. It was part of a 10-point plan to improve JMO wellbeing. In terms of why it doesn't count, I might need to take that on notice, but I will just say we're in discussions with ASMOF at the moment around some fatigue management. So those discussions at the moment are underway, and that will address some of those issues around safe hours and gaps between shifts.
Thank you. I appreciate you've just taken that on notice. Because my own observation was that it shouldn't matter whether the overtime was rostered or not in terms of its contribution to fatigue and the risk to work health and safety and patient safety that then comes from that. My follow-up question is if someone is working overtime on a regular basis, if there's a role that clearly is requiring significant overtime and you would know that because the overtime's now being paid, is there any monitoring to then follow up whether that overtime should then become rostered or the role should be changed?
Yeah, again, you're talking specifically medical?
Yes.
Yeah. So the answer to that's yes, it is monitored, and yes, there is processes to look at the workforce levels within that particular area. The challenge, of course, is whether there's supply, and all of those are very pragmatically taken into account in terms of whether we can lift workforce in those particular areas and supply the workforce that would be necessary. I can assure you that DMS's Directors of Medical Services are very heightened about JMO fatigue and wellbeing, and while we've got some practical challenges at times around some supply, that it is an area of focus and concern for the Directors of Medical Services.
Thank you. Look, I'm pleased to hear that it's a focus area for the team. In terms of that argument that there might not be supply to fill the roster without the overtime, is there any modelling or testing to underpin that argument? Are there examples of places where positions are advertised and they're vacant, for example?
I'd probably have to take that on notice to give you some specifics.
Thank you. While I'm with you, Mr Griffiths, I had some questions about use of locums. and I've asked about this previously. So I understand that in 2024 there were 59 different medical locum agencies contracted by New South Wales Health. When I asked about this in August, you confirmed that there were 62 agencies on the register, and based on the New South Wales Health website, we're now up to 64. Given the work that's underway, with my enthusiastic support to bring the management of that contingent workforce in-house, why is the number of external locum agencies being contracted actually increasing?
Well, I think with the market as it was, I think there was opportunistic suppliers seeing a gap in the market and wanting to tap into some of that market share. We're very open in terms of communicating with the market around where we're headed in terms of the locum work. If we have access to suppliers that meet the standards under our policy, we of course will welcome them and welcome them in terms of supplying staff in the meantime until we get our internal service up and running. That's slated to go live mid-2027, so we're in the design and building process at the moment. But in the meantime, if we've got agencies who meet those minimum standards and are prepared to supply at the prices that we require, then we will take their staff.
Okay. And have you got an updated figure for the last financial year of what the total costs were on the agency commission fees?
I do. If you bear with me, if I can take it on notice, but I'll come back to you this afternoon with an answer. I've got it here. I'll just find it.
That's no problem. Thank you. Dr. Flynn's still at the table. I might come back to him with a couple of things from this morning. There were two things that we cut short this morning. The first one was you were talking about the triage processes being revised. It was in the context of my question to the Minister about changes to the mental health line. Could you elaborate further on that revision of the triage process and what that's for?
Yes, thanks, Dr. Con. So the triage policy for New South Wales Health clinicians is being revised, and that process is expected to be complete approximately somewhere between February and April of next year. We are, as mentioned this morning, making sure that our partners in the delivery of the new single front door, or Connect MH, are aware of the importance of this revised instrument, so that we're trying to make sure that the timelines match. As the policies revised, that can be sort of, lined up with the software build for the new system. I think you would be already familiar. The plan is to use the IAR DST tool, which is a standardised instrument that is used for first contact for people with mental ill health or psychological distress, and then there's an urgency rating scale then that's applied by the districts, and that urgency rating scale is where the New South Wales Health policy comes in.
Mr. Flynn, you might have to bring the microphone a little bit closer because it will struggle to pick you up when it's sort of...
How's that?
That's
Mr.
better.
Fang, is that good? Yep.
Yes.
Yep.
I can hear you,
Good.
Dr. Flynn. Thanks. Can you just explain a bit further in practice how this will work? And I'll put the problem to you that's been put to me, which is these sort of mental health line, single front door sorts of ideas. So someone can ring one of those programs, be assessed, be triaged, potentially be referred to a local community mental health service, where their first phone call from that service is then also an assessment and a triage process. So you've ended up with two qualified clinicians. The patients had to then tell their story twice, and they still haven't received any care or support yet. This is still just an assessment or a triage process. So my question is really around where things are going in terms of being able to be integrated or streamlined so that this doesn't keep happening.
To be really specific, a major part of our work in partnership with the districts will be encouraging their clinicians to trust and utilise the assessment that's already happened. It is, and I suspect you're well aware of this clinical reflex that clinicians have, which is to sort of make sure they've got the story right for themselves. there's an element of safe practice in doing that, but we really want to make sure that the bulk of the information is collected at the first single point of contact, and that rather than set up a sort of duplicated local intake, that this service can provide the team with the information they need to get going in terms of somebody's care. And I think you'd be familiar with trying to balancing that out against, clinicians' often natural instinct to try and make sure they're not missing something. But I really think we need to think about what that means for people who are distressed and try to minimise, that process that is very difficult.
Absolutely.
Yeah.
As you've accurately predicted, I was trained to always start again from the beginning.
Yep.
Not only for good clinical practice, but particularly in a really heightened medical legal context.
Yes.
What support will you provide for clinicians following that new system where if there is an adverse outcome because they've trusted somebody else's initial assessment, will New South Wales Health then back them in because you're the ones instructing them to do that?
I think there's a couple of parts to that question. I might answer the last one first, which is our mental health clinicians, like all of our clinicians, make difficult decisions all the time with the information that they've got, and health will always support people who have done the job to the best of their ability and documented that. And that is, when we talk about the poor outcomes that can happen sometimes in mental health care, usually there is also a clinician involved who's done their very best to ensure that that didn't happen. So we do need, our clinicians should expect that if they do their role to the best of their ability, they will be supported. I do think that it's not just an issue with the mental health one, it's an issue for all of us in complex health systems, the extent to which we need to accept certain information as given before another clinical assessment happens. And, for that reason, a ED physician does not take the, 50 minutes that they might have been trained on originally to assess someone with, a clinical condition. They have to accept certain information and really focus on what they need to know to manage. And the same thing happens in mental health. We can accept some things, but there are some things that the clinician will need to check, and we will support people with training and supervision and policy support around that work.
This morning we also touched on the eating disorder coordinator position at Albury-Wodonga. Were you able to update further on that?
Dr. Connor can update on that, with thanks to colleagues who provided this information. I was inaccurate this morning when I was aware there was a letter that went from Minister Jackson around co-funding of the eating disorder position at Albury. That position has actually now been funded entirely by Albury-Wodonga. But the important thing around that is that that position works in partnership with particularly the Murrumbidgee Local Health District Eating Disorder Coordinator. It's not called an eating disorder coordinator. There is someone in this role who is an expert in helping Albury locals to navigate the system. But the term is the Early Integration and Interventional Lead.
Okay. Is that a position or advice that can be accessed by a member of the public or a patient or their families directly?
I don't know exactly the nature of how that service is delivered within Albury-Wodonga, but I suspect it's a bit of both. If it's similar to eating disorder coordinators who largely help other clinicians, but certainly do get to know some consumers quite well and can sometimes help them navigate and problem solve. And I think by definition, if we're talking about care navigation, that means that a member of the public is likely to be able to access them. But I really can't speak for Albury-Wodonga Health in the sense that it's a Victorian government clinical service.
I've heard that before. My last question for you, Dr. Flynn, in community mental health teams, which, it's my understanding that broadly they're enormously under the pump. They're trying to care for far more people than they're able to easily. What do you see as an ideal staff to patient ratio, specifically for psychiatrists?
Yeah.
How many people should each psychiatrist have under their care to ensure that that's actually being done safely?
Yeah. Look, it's a reasonable question. I don't think there's an answer that will accurately reflect the different sorts of work that different community teams do. So if I'm working in an adult community team, then that might mean that I am involved more frequently with a lesser number of consumers. If you work, as I do, in a rural local health district doing older person psychiatry, I tend to see people who have already been seen by the team rely on a fair bit of the information, but then, essentially the team choose who needs to be reviewed. We're really cautious around the notion of ratios because not everybody who's referred to a community mental health team needs to see a psychiatrist. And the other thing we're really trying very hard to do is to equip all of our clinical staff, so our nursing staff, allied health staff, junior and senior medical staff, with a greater degree of autonomy around their clinical practice and their ability to delegate, so that the whole community gets the full value of this workforce's training. So that might mean that it is actually not necessarily required for a psychiatrist to see everybody if they're happy that the case manager is confident and the consumer's confident that that is not necessarily required. So,
I'm aware of at least one location where the workforce situation has meant that no patients are actually seeing the psychiatrist directly. They've limited psychiatrists only to secondary consultation to support existing staff.
Yeah.
Surely there are still patients who are complex enough in any community mental health service that they should be able to see the psychiatrist directly if they need to.
Because of that very issue, so we are concerned about that and we agree with you. There's one silver lining from what's been a very tough year in New South Wales psychiatry and mental health circles, which is the virtual psychiatry hub. So that actually means that there is a cohort of psychiatrists now who can see anybody across the state for any team that is in the situation that you describe. So we'd be keen to hear about that team and if we can assist them with the virtual psychiatry hub. Because that's, we recognise that it's difficult to, distribute the resources. Yeah.
In my last few minutes, I might come to Ms. Black. At last estimates, I asked about the safe work notice that the Commission had received, and you provided an update on some of the workplace culture improvements that were underway. Can you speak to the progress of that work since our last hearing?
So they were the original WorkSafe notices that you got an update on?
That's right. So the 3 improvement notices, particularly psychosocial hazards.
Yeah. So that was closed in June of 2024, before I arrived. But during the 12 months that I have been here, we've engaged in a really significant cultural program with the staff, which has included facilitated workshops over an 18-month period. So that's still going on as we speak. A leadership development program to ensure capability building of our leadership group, which has also included some coaching of leadership and executive staff. We work with staff to identify 2 key issues, which were psychosocial safety and enacting a vision and purpose for the Commission. Some of the commentary was around not having a clear purpose and understanding the role of the Commission. So we've worked with staff around a psychosocial safety working group and a vision and purpose working group to make improvements and feed into our PMES action plan. We've developed a new vision and purpose for the Commission, and that includes a clear vision for our work and strategic actions that will guide our work over the next 5 years.
You mentioned at the start of your answer the facilitated workshops. Was that to do with the vision and purpose of the Commission, or was that for a different subject?
No, that was to do with the culture, to build our culture and to work with the staff around, what that would look like and what that would take. And that's still work in progress because as I'm sure you appreciate, culture doesn't change overnight. It
Absolutely.
takes some
That's why I
time.
ask for an update each time I see you. So what are the actions that have arisen out of that workshop, or what changes have been identified moving forward?
We've focused on ways of working and ways of being with each other. But two of the actions that were identified were that we needed to focus on psychosocial safety and vision and purpose. So the one action that's complete is actually having a strategic plan for the internal purpose of the Commission. We're almost at the end of the short-term psychosocial safety group, and we've got a list of key psychosocial risks, and we've got actions against those, and we're working our way through those.
And following on from the passage of the Suicide Prevention Act, you've obviously taken on a big part of responsibility for that. How has that changed the way that the Commission's working?
So we have been through a realignment process to ensure that we're best positioned to be able to do that work for the people of New South Wales, really important work for the people of New South Wales. And so we've created separate teams to actually drive the key pieces of work, which for us now are the mental health and wellbeing strategy and the suicide prevention work.
Thank you. I'm out of time. We'll go back to the opposition.
We can let water go if you can let water go.
I'll double check
Yeah,
while you ask
okay.
your questions.
Sure. Perhaps, Ms Larkin, if you're available, I might start with you. Thank you. At the previous budget estimates, we were asking Mr D'Amato a number of questions. You may have seen the transcript. He didn't have the level of detail that we were looking, so I'm hoping you'll be able to assist. The initial budget allocation for 25-26 for Blacktown Mount Druitt Hospital is just over $514 million, I believe.
Mhm.
That's correct?
Correct.
Okay, and the allocation for Blacktown Mount Druitt was over $598 million in 2024-25. So can you explain to us why there's an $89 million decrease this financial year in the initial budget allocation?
I believe that the Director of Finance, Alpha, gave some detail around how the budget was allocated.
What he did, I think, from memory, is offered theories as to how that would happen, but that's why I'm hoping you could tell us exactly why the decrease in budget allocation in your LHD.
Yeah, can I just refer to Alpha on this one in that regard? When I say that,
sorry.
No.
Am I hearing that you can't answer this question?
It's not that I can't answer it. I've been in Western Sydney since June of 2025, and I've been working through the details of a very significant and large budget for Western Sydney. There were some changes in terms of how that budget was allocated this year, and that's something that the Director of Finance and I have been working through. That would be good for Alpha to actually talk to with us, yes.
Okay, great, yep. I'm just a little perplexed because these are the questions I asked last time,
Yes,
so,
no.
but I'm keen to get the answers.
Sorry, if you don't mind. So the answer is very simple. As I mentioned last time, that my suspicion was that we are
Sorry,
missing-
I'm struggling to hear you. I apologise.
Sorry. Is it better?
Yes, thank you.
Okay. So as I mentioned last time, I suspected that they made some changes in technical.
I guess this is what
yeah.
I'm looking for. You
The
had
techni-
theories as to why that might have
so
happened.
we
You can
investigated.
answer
We
it for us.
investigated this, and I'm about to answer the question.
you.
The question
Yep,
is
thank
that the original approach was developed on a fully absorbed methodology, which means
Sorry, what does fully absorbed mean?
Fully absorbed methodology.
Means what, sorry?
Fully absorbed methodology.
No, what is it?
What does
just
fully
about to
absorbed
describe what it
methodology
is,
mean,
which
what I'm
means the
asking.
full cost of the overheads of the district were fully
Yes.
allocated to each individual hospital.
Yes.
Yeah? So therefore, all of the overheads to run the district were also incorporated into the local budgets for Blacktown Mount Druitt. The previous methodology didn't include that, and so as a result, there is a change. So what we did ask them...
Sorry, just if I can go a bit slowly so I
Yeah,
really
sorry.
understand you. So you're saying the reason for what looks like a decrease in funding is a change in methodology.
Correct.
And what was the reason for the change in that methodology?
Look, there was a local decision. The districts tend to have approached this slightly differently, but there was a local decision made to fully...
And what was the reasoning for that local decision?
Look, it wasn't my decision. My
Who can help us answer that question?
So in conjunction with the Director of Finance, in terms of how we were allocating the budgets across the district, and as I indicated, I had just arrived,
Yes.
in the district in relation to that allocation with the Director of Finance. Those changes were made. Yes.
Why?
In terms of a better presentation in relation to what was actually the budget for Blacktown,
Okay.
and the resources that were required to deliver services in that area.
And so
Yep.
is it possible on notice to provide us with a like-for-like figure adjusting for the different methods of
sure.
calculation?
Yeah, absolutely.
Yeah, we can.
Okay.
Yeah.
That'd be great. Thank you very
But
much.
I think, Mrs Cutter, it's important to note there has been no reduction in funding to Western Sydney.
Well, and I guess
At
this is
all.
exactly what we're trying to,
In
to
fact,
actually
there has
see.
been an increase in a budget this year
Mm-hmm.
compared to last year to Western Sydney Local Health District.
And look, to be honest, that's exactly why I'm hoping to get that
Thank you.
like-for-like
Yeah, no, we'd be
comparison so
very
we
happy
can
to
see
provide
that.
it because it got a
Yes.
significant budget uplift
Yes.
in this financial year.
And at first glance, without an explanation of the different method of calculation, it looked actually like a significant decrease, which is what was
we can
concerning for us.
categorically confirm to the committee that there has been no decrease in the budget for
Great.
Western
And
Sydney
I
Local
look
Health
forward to
District.
getting the figures that make that very clear.
Yeah.
And so is that the same reason for the explanation why the FTE budget for Blacktown Mount Druitt appears to have been reduced in 25-26?
That's correct.
Okay, and can you produce like-for-like figures so we can
Yep,
just track
absolutely.
exactly?
And we also updated the information on the website to provide further explanations why the two figures cannot be compared year on year because
Okay.
of the change in methodology.
Did this happen for any other LHDs in terms of... Okay.
No, this was a bit of an outlier, and we only identified this recently. All other districts tend to use the same methodology, which is a direct budget allocation.
Okay, thank you. Car parking. Can you explain why car parking revenue for the LHD rose from $11 million in 2024 to $17.6 million in 2025? Ms. Larkin?
In relation to my understanding, is that between 2023 and 24 there was a proportion
So I'm
of that
looking at the 2024 to 2025 figure, from the 11 million to the 17.6
No,
million.
You did ask for a comparison to the previous year, didn't you?
For the 24 to the 25?
Yeah.
Yep. So I'm just saying from 2024 to 25, the difference is in terms of the proportion of allocations that came in for staff car parking fees, and then there was a full allocation in 2025 is my understanding.
So what do you mean by allocation?
Well, I think, Mrs Cutter, if I might just add
Sorry.
here, sorry, I did clarify this in broad terms prior to the lunch break around car parking, and the same applies here, that there have been a combination of factors. One, that in the 23-24 year, which is being compared to 24-25, in that previous year, 7 months of the 12, our staff were still getting free car parking as a consequence of the pandemic.
So sorry, if we can just go through
So
this
we're
slowly.
apples and oranges.
I'm just trying to understand this.
Yeah, no, happy to.
Yeah.
So 23,
no, sorry, if
yeah.
we can just,
Yep.
so I understand that bit. So
Yep.
when you're talking about partial allocation, proportional allocation, we're talking about
That's right.
And so what we're really saying is that staff was still getting concessional parking for part of the 23-24.
That's free parking.
Free,
Correct, yeah.
but now staff are paying for parking. So
Still heavily discounted, but
Yeah,
yes,
but-
it's returned
but-
to pre-pandemic
so-
arrangements.
But
yeah.
I understand and I recognise and I would advocate for the discount for staff parking. Western Sydney, we're talking about more than $6 million increase in revenue year on year. So that $6 million is coming from parking paid for by nurses. Is that right?
So I think there were a combination of factors, which I also outlined. So
we're talking about parking paid for by nurses, and the other factors are?
The increasing parking spaces.
Okay.
And a
which-
CPI
sorry,
increase
in terms of
to
increasing
parking
parking
rates.
spaces, do we have the list of where increased parking spaces have been provided?
I have the list across the state, yes, and that is being provided.
Through each LHD?
Yes.
Okay. Has there been additional parking in each LHD?
No, it's spread across a number of LHDs. It depends
Okay,
which
so
year.
which LHDs have there been an increase in parking spaces?
It depends which year. If you're looking only
No,
at
24, 25. If part of the reason for this, what looks on paper to be a huge increase in revenue from parking, if part of that is increased parking spaces, well, exactly where are those parking spaces in the last budget year? So how many more at Westmead, for example?
Westmead, we didn't have any Westmead, but just
so
need to
therefore,
just
all
need
right,
to confirm. But
other
can I
places
just
in Western Sydney, how many
Mrs.
more?
Carter, could you just allow Minister D'Amato to answer the question, please?
I just want to
it's not just
answers, but it seems
There
to
are-
be global, and I'm asking for particular, and I've asked
well,
all
the
morning for
particular,
particular.
I guess the particular answer that
Water. I believe these witnesses have taken a large part of this question on notice, but I am also just concerned around procedural fairness for them being able to actually answer a question, and they're continually interrupted. So,
And to the point of order, I've asked for specifics, and I'm being told general, and
I think they've taken the details on notice, though.
Yeah, to the point of order, I mean, the member is entitled to ask for specific information. The witnesses are also able to take that on notice if they don't have that information
to clarify, can you now provide us with the hospital by hospital increase in parking spaces?
can I take it on notice?
Yes, when could you be able to provide that, do you think?
I need to just check with the team. But the part I would like to stress one more time
I
is
guess
that when
the
you
challenge
compare,
I have
yes,
is we're being told that part of the reason for the huge uplift in car parking revenue is increased spaces. And then we're being told, but we can't tell you where the spaces are. So it's difficult to reconcile these two pieces of information.
Ms. Carter, if I can just make a comment. In regards to the significant addition of car spaces, there's been around 4,000 car spaces added over the course of the years. However, if we look back at the 1819, which effectively was the only financial
So no, we're comparing 2023, 24 to 24, 25.
And as we mentioned several times, you can't compare it because there's only part year in the 23, 24. So once we adjust for that.
Excuse me, Mr. D'Amato, Ms. Pearce said that there were multiple reasons, one of which was the change in charging nurses, another of which is the addition of car parking spaces. And so we're exploring all of these reasons.
That's fine.
Could I just seek to clarify a couple of points just on this matter? This morning when we asked the Minister about the story that was published in the Telegraph this morning about the increase in parking, the Minister clearly articulated that that was because the number of parking spaces available had increased. I contended that it was actually because we were now charging nurses for parking at hospitals, and that was likely to be the increase. Did the Minister, on seeing the article this morning, ask the department for any advice as to why parking had increased, the parking revenue had increased, and was the advice given to the Minister that it was a number of parks that had increased, or was the advice given to the Minister that the nurses are being charged for parking was the reason for the increase?
Mr. Fang, I know that I don't need to remind everyone here, we are under oath in this hearing. We are speaking the truth, and of course we provide our Minister with advice, and it is the same advice as we have provided this committee. You're asking us for the specific details, Ms. Carter. I completely understand why you're asking for that. We are very happy to provide you a detailed list of the increase in car parking spaces that have contributed to this revenue figure that you're quoting. We have also stated very clearly, and you are referring to nurses, it is, that these parking arrangements apply across the board in our health system. Except for the regional, as Minister Jackson outlined this morning. There is a CPI increase associated with car parking, which is very, in the grand scheme of things, it is a very small figure. It has gone up by around $5 per week since 1819. So car parking charges are not a new concept in health. They have been occurring for many years. They were occurring prior to the pandemic, and the reason that they were altered during that period obviously was the burden on our health system during the pandemic. That went on for quite a long time. We were then receiving complaints from carers and patients because they couldn't park in our... I'm sorry, I think that this does, you have spent a lot of time on this topic, and I think I should be entitled to provide a thorough
And Ms.
response.
Pearce, I wasn't seeking to.
You are comparing the 23-24 year to 24-25. And my response to you is that you are comparing two periods where they are unequal with respect to free parking for more than half of the former year. So there is a genuine reason why there is an uplift in addition to the parking spaces.
For visitors, it was only free parking for the staff. Is that correct? So it's only the staff that are now paying that weren't paying previously.
The staff were paying previously, Mr. Fang. Of course they were.
I'm talking about in 23-24. The free parking only existed for nurses, cleaning staff, etc. It didn't. It's when the government reintroduced staff paid parking that the figures shot up. Is that correct?
What I'm saying to you is that you have two. We're comparing two periods.
I appreciate that.
One period was for the great part of the year, free parking for staff. What we saw in our car parks during that time was a lot of staff parking in them, understandably, because it was free. We received complaints, and I understand Minister's offices also received complaints from constituents that they couldn't find a car park in a hospital car park because they were occupied by staff. So that balancing act for us is important. What I'm trying to describe to you is that if you're comparing 1 year where for 7 months of the year the staff were getting free parking to the next year where they, for the full year, they weren't, it's not an equal comparison. So naturally, yes, there will be an uplift in those numbers. In addition, there are more car parking spaces that contribute to that calculation, and then there's the CPI increase. So it's a combination of those things.
So I just want to confirm the three factors are staff paying who previously were not.
No. Well, except for.
Sorry.
Can I just clarify?
As a year-to-year comparison.
Yes.
The free period of parking for staff ending during the previous year, additional increase in parking spaces. Are you able to provide those figures later today, or any figures that you have?
So I can confirm the additional car spaces where Southeastern Sydney...
it's just simply a question. Can you provide the list for me later today?
We will take that on notice. We'll try to get back to you this afternoon on it if we can.
We'd really appreciate it.
If we can give you the clarity that you're looking for. Okay. Otherwise, we will need to take it on notice and respond in the usual way. But I just have to restate my point again.
The third factor is CPI.
Yes, which is...
Are there any other factors that we should be taking into account? I
There's
just want
only
to
one
get the
factor
whole
I want to mention to you.
Sorry, Mr. D'Amato?
There are two factors. Sorry, there's one more factor to take into
Yes.
account. A number of hospitals in the period, a number of car spaces, car parking, in the period where the policy was applicable.
Are you able to bring the microphone a bit closer, please?
Sure. There were two hospitals that were under a concession arrangement whereby effectively we didn't receive revenue. We didn't receive revenue because a third party built the car.
And which
parking.
hospitals were they?
There was St George and Canterbury. So in the period where the policy was applicable, the COVID suspension policy, these arrangements terminated, and as a result, there is now included in our revenue. So there is an extra element. It is purely technical.
No, but it helps to understand these things. If you don't understand it, you don't know. Ms. Larkin, how much did the LHD spend on security services in 2025?
I need to take that on notice.
Okay, it appears again that it's spending less now than it was in 2024 and 2023. Do you have any explanation for why there's been a decrease in expenditure?
There is some work being undertaken to look at trying to bring some of the security work from contract into staff. So there's been some ongoing work around that.
Sorry, so you're saying you're moving from contractors to staff and that's why the spending is decreasing?
Mm-hmm.
What's happening to the actual number of security personnel and hours of security?
Can I take that on notice just to be sure in terms of what the figures are in response to that?
Okay, thank you. And can you also, if you're doing that, take on notice the number of incidents that security have needed to respond to, including knife incidents, particularly at Westmead?
Sure.
Thank you very much. Ms. Larkin, at Westmead Hospital, the median waiting time for non-urgent surgery is 389 days as of the last BHI quarter. But in the March 2023 quarter, it was 276 days. Why are patients now waiting an additional 113 days for surgery at Westmead?
So overall, our approach at Westmead in terms of surgery has been to, and if I can just answer, by June of 2025, we hit 000 in relation to any overtime waits, which was a significant effort in relation to both inpatient work that was undertaken, but also, which was within the hospital, but also we contracted work out. So we are monitoring carefully that work at the moment, and at the right now there are about 385 patients who by the end of December who will be over the wait time. So we are really working to understand what work that we can contract out and get some support to do that work, but also what our footprint is to increase the inpatient surgery component.
So the question was, why are patients waiting 113 days longer now than they were in 2023? I understand what you said is you're doing work on this, but that I don't believe I heard an answer to that question about why there is such a longer wait time now.
There has been an increase in the volume of surgery that Westmeads need to completed, and we need to be sure that we've got the footprint to do the work within the hospitals, and any additional that will work in terms of contracting out to get that work done.
So if I can translate that, you're saying more people are coming to Westmead, therefore waiting times are blowing out?
There has been an increase in terms of volume of work that we've needed to get through.
Does volume mean more people or more complex presentations?
No, more people also.
Thank
yes.
you. And Blacktown Hospital, we've all seen the reports of patients sleeping on the floor in the emergency department. What work's been done to address that?
Significant work has been done both with the CEC, but also internally, and also with the patient experience, the Chief Patient Experience Officer. So that work has been very much targeted at patient experience, the volume, dealing with the volume of patients coming through the emergency department. There have been some specific issues that we've done in relation to patient experience, doing some patient journeys with people, looking at developing our models of care in the emergency department, such as the iGEM, which is aged care. So a range of strategies are in place, and significant focus from the staff and clinicians at Blacktown to address that.
Thank you.
Just before I go to my colleague, Ms. Fairman, the committee has advised that we have no further questions for some of the witnesses who can go. That's Andrew George, Darren Cleary, Amanda Jones and Grant Barnes. Thank you very much for making the time to be here.
I thought you were going to say me.
Sorry, Ms. Pearce, I'm not done with health yet. I'll go to Ms. Fairman.
Oh my God.
Thank you, Chair. I've got some questions for the Far West LHD. Are you...
Could I just note, Ms. Fairman, Mr. Dygraff has just started in the role 2 months ago, so just so you know, he's very new to the role.
Thank you, Mr. Dygraff. Is that the correct pronunciation of your surname?
That's correct, thank you.
Yes?
That's correct,
Sorry,
thank you.
there was a bit of scratching. Thank you. I did want to start, I've got questions about Broken Hill and lead issues. I'm sure, have you been advised that I'd probably ask some questions on that?
I've been so advised, thank you.
Okay. There was a story recently, there's been a couple of stories in the Broken Hill Times about the issues around lead coming from mining activities there. There's a story in the 8th of August that refers to the fact that both the Far West and the Western LHDs said that they would no longer make the lead reports public in the Broken Hill City Council papers. Firstly, are you aware of the lead reports that are being referred to there in terms of the lead reports from the Far West LHD? Have you seen those yourself?
No, I haven't. I'm not aware of those reports.
Okay, let's take a step back then. How is lead publicly reported then in terms of the LHD?
So, noting that I'm new to the district, I'm not aware of how we report lead levels publicly in the Far West. I would need to take that on notice.
So, Ms. Berman, I can probably just indicate that there is no, there's nothing being brought to my attention that the reports that are compiled by, there's a shared public health unit across Far West and Western New South Wales, and there is no intent not to publicly report those in the way that has been usually done. I can call upon Jeremy McAnulty, who can just clarify that.
Thank you. Yes, so the reports continue to be produced by the Public Health Unit on behalf of the district.
Okay, all right. So this article refers to an email from Melissa Welsh, who's still at the Far West Local Health District, isn't she?
That's correct.
Yeah, that asks that the reports attached to the lead reference group's minutes submitted to the council be removed. So just to be clear from your perspective, Dr. McAnulty, they should not have been removed and they'll be included in the future?
Well, I don't know the detail of that particular email, but I do know that the Public Health Unit continue to publish those reports on publicly, do a media release and put them on their website.
Okay. Can I get an update about where the funding, funding for the Be Help program is up to and the continuation of that program?
So we can. I can't talk about the whole of government because EPA.
Yes, but you do
and
take
premiers,
a lead role.
But I can tell you about the New South Wales health component of those. So health is responsible for the blood screening component of the lead program, and in 2025-26, New South Wales Health, which includes both Far West and the Ministry, will provide 571. 739 to the support the program, and EPA will provide 358,000 to support the Miramar program component.
This is, did you say 25-26, Dr. McAnulty?
25-26.
Okay, that's for, okay, so 1 year you said that the New South Wales Health component was 571,000?
That's correct.
And you've got in front of you the EPA's component was?
358,000.
We should just be clear that the EPA provides funding to Miramar.
Yes.
To deliver the program. Yeah. So that there'll be other EPA commitments to funding, but that's particularly funding to Miramar.
So and the 571,000 goes to the LHD.
Yes, to support the district's blood lead testing program and associated parts of that.
That's all for lead testing?
And associated parts, supporting affected communities, families in Far West.
Is that an increase on the previous year or two, or how does that compare to previous years?
I can't tell you that off the top of my head. I'll have to take that on notice.
Okay, so I've got some documents to be handed around if the Secretariat wants to grab them. My poor staff took the liberty of making enough copies, so we won't delay, even though Mr. Donnelly isn't here, and I did it so it wouldn't stop me. So anyway.
Now, Kate.
Well, it's true.
I know. I was on the receiving end.
Okay.
Mate, where's your jacket?
You're not going to because I've got all those copies.
Where's your jacket, mate?
Yes.
Seriously,
Where's
how
your
many
jacket?
times?
So
we'll be writing to the President. Thank you.
I do just want to ask a general question, perhaps either Dr. Chan or Dr. McAnulty, in terms of how you think the Broken Hill District, maybe even you, is it Mr. or Doctor?
It's Mr.
Mr. Dykegraph, about how Broken Hill lead is tracking in the population, in the children. Are you aware? Maybe I'll go to you first.
Indeed, I'm aware of the program across the last number of years. We note that we've got a high level of involvement from our local community and participation from the community in terms of screening for the lead program. And we note that whilst the levels have plateaued in children, there's been a downward trend on that up until the last couple of years in terms of lead levels more broadly.
Okay, and what about efforts? I did just want to, why don't we turn to the first document there, which is an information brief, which, sorry, it's an email in relation to the Broken Hill lead program review. It's from somebody within your section, I think, Dr. McAnulty, or in terms of Health Protection New South Wales.
Yes, Dr. Douglas was acting for me when I was.
Yeah, okay. And Dr. Douglas does say that it is our belief that the level of lead contamination, the ongoing emissions, means that this will be an ongoing health problem and long-term programs need to be implemented. And he also suggests that other initiatives such as broader screening of age and mobile populations be established. Now, at the moment, there's only under 5 screenings for under 5. What's New South Wales Health doing in terms of looking at expanding the screening available for, in terms of blood lead levels in Broken Hill?
So we held an expert panel involving people from Murray, the district, and other experts in lead from around Australia, who concluded that the program was actually working well in terms of screening and had as noted, had a high participation rate and didn't change the target for the screening.
What is that expert panel? Which one's that?
So it was, I've forgotten the exact name, but it was Health's expert panel on Broken Hill.
Like called an expert advisory panel?
Words to that effect.
Is that wrapped up?
That has wrapped up, that's right. That met for about a year or so until the end of last year.
Did you chair that?
I did.
Now, I'm conscious of that document. There's, in fact, I'm conscious of that panel. That panel also looked at issues such as the level of, it did say that there's limited capacity to remediate all children. This is meeting minutes from the 14th of May 24. It did say that there's limited capacity to remediate all children with elevated blood lead levels of 15 micrograms per decilitre and above. Dr. McAnulty, is that a concern for you?
Yes, that is a concern, and EPA has been, I understand EPA, who is responsible for the remediation process, has been looking at how to make that more efficient and more effective.
I'll come back, yeah.
Ms Ludford, thank you for making the time to be before the committee today. I understand from your recent appearance at the LHD AGM that there are no surgical abortion services in the Murrumbidgee LHD. Where are people directed to go when they're seeking a surgical abortion and they live in your LHD?
Thank you very much for the question. We have, of course, our New South Wales Pregnancy Choice Helpline as well as our District Women's Health Service. And together they will advise women based on their address, where their supports are, what is the most appropriate location for them to access that surgical termination of pregnancy. Our Women's Health Service clinicians do follow up women both before and after the procedure to provide that wraparound care for women.
Can you clarify if people are still being sent to the Western Local Health District or not? And I ask because I know that residents were previously advised by the Pregnancy Choices Helpline that patients could go to Orange, but I'm now also advised that Orange is no longer seeing patients from outside of the Western LHD.
Yeah, that's right, and I am aware of one woman who was referred to to the Western New South Wales LHD, to their service in Orange. But our usual referral pathways are actually to Wodonga and also to Canberra and Sydney.
What are you doing to address that inequity? It's obviously not equitable for women living in Murrumbidgee to have to travel interstate for something that could arguably be provided within the LHD.
I absolutely agree with you, and we are absolutely committed to improving the equity for women. The issue that we're facing is that we introduced medical termination of pregnancy quite early with the abortion reform bill, and we've really focused on getting our clinicians working to provide that medical termination of pregnancy, and that service is going really well. We're now focusing on the surgical termination of pregnancy, and the issue that we have faced has been that our 4 specialist obstetricians and gynecologists really have their personal beliefs and values where they'll only provide surgical termination of pregnancy to women who have got complex medical or fetal conditions. But I want to say that we understand now the importance of balancing the rights of clinicians with the rights of women to access care. So we have made a commitment that we will now bring stakeholders together to work on a reproductive health plan that makes our responsibilities clear about how we are going to look to provide a service using an alternative workforce and looking to see where we can provide that. And that's got to be balanced up, of course, with the priorities of the hospital at Wagga.
Thank you. Look, I'm interested, you mentioned the term alternative workforce, so what consideration have you given to bringing people in who could provide the service, noting that there is a legal right for an individual to have a conscientious objection?
Yes, thank you. And I think on the back of the statutory review, of course we're looking at midwives and nurse practitioners, endorsed midwives and nurse practitioners, and we've had a really good response rate to Ms Wood noted earlier about the availability of scholarships. So 7 of our staff have put their hand up, which is really encouraging. But I do also want to talk about GP obstetricians because I think that is also a really, really important opportunity for us. What we are working on is how we can provide that escalation pathway because they will still need the support from specialist obstetricians and gynecologists should something outside of their scope of practice occur. But I do know that we have a number of interested parties who could be credentialed to do work in this space, and we're just engaging with people at the moment. So it is early days, Dr. Con, but I want to assure you it is a priority for us.
Thank you. I'm pleased to hear that reassurance. I have a couple of questions on a different topic for you, Ms Ludford. As I'm sure you're aware, John Stutchbury, a surgeon at Albury-Wodonga Health, recently had his contract terminated by the health service with very short notice. He was one of only 2 providers of public breast cancer surgery at Albury-Wodonga Health. What impact has that had on your services in the Murrumbidgee?
I'm aware of the matter that you are referring to, and obviously breast surgeons are in high demand, and we're extremely fortunate that we have got some really good surgeons available both in Wagga Wagga and also in Griffith. We've got 3 altogether who are doing this work. So at this point in time, we haven't noticed an impact on our own services, but I'd say to you it's probably early days at this stage.
Similarly, the Ramsay Albury-Wodonga Regional Cancer Centre in Albury is changing hands to Albury-Wodonga Health on the 23rd of January, and I understand that there's no transition plan and no guarantee of jobs for staff moving forward. Have you been involved in conversations about that transition, and what availability is there for support for cancer patients in Murrumbidgee LHD if those services aren't available at Albury?
So they'll answer the first part of the question. I haven't really been advised around the transition of that service. Obviously, I have read about it in the media, so I'm aware of it. In terms of capability within our own services, I guess for people who would come from that Albury region, quite a few of those patients may live along the border in the Corowa-Deniliquin area. And we've recently introduced a new service in Deniliquin where we've got capability to do additional work. And also we do our own chemotherapy service in Griffith. And also there's a third-party provider which we contract, the Cancer Care Group, that provides radiotherapy. So I believe there probably would be some capacity to absorb additional patients should they be required.
And just to follow up on that as well, so there's a Premier's award-winning clinical trials unit at the Albury-Wodonga Regional Cancer Centre, and I understand there's been a challenge with short time frames to redo things like ethics approval with the complex governance of clinical trials. I'm aware of some people being transferred to Melbourne to maintain continuity of care. Have there been any conversations with yourself from either Ramsay or Albury-Wodonga Health about maintaining continuity for those patients?
I'll have to take that one on notice because I am not aware of any matters that have been brought to our attention. But I could say we've just got a new medical director in clinical trials. So I will check in with him because, in fact, he came from the Albury-Wodonga system.
Thank you.
Thank you.
Come across quickly to Dr. Morgan, if I can find my sheet. Okay. Just to follow up some previous questions I've asked about infrastructure upgrades, so ambulance station upgrades. I understand that there are a number of new stations opening up on a regular basis, which I see in the news, but where's work up to in terms of addressing existing ambulance sites that are no longer fit for purpose?
Are you specifically referring to ones that we no longer work out of because we've built new ones?
No, I'm referring to ones where you're still working out of, but there's obviously work required. I mean, the one that most commonly comes to my attention is Campsie. I understand there's 36 staff using one toilet.
Sorry, Campsie?
Yeah.
So what I can tell you is Campsie Station has only just reopened as a new, as one of our existing sites where staff begin and end their shift. In terms of the overall budget, we've been provided $3.5 million for minor capital works this financial year. That specific location, whether any of that's been allocated to them, I'd have to take on notice.
I understand that many paramedics are only receiving their 9-week roster a week in advance, although in some areas I hear that there's a level of goodwill that means people get their rosters earlier. What are the barriers from your perspective of being able to give greater notice of rosters?
Thank you. So under the award, that is the award stated time frame. I have been previously asked about the statewide rostering system that we brought in. Literally, we've only just completed it this year. One of their efforts is to put all of those rosters out 2 weeks in advance. Now, this is early days on being able to do that, but it's for exactly the reason that you state. The more notice we can give people, the better. But the correct answer is it's 1 week in accordance with the award.
Similarly, I understand all of the annual leave for the year is typically allocated in June with some goodwill in some areas. What are the barriers to being able to be more flexible?
6,367 staff requiring annual leave is a very complex thing for us to do. You can imagine we need to make sure that our rosters are done in such a way that as far as possible there's an even distribution across the year to ensure that we've actually got paramedics available at peak times, over school holidays and at Christmas time, etc. So they have to plan well ahead. There is no barrier to people applying during the course of the year for leave that may become vacant because another person has swapped. So it is quite dynamic, but you're entirely right. We do have a point where we actually do the statewide rosters, smooth out for service delivery and then make changes throughout the year.
Thank you. The bell has gone so out of time. I think there's a short amount of time for the opposition. Mrs. Connor?
Ms Ludford, if I could come to you. I notice your comments about an alternative workforce. Does that mean that you would be looking to employ people based on their conscientious objections or not to abortion services?
Thank you for your question. It's a delicate subject, as you'll appreciate. On the advice that I have received from my Director of People and Culture, I think if we are employing people to work in reproductive health, if we make it explicit in the position description what reproductive health services people would be providing, people would be obviously applying for roles based on that position description.
So that would exclude people from working in your health district in reproductive services who have a conscientious objection to abortion. Is that consistent with our understanding of the way conscientious objection works?
Look, I think conscientious objection is obviously if somebody is working as a generalist, obstetrician and gynaecologist, and they have a conscientious objection, we absolutely respect that. But we also have to balance that with the rights of women and the rights of women to access services. At the moment, we don't have any surgical termination of pregnancy in the Murrumbidgee Local Health District.
At what week period would a surgical termination normally occur?
From?
Yes.
Yeah, so after 63 days.
Which is, sorry, how many weeks?
9.
Okay.
9 weeks plus 0,
Okay.
yes.
And if there was a woman with a complex pregnancy, is there the capacity to support her the entire way through, or would she be sent to Canberra or Sydney or some other place?
No, just to be clear, our specialist obstetricians and gynaecologists will support women with medical complexities or fetal complexities, absolutely, and are doing so now.
And are there, so for example, are there any other surgical services that are not available or difficult to access in your LHD and for which patients would need to be transferred somewhere else?
We're Wagga Wagga based hospital, I guess. I will just to clarify.
I mean, some examples, neurosurgery.
Yeah, neurosurgery, cardiothoracic, for example, is
would have to
probably
be transferred somewhere else.
Yeah, that's
so,
right.
So it's not unusual in your LHD that there are some surgical services that people have to travel for.
A very small number.
Yes,
that's right.
Yet you're telling me that you would make it a condition of employment that somebody has to be prepared to perform termination services, and so conscientious objectors should not apply. Is that really respecting conscientious objection?
So obviously under the New South Wales government, people who apply for jobs can do so under equal opportunities rights. So people can apply, and there would need to be discussions, I suppose, around the responsibilities of the role.
So would you regard it as a responsibility of the role that would knock out a conscientious objector if they did apply?
That's a question obviously based on a lot of complexities. I'll have to take it on notice because reproductive health is a large service. Surgical termination of pregnancy is only a very small part of that. There's also a lot of other reproductive health services such as menopause and other things. And so I'll take it on notice so I can make sure that I get really good, clear workforce advice. Thank you.
Thank you.
In the short time I've got, Ms Pearce, under the LGBTIQ health strategy, there were 21 projects funded over the last 2 financial years, is my understanding, and some of those were really excellent. As the short-term funding for those projects runs out, is there any work being done to evaluate and then expand or replicate the work where it's been successful?
Look, thanks for raising that issue with us. It is something that's really deeply important to us as part of the work we're doing around diversity and inclusion generally. I'd have to take on notice the specifics, but suffice to say, unless one of my colleagues here can respond, but suffice to say it is something that we'll continue to work on and invest in. We've committed to this work and we will be continuing to commit to it into the future.
Okay. Thank you. I appreciate you've taken that on notice. Similarly, I've previously asked about improving data collection for LGBTQI communities, and that in response, I was advised that was potentially part of the single digital patient record upgrade, that there was the opportunity to do that work. Ms Wood is nodding at me like you want to answer this question.
Yes, sorry, Dr Connor, have been involved with this. So absolutely improving the collection of data is very important. We do have a working group with community representation considering next steps to how we can improve that data collection, and it is working very closely with the single digital patient record, which does commence in March next year. So we've worked very closely with community on that.
Okay. March next year is obviously very soon.
Yes, it is.
Okay. So that working group looking at the LGBTIQ data collection is expected to be completed in time for March?
So it will continue to be an ongoing piece of work, Dr. Con, because I think when we go live in March with the first tranche of single digital patient record, each tranche beyond that will continue to evolve. So it will continue to be looked at and improved as we work through that piece of work with the working group.
Okay, thank you. I have another question about the single digital patient record while I've got you on this topic. It's been raised with me that the current electronic medical record systems can't issue e-scripts, and that's an issue in some contexts. Will the new record be able to produce e-scripts for patients?
I'm going to take that on notice, only because there are a couple of quite complex elements around that, so I will take it on notice.
Dr. Chant, did you were keen to jump in?
There's some particular considerations, and we are doing a piece of work on this. I know that there's been some issues particularly raised around scripts and who can write them. New South Wales and ACT are the two, a state and a territory that is not currently signatory to the pharmacy agreement. We are keen to be part of the pharmacy agreement, and we are working collaboratively with the Commonwealth to work through those issues, because that is one factor that influences who can write them, where they can be transmitted to, and our access for our patients for PBS scripts.
Yeah, so I just want to double check my understanding. So there's a part of this question that's about the technical capability of the software to issue the script. Dr. Chant, you're obviously talking about people's eligibility for writing PBS scripts.
That's right, because currently we're not permitted in many of our settings to write PBS scripts because New South Wales is not a signatory to the pharmacy agreement.
Understood. The separate part of the question was, will the new single digital patient record have the technical capability to do that?
Yeah, I'll
notwithstanding
take
the
that
pharmaceutical.
on notice, Dr. Con, so I'm not sure exactly at what point in it that becomes possible, so I'll take it on notice.
Okay, no problem. That brings us to afternoon tea. We've got a short break for 15 minutes. Thanks, everyone.
Seriously.
Welcome back, everyone. We're into our final session. We'll start again with questions from the opposition. Mr. Fink.
Thank you, Chair. Ms. Black, just in relation to the Macleay area, my understanding is that there is going to be 10 beds from Kempsey moved to Port Macquarie, and in replacement, they are going to provide 4 hospital in the home beds for mental health. It's been suggested that you have told that local health district that that is best practice. Is that correct?
No.
Have you been engaged, or have you provided any advice to the Mid North Coast Local Area Health District around hospital in the home provision of services?
No.
So the local health district has clearly said that the mental health commissioner has provided advice, and you've said it is best practice for 10 of the beds that are being moved from Kempsey to Port Macquarie. That is okay, but then to have that replaced with hospital in the home instead.
That's not advice I've given.
Okay. Well, I might be asking. I might seek some further advice, and I'll come back to this matter, because they've clearly provided advice to the local member.
I haven't been asked for formal advice on that matter.
Okay. So let me put the question another way then. If you were asked to recommend that hospital in the home services replace inpatient care for mental health services, is that something that you would say is best practice?
I would say you need a continuum of care, and that you need a variety of different choices depending on the needs of the individual. Okay. What we hear in our consultations is that people are keen to see models that actually support them at home or in the community, but you need the whole continuum of care.
Okay, well, I suspect that the local member up there might be asking some more questions of the local health district. In terms of Bathurst Health Service, there's a redevelopment that's occurring at the moment. I believe the community has indicated that car parking, and we're back at car parking now, is one of their top concerns. Ms Pearce, are you able to provide any advice as to why parking at Bathurst hasn't been addressed in the redevelopment?
My understanding is that it is being addressed, but I'll ask Ms Schoolander to answer that if that's okay.
No, fantastic. Thank you.
Good afternoon.
Hello.
In relation to the parking at Bathurst Hospital,
yes.
We are aware, as with many of our redevelopments, that parking is of great interest to the local community. In relation to parking that we're providing on site, we will increase the parking by 46 spaces, and there'll be an additional 25 spaces on adjacent streets. With every redevelopment, we prepare traffic and parking impacts, and we're satisfied that the impact of the new redevelopment will be addressed by the increase in parking on that site.
Okay, so there's 46 on-site additional parks that will be
correct
included, and then you said 26 additional...
25 on adjacent streets. Sometimes we're able to change the street parking arrangements through agreements with council to be able to increase the number of parking spaces on street. For example, changing the angle of spaces or using verges.
Okay, so it's fair to say there'll be approximately 70 odd additional parking spaces. Okay. Well done.
Thank you.
The staff restructure that's occurring at Bathurst Health Service, are there any job losses associated with the restructure?
We would have to take that. We would have to take that on notice.
Okay. If you're able to take also on notice, just in relation to that, if there are job losses, how many are being lost? And are there any complaints against the General Manager at the Bathurst Health Service? Has that been raised with you?
We have been working with the local health district around some of the results associated with the staff surveys across a number of our hospitals, of course, but any discussions around specific complaints is not something that I would be discussing in this forum.
Okay. Is it PMES? I think it is. They, I understand, are particularly low for Bathurst. Is that your understanding as well?
The Western New South Wales C, as I've just said, is engaged with Bathurst and others. Anyway, look at that as a consequence of the PMES, and Mr. Griffiths may wish to comment further. Mr. Fang, obviously we always look for areas where there is any, distortion in the results that we see there, and then seek to understand what the issues are.
Yeah.
And that would apply anywhere.
Because it's my understanding that the local member has received quite a number of complaints from staff about, I guess, some of the matters in the Bathurst Health Service. Has the Minister or the local health district sought advice on how they can best manage and see an uplift in those in the staff morale?
Well, again, look, you'd have to direct your questions to the Minister and to the district. I can't speak third hand on behalf of them.
I know. I guess I'm asking if the Minister's actually made representations to the department about making sure that the local members' concerns about what he's hearing from the staff are raised
The
and
Minister
addressed.
most certainly would pass on any concerns from any local member that he hears, and he dutifully passes that on to us, and we respond accordingly.
Thank you. The Grenfell MPS, is there... Am I best to direct my question to you, Ms Pearce, on that?
Yes.
For the moment? Yep.
I'm not sure I can assist you, but yes.
It's funded and licensed for 9 beds. However, there's no physical capacity for the beds. Is that something that you've been made aware of?
No, it isn't, and I would need to take that on notice.
Okay. Do you know if there's been any funding allocated in relation to...
I beg your pardon. Sorry, Mr. Fang. It's remiss of me to forget that Mr. Luke Sloan, our Deputy Secretary for Regional, is in the room and can assist on that matter.
See, he was hoping that he'd hide right back in the corner.
No, he put his hand up and leapt forward with a great deal of eagerness.
It was yes, it was fantastic.
I'm keen as Mr. Fang. Thank you for your question. So I think it's probably a bit of a conflation of issues there. There was an increase approved of residential aged care beds approved by the Commonwealth. Quite often, a lot of the regional local health districts will submit for increased funding for residential aged care beds in line with their MPS footprint. And there's always the case of, once they're approved, ensuring that we can actually have the capital development to actually match that, which is often the case where it's out of sync with what the Commonwealth are actually putting out. So we're working with the Commonwealth at the moment across all of the regional health districts to ensure that we're matching that capital investment with the Commonwealth with their own capital works program, so that when we do apply for increased bed spaces, we are able to action those. There is a period of time once they're approved by the Commonwealth that we can actually work through and action them through the capital program. So that will be a work in progress for Grenfell.
Okay, so I guess my final question on this matter before I pass to my colleague, Mrs. Carter, is when do you think Grenfell might see the works completed once the coordination is completed, and that there will be the availability of those placements?
Yeah, look, I don't think that's a question we can answer until we align the capital programs with those beds that now have been approved. Those 9 beds are actually just the additional RAC approved spaces from the Commonwealth that's not aligned with either the Commonwealth or New South Wales Health's capital program.
Thank you. Ms. Carter? You might have to come back on the stuff. I'm just going to double check that.
Sure. Ms Pearce, if I could ask you, I believe you'd be the right person, but please direct me if not. I have a couple of questions in relation to the forthcoming statutory review of the Voluntary Assisted Dying Act. Do they go to you? Or?
Dr. Chan.
Oh, Dr. Chan, great, thank you. So I'm just wondering what the parameters of that review will be. Certain stakeholders have approached me. You'd be aware of the case, I'm sure, where the father of an abuse victim in hospital was able to take advantage of the VAD process, and questions have been asked whether this is a matter that can be considered in the statutory review in terms of who is able to access VAD and whether prisoners, is it appropriate for them to have restrictions? So is that a matter that can be considered in that statutory review?
So the statutory review, we're welcoming all comments. And there's a series of webinars and engagement with a variety of different stakeholders, and there'll also be a capacity to provide an online submissions. So I can make available to the committee the processes and the planned meetings, but there is an accompanying document that we're asking people to consider as part of it, but certainly we'd be happy to hear about any concerns in relation to or areas for improvement or where it's working well in relation to voluntary assisted dying.
Great. And when will that public consultation begin?
It's commencing as we speak now. I can bring up my statements, so I can provide a program of the dates that we'll be conducting. If you just give me a moment.
And is there a website that I can direct people to?
Certainly. We'll make available to the committee the details of the website.
Thank you very much. No, that'd be very useful. Thank you. I know there's a lot of interest. Thank you very much. And actually, just a question, Dr. Chan, if perhaps this is for you as well. In the annual report that Health put out, there's a table at the back in relation to palliative care, and I noticed that it talks about expenditure on end-of-life and palliative care. What's the difference?
So just to clarify which report.
I'm looking at the 24-25 annual report.
Annual report.
And I'm looking at Appendix 1, health statistics, palliative care. Okay. And it talks about expenditure, and it helpfully provides a district-by-district breakdown from 2019 through to 23-24, and it talks about end-of-life and palliative care. I'm just wondering what the difference is.
I would have to defer to the finance in terms of how
you
they...
mean the difference between end-of-life and palliative care, is
Yeah.
that
End-of-life is a broad term that's used to factor in the period where a person is deemed to be approaching end of life. We would use it in that broad holistic sense. Obviously, palliative care forms a particular subset of that, but within end of life care, we would support things like having advanced care directives, making sure that your people around you were very clear about your limits of care that you wanted to take. So that end of life process is when people have got a range of issues that might impact.
So in terms of the funding allocation, this table is only palliative care, and there is additional funding in the budget somewhere for end-of-life care?
So end-of-life care is woven into everything, and so why I was hesitating in going to our finance colleagues, it's how we cut things. We would expect that end-of-life is a component of care that all clinicians in hospitals provide, even to our ED ED colleagues, our cardiologists, and those sort of aspects. It's a component of care. Substantially, I suspect that financial statement relates to palliative care expenditure specifically. It may have some end-of-life coordinators, and so there might be coordinators in our local health districts that support end-of-life or coordinated care.
So who could provide the detail of how much of this is palliative care and how much of it is other types of care at end of life?
We would have to take that on notice, but I would like to make the point that the funding for voluntary assisted dying is a separate bucket of money that has been provided to districts for that purpose.
No, that wasn't my question. My question was to try and understand exactly what these figures were, and if it could be taken on notice. That would be.
I probably just would want to make one component is that we actually do see good end of life care as embedded in everything we do, and a component of people's clinical responsibility and clinical teams. So the definitions of what's included and what's not is probably to some extent a little arbitrary.
Dr. Chan, I'm not quibbling with that. What I'm trying to do is seek to understand exactly what these figures represent and what else is included in those figures, if anything. Thank you. Ms Pearce, if I could come to you, and you be aware of the Audit Office's State Finance 2025 report?
Yes.
And one of the high-risk findings related to health entities which had entered into non-standard arrangements with staff specialists and VMOs without the required delegation. How many of these arrangements were entered into and by which health entities?
I'll have to ask Mr Griffiths, I think, to respond to that.
Sure.
What I can say broadly, and we gave this evidence to the Special Commission of Inquiry as well, which so that will be in those transcripts. There are a range of non-standard arrangements that exist, some of which date back 20 years across a range of our districts, and clearly it's something that we've issued instructions on in regard to those arrangements. But Richard, did you want to add?
Well, actually, Ms Pearce, I don't know that I can add a whole lot more without perhaps taking it on notice to give you some more detail around that matter.
Yeah, look, I'm happy for you to take it on notice so we can understand it, and perhaps this is also having to be taken on notice, the nature of the benefits that were given to the staff specialists or VMO that were beyond what is provided for in the award or determination.
Yes.
Thank you very much. And also, perhaps you can tell us all on notice what steps New South Wales is taking responding to this finding.
Yeah, happy to do that.
And in relation to security risks and Auditor General's report, the Auditor General has flagged cybersecurity issues. 59% of reporting agencies do not have independent assurance over their assessment of New South Wales cybersecurity policy requirements in financial year 2024, for example. I'm just keen to understand the cybersecurity incident in relation to the South East Sydney Local Health District. How is that picked up, and what are the cybersecurity protections in place?
Look, I'll clarify this for certainty, Mrs Carter. I don't believe that we classified that issue with South Eastern Sydney and the website a cyber incident as such, as opposed to a sort of a bot. And look, I don't pretend to be an expert on this, and our Chief Information Officer would certainly be able to clarify this more fulsomely. We are aware of the findings of the Auditor General's report. Obviously, earlier this year, we've established a cyber security task force within health that's looking at these issues. It's clearly important to us to protect our data systems, and patient privacy fundamentally is clearly something that we remain always alert and concerned about. We would be happy to provide on notice a much more fulsome account of the efforts we're going to address these issues. I know that we are looking at increasing a budget allocation, I think next year, or this year, within this year, to the tune of around $12 million. If I'm not speaking out of turn, our Chief Financial Officer will certainly correct me if I've got that wrong, but to increase our efforts in that regard. I will say that the report that the Auditor General conducted earlier this year was based on some discrete units within health. It certainly was not based on the whole of New South Wales health, and it is a particular part of our system that we are paying active attention to. So yes, certainly it's something we're absolutely aware of and committed to continuing to address, because I think, to be fair, it is something that all agencies across the country clearly would be alive to each and every day, because that threat and the maturity of those threats and the sophistication of those threats continues to grow, and we're trying to keep one step ahead of them all the time.
And you're satisfied that none of these links or sites were uploaded by anybody within health?
The South Eastern Sydney?
Yes.
I can't.
Has it been investigated?
The team have certainly had a look at that issue that you raised this morning. To be very, very clear with you, my advice is that it is likely to be a bot. If not an unknown person, we have not certainly located any individual responsible for that. We have not received any complaints from the public with respect to those issues that you've raised. So I've no evidence that anyone has accessed them, including children.
And how long between the bot putting it up and health taking it down, and how many repeat times have bots put these up?
So I'd have to take the second part of your question on notice.
Thank you.
In respect to the first part, what I can say is that as soon as the local health district became aware of it, they took it down immediately. They did take some time, however, to let eHealth New South Wales know about it. So that perhaps is the gap that you've referred to this morning. They have then sought to obviously, remove it and scrape it, as I think the term goes, from Google and other sites. But in respect to the document that you provided to Minister Jackson this morning, what was evident in that document in what had been included in the search bar was a very specific reference to South Eastern Sydney LHD. It was not something that you would Google and would take you there. So whoever provided that document had specifically searched for that with the known link. I make no assertion about that. I just make the point that insofar as Googling was concerned, it was not something that would be readily accessible unless you knew specifically where to look.
I've got different information, but my time's expired.
I'll go to Ms. Mihalich.
Great, thank you, Madam Chair. Hi, can I have is Miss Amanda Scalander? I think. Is she
Emma
here?
Sculander.
Sorry?
Emma Sculander.
Yeah, Emma Scalander. Is she here?
She is.
Yeah, can I have? Great, thanks very much. Ms. Scalander, can I just ask you, at the estimates hearing on the 10th of September 2024, you provided evidence to the committee that a combined hospital and TAFE at Chapel Road site, Bankstown, was still in consideration as part of the business case then? At what point in the planning process did Health Infrastructure determine that TAFE Bankstown would no longer be part or included as a funded component of the business case?
So, and you're testing my memory, you'll appreciate that's a little bit of time ago, but in 2024 we were preparing business case options, and at the time certainly the amount of scope that we were seeking to achieve from the budget available for that project was challenging to be able to fit into the budget envelope. We prepared a series of options. We worked collectively with TAFE to do so, and we presented those options to government.
What month? When do you think you did that?
I would have to take that on notice in terms of when the business case was submitted to government.
You can't recall the
No,
exact
I
month that
genuinely
came off?
cannot recall exactly when the business case was
Can I
submitted.
just put to you, Ms. Calanta, that in March budget estimates, Mr. The Minister for TAFE said, and I'll quote, health infrastructure is running the process. We don't want to have multiple bosses of this one. Do you know who the boss is that made the decision?
In relation to...
He's referring to not having multiple bosses. We want one. Who is making the decision within health infrastructure that Bankstown TAFE will no longer be at the Chapel Road site?
So in relation to the process that we lead, Health Infrastructure leads the planning and the delivery of that Bankstown Hospital process.
Yep.
As part of that, we worked together with TAFE to prepare options to government. Ultimately, they were presented as options to government, and it was a decision for government that would be cabinet in confidence.
So it was a decision of government, but it wasn't a decision of the Minister for TAFE, because he says that he made it clear that Health Infrastructure,
I couldn't
and
comment
I'm quoting
on
him, is running the process. We don't want to have multiple bosses of this one. So
I'm not sure what he would be referring to, but I can confirm that I am running the process with Health Infrastructure. I guess in relation to how that decision was made by government, I'm not privy to that. It was
could you take the notice? I'd like to know what month.
I wouldn't be able. I can certainly
you can
take
certainly
the
tell me
month
the
on
month
notice.
that that decision was made. So you're saying it was a matter for government, a matter for cabinet? Is that what you're suggesting?
That's right. So we present the business case and at the point that the business case is submitted, it then goes to an expenditure review committee for decision, and that would be the month I would be able to provide to you when the decision was made.
Well, it must have been, obviously, we know roughly it has to be after March 25 because
Yeah.
Minister Fatake wouldn't have misled budget estimates.
I don't
And-
disagree with you.
And June was the budget announcement, and TAFE was already given funding for a site, or certainly a temporary site at the University of Western Sydney.
I just don't have that exact information to hand.
Right. Are you familiar with are you responsible or playing a role with the REF document?
Yes.
Okay. The REF document says on page 15. Sorry, I just want to I'm interested in building D. So there's still going to be on the current TAFE site where the new Bankstown Hospital be. You're indicating that there's something called building D, which will still be used for education training. Is that going to be some sort of a TAFE site there, or temporary TAFE? What does that mean by education training?
Yeah,
does that mean TAFE or not?
We have an agreement with TAFE for ongoing use of that building up to a period of time, and so TAFE is just working through.
Do you know how long the time? It says here up to further 5 years.
Yep, that's right. And TAFE is just considering that proposal for its use of that building for that period of time.
And do you know the number of students that are expected to be on that site?
That would be a question for TAFE.
Okay. Because in your document there on page 15, you're suggesting that there'll be 300 students there. But when you look at your construction traffic management attachment, it's down to 100 students.
Okay.
Can you take it on notice?
I would
then,
have to take that on
which
notice,
is the
yeah.
correct figure? Because it's in the
Absolutely.
same document and there's two different figures for the
Yeah,
number of
it
students.
sounds like
there,
an
so I'm interested to know.
inconsistency that I can review.
Also, the demolition, I understand, is starting next year,
Correct.
February?
Yeah.
Right? And you're saying in your document that there'll be no traffic impact on Bankstown as a
In
result of
relation
the works
to-
that you're during the demolition works. Is that
The demolition works. Yeah, I mean, I'm happy to take on notice to review the traffic plan in more detail. The information that I've been provided is sitting in that planning documentation.
okay? Because it's saying that trucks are going to be turning right out of Chapel Road onto the highway, exiting the site, and at this point there's a no right-hand turn there. Do you
Okay.
know that, Ms. Galanda? So I'm just wondering how the trucks are going to get past that.
Yeah, look, I don't know the detail of that. I will undertake to review it. I think just to note, we do have to manage traffic impact all the way through construction, and it's certainly something that we're very committed to in Bankstown. It's going to be something that we will keep an eye on in terms of construction parking and construction traffic all the way through construction, which is going to be a long period of time.
Thank you.
Thank you, Chair. Dr. McAnulty, I'll just go back to the documents that I handed out before. There's page 30 of what is, page 30 is actually the last page of some meeting papers that start at page 21 from an expert advisory panel. Now, this is different to the Health Expert Advisory Panel. Is that correct? Because at the bottom it has the Premier's Department as a footer.
I believe so, yes, that's different.
Because page 21 has the start of those recommendations and key findings. It's a meeting paper 3.2.
Yeah. Yeah,
Are
that's
you
different to our health panel.
Okay, so that's different to the Health Expert Advisory Panel. Are you part of this Expert Advisory Panel within the Premier's Department, or is that you, Dr. Chan?
No, it's not. It's not me. It would have been. I'll have a look at the document, Ms.
Yeah.
Vernon. It could be.
I'm just wondering, because at the end of that, this document is dated the 15th of August 2024. It does say, the last paragraph there, it does say it is concerning that the NHMRC levels, which are the blood lead levels of 5 micrograms per decilitre, are continued to be treated as safe. It says the expert panel has recognised there is no safe level of lead in a developing child. And that the NHMRC guideline is used to triage resources. What's New South Wales's health's view on that?
So I don't There are a number of panels that the Premier's Department convened. I don't recognise this as being one that I was on. However, the NHMRC has a comprehensive guidance on lead management and screening, which was released around 2016, I believe. We've written to the NHMRC asking them to consider updating the evidence around that and to update their advice. But the current
When was
advice,
that, Dr. McAnulty?
when did we write to them?
Yes.
I think it was about a month or so ago.
Okay.
But the current advice, which was well researched, advises that an action level of 5 micrograms per deciliter is when you, if somebody tests for that level, a child tests for that level, then an investigation as to their potential source might be warranted. But the evidence from that document of harm below 10 is unclear because of the available literature at the time.
Yes, so there's briefs, I understand.
So, Ms. Furman, I suppose just to summarise, we support that reducing lead levels down to the lowest possible practical level is what's supported. The threshold in the NHMRC, including the document, the levels set by CDC, are basically set as sort of action levels, but I can confirm, and Mark Diagraph might be able to assist as well, is to confirm that information around reduction of lead levels and is provided to all people regardless of their lead levels. We recognise that factors change, people move within the community, and in addition we're very keen to even move further upstream and do our interventions into more of the antenatal, pregnancy and maternal space, but Mr. Diagraph can probably comment on that if that's useful for you.
Yeah, that's fine, actually. I'm sorry, Mr. Diagraph, because I do have quite a bit of stuff to talk about, but or ask questions about. I can see that within these documents that you are New South Wales Health does appear to want to expand its testing. The funding that you mentioned before, Dr. McAnulty, does seem to be just maintaining the status quo at best. The documents I have before me suggest that there was an attempt to get a whole of government funding and increased funding to deal with the lead issue in Broken Hill. Is that correct? Was an increased funding bid put in to the last budget process, budget timeline, and wasn't agreed to?
In terms of the health component,
yes.
You asked earlier this morning whether...
Because it used to be, remember, $13 million over 5 years.
In terms of the health component that I mentioned this morning, you asked whether that had, how it changed from last year. I can confirm that was the same last year as this year, and we intend to maintain the responsibilities, the funding for the things we're responsible for in terms of lead screening into the future.
So why isn't New South Wales Health asking for more money?
So in terms of the more money, we're taking an approach to that we have received some additional funding for a variety. So health's role in this is really around screening, assessment, making sure that we provide support for parents to remove the exposure risk. And as I said, we've really recognised that needs to be brought forward into the antenatal period. And then we have received funding, Far West has received funding for additional programs that touch pregnant women and their families. And what we're looking at is embedding this within those programs because we think it makes sense in a holistic way that many of the families that will be touched by those programs will be experiencing multiple elements. And Mr. Diagraph can talk about the source of funding that has increased for those programs, particularly the sustaining SNF Plus, if I've got the acronym right.
So I'm particularly interested in that cross-agency bid that's referred to on page 36 of the documents. It is in the New South Wales Health Expert Advisory Panel meeting minutes from the 14th of May 2024, Dr. McAnulty, and the point is made at the top of that page 36 that there is limited capacity and resources to respond to all children who are over the NHMRC guideline of 5 micrograms per decilitre. Imagine if that was the case in Sydney, firstly, and that it goes on at 10 micrograms per decilitre, family receives home visits, but it really stresses the need for more resources. Then there's a cross-agency bid there, but there doesn't seem to be any evidence coming out from the government right up until today in asking you the questions about increased funding, that in fact that cross-agency bid has been successful to do what it says here, including things like wraparound services, co-designing the program with Aboriginal people, reducing emissions from mines, importantly. I know that's a EPA issue, but was it unsuccessful? Is that fair to say?
So my understanding is there are still discussions ongoing about how we can make sure that we've got good coordinated resources across government agencies at Broken Hill.
So, Ms Furman, just that there's a whole of government process that was led by premiers. Probably these questions are best directed at premiers. New South Wales Health is really committed to making sure that we've got good coverage of our screening programs, that we're embedding the prevention into all of our programs, and to make sure that Broken Hill the families in Broken Hill are supported. There have been some new investments in some of the early childhood, more intensive interventions, and we're really hoping to embed some of the prevention activities within those lead programs, and we're committed to, if we do need to find some additional funding for our part of the program, we're really committed to the communities in Broken Hill. We recognise this is a complex.
Given the state where we are with the budget cycle, is New South Wales Health and indeed the Far West LHD putting in increased bids to deal with this terrible problem? I mean, it's a terrible problem in Broken Hill.
So the issue, as you know, is a complex one in terms of the need to secure alternate housing, to remediate properties. It's a complex issue. We are looking at how that some of those programs can be done in a more efficient way as part of whole of government, but that funding would probably accrue to other government agencies to deliver some of those longer, those strategies. From a health perspective, as I said, I'd like Mr. Digraph can comment about the adequacy of the program elements from your perspective.
Certainly, thank you, Dr. Chan. We believe that we have sufficient health resources at this time to support the lead screening and wraparound services. So linking it to the Sustaining New South Wales Families program, that intensive program for the first 2 years of life. We're also asking our community and family nurses to follow up with universal home visiting. That's a handoff from our midwifery group practice as they exit their work at around 6 weeks post-birth. Then our child and family health nurses are engaged in that program. We're also interested in through our VANS program, our Violence and Neglect Out of Home Care program, to make sure that those children that are at particular risk are followed up in a comprehensive way. The other areas of partnership, working with Marama, and they've got a strong program of screening and detection, and they work well with our maternity services, saying what can we do with further work in those early years of life. We note that Marama has recently secured funding for a childcare centre which will open in 2027. We're expecting to work with them closely on the issues of healthcare generally, but specifically lead in those first few years of life. So we're taking the available funding, which we believe to be meeting those needs around lead screening and lead programs in those early years.
Has the funding increased significantly to deal with lead issues then in Far West LHD, Mr. Digraph?
I can't comment on previous years. I would need to take that on notice and do that comparison because I don't have that front of mind past years. What I would say is I note the funding streams that are coming to us now through Sustaining New South Wales Families, etc., and we're using those funding streams as a way of dealing with what is a chronic health issue, and saying, have we got the available resources deployed appropriately to what is a significant local health issue?
I mean, up until last year at least, but possibly this is still the case, point of care blood lead testing machines, for example, being used within the LHD. Do you have the modern lead testing equipment, blood lead testing equipment?
Mr. McAnulty had an expert panel on this
yes,
issue.
the point of care tests still being used.
The point of care tests that have been suspended by the TGA, do you mean?
So the TGA has a special arrangement with the district to enable those point of care tests to continue. They're very convenient, they're pretty accurate, and they get followed up by a venous blood test if there's a high level.
And so why are those? Are they being used in other parts of the country?
I believe they are. I don't quite remember the answer to that. I believe they may be in other states, but I'd have to check on that.
As part of the issue with these point of care, with the ones that the TGA has essentially now cancelled, I think, not just suspended.
They
other than in Broken Hill.
I've forgotten the exact terminology, but it was to do with lack of data from the US manufacturer. However, based on some evaluation and some discussions with the TGA, our local public health physician has been able to enable a TGA process that enables those tests to be used. The feedback we had from both services that are offering blood testing in the local district was very effective. They were a one-stop opportunity to engage with families who are being tested without the need for recall when the level came back. So all these things are a balance of what's best for the child and the family, and with the TGA's permission, these machines are being continued to be able to be used.
I mean, in the emails that I've got, page 49 is an email from Dr. Bielefeld, which states that what he's responding to concerns about this testing, and he's suggesting that a response says something like the TGA noted there was insufficient evidence to support the accuracy of results in relation to lead levels with capillary blood samples. They've gone back. The TGA went to the manufacturer of the Leadcare-2 and asked for evidence. This evidence was not provided. So at this point, does it look like the evidence is there that indeed those old point of care lead testing devices are testing 100% accurately for levels of lead in Broken Hill?
I don't believe old is the right term. I believe they're the currently available machines.
The TGA doesn't think so, except in Broken Hill.
There's when a new generation is produced by the manufacturer, I think we're looking to get one. No test is 100% accurate. There are limitations. There are some data on the accuracy that have been published, I understand. But again, it's this balance of what do we make sure that screening tests are screening tests for further evaluation, and as I said, venous testing later on if they are indicating a higher level, and the intelligence from the clinicians on the ground based on feedback from the community was that this was a point of care test was the best option for the Broken Hill community, given their limitations, but given the limitations of other methods of doing blood testing, which might require a venous sample and a delay of getting the result, by which time the families may not come back easily for the follow-up.
So, Ms Furman, as soon as New South Wales Health was aware of the issue with the machine, an expert panel was set up, and that involved local clinicians as well as experts to work through this difficult issue. Screening tests often, such as point of care, often have not as accurate, but we trade off that in terms of their detection. So if we have a very low threshold that if they detect something within a window, we then move to venous blood to validate it. It was considered very appropriate as the feedback I received from briefings from the work that had been undertaken. But New South Wales Health took this matter seriously. We'll continue to reflect on any evidence available, continue to generate the evidence. But it was considered that the other options which were explored with other capillary tubes and other testing methods, including venous blood on all the children, we'd actually get lower uptake, and it would be on balance, it would be a worse outcome. So we will continue to monitor this area very closely to ensure the right testing is available. Thank you.
Back to the opposition.
Thank you. I've just got a couple of quick questions before I pass back to my colleague. Just in relation to the issue around the Macleay Valley area, the local member has raised some concerns about the moving of those mental health beds from Kempsey to Port Macquarie. Do you know if the local health district had a communication plan in place before they elected to tell the public about the change?
I'll ask Elizabeth to respond to that. Thank you, Mr. Fang. Yes, they did have a consultation process in place. It was quite extensive from September, and certainly as late as today, they're meeting with some of the local groups. I understand that some of the information provided could have been done so better, and so they have sought to work through that in recent days with specific groups, and I've got the details of that I'm very happy to table.
Okay, that would be much appreciated if you wouldn't mind. The local member has rightly raised some concerns about how the local health district is going to guarantee somebody who has suicidal ideations in the Macleay Valley is going to receive treatment in relation to, I guess, the mental health aspects, given that a lot of the services are moving to Port Macquarie. Do you know if the local health district has considered the way that they've communicated to the local area about those matters?
Look, thanks, Mr. Fang. I think I'll defer to Murray and Brendan as required, but I think most importantly and really important for the committee to understand the services in terms of if people have any requirement for services, they still need to present to the hospital. It's probably also important to note that the volume of patients accessing Kempsey from Port Macquarie is nearly half. So actually half of those patients will now have care closer to home for them. In terms of the specifics for Kempsey, we will have obviously the safe haven that will be there, which we know from other districts has been incredibly positive for patients that don't necessarily want to present to hospital, but provides them with a safe place to be. And so a lot of the work that we will be doing with the district is really about improving access to that model in that facility for patients who are currently potentially not accessing the service because of their fear of being in a hospital environment. So a lot of the work has really been about improving access for that community. But I think Dr. Wright or Brendan, I don't know if you have further.
Look, I think Ms. Wood has covered most of it, but I think that I guess the point that I would make is that suicidal ideation is a condition which for a very significant number of people can be managed without having to resort to hospitalisation. Okay. And so by introducing a hospital in the home capability, we're probably going to increase the number of people who can be treated very close to their home in familiar surroundings, and I would argue that that's a huge benefit for them. I think the point we made earlier in regard to this, though, is that this is not a new model internationally, but it is a new model for us. And we are very, very keen to evaluate it very carefully because, we don't want there to be unforeseen consequences that disadvantage people. There's a genuine desire to see if this is an improvement to the range of services for that community.
And while I accept those answers and I appreciate everything's been done in, I guess, good faith, what is of concern is that the advice that was provided to the local member clearly states that the Mental Health Commissioner has said it's best practice. Now, the evidence that we got from the Mental Health Commissioner is that she wasn't asked for this advice at all. Given that it is a trial, and noting that, Ms Wood, you said that some of the patients from Port Macquarie were going to Kempsey, or you said, I think, some of them. We've now got a situation where 100% of the patients from the Macleay-Kempsey area are having to now travel to Port Macquarie. What's the guarantee that this hospital in the home is going to be supported by New South Wales Health so that we can adequately ensure that we have success here and we don't have to deem it a dismal failure, given people may not respond to it?
Can I comment on I'm not sure who said what to whom about what best practice is, but I think there is this model emerged from a process which was run by the ACI, looking at models of care that could be introduced in New South Wales mental health services, and they did do an international literature research. And so the comment about best practice, there's a very strong evidence base about the benefits of hospital in the home. There's no doubt about that. Implementing it in a rural setting and implementing it for the first time in mental health services is not without challenges. But there is no doubt about the evidence base that supports this model. We think we wouldn't be running with this if we didn't think there was a net benefit to the community of that district. But all new models, all implementations have to be looked at carefully, because there are often bits that we hadn't anticipated, and they need to be either addressed along the way or the model needs to be revised. But I think we need to be clear. There's a very strong evidence base supporting hospital in the home as an innovative and beneficial service.
And if I may also just add, and this came up earlier from Dr. Con, there is actually an extensive monitoring and evaluation plan that has been developed. It has 29 indicators that really focus on patient experience, outcomes, as well as any indication that patients are returning up to hospital where they could have otherwise be treated. So we are very happy to provide that, Mr. Fang, on notice too.
Thank you very much.
Mr. Shembry, could I ask you some questions, please?
Thank you.
Thank you, Mr. Shembry. So you'd be aware that doctors at Northern Beaches Hospital have indicated that they will leave if they have no certainty about ongoing provision of private services prior to Christmas. So are you going to be able to give them the assurances of what the future looks like within that timeframe?
What we are able to do is talk with the Northern Beaches clinicians about the refresh of the clinical services plan.
So you have a plan you can discuss with them now?
Can I just make a point? Sorry, we're not in a position immediately, and this is part of the challenge, because the contracts haven't been signed. So I think Mr. Shembry and also Mr. Daly, who may wish to have some comments here, in a general sense, can comment, Mrs. Carter, but the challenge we've got at the moment is that we're still working through that contractual process. So we, once that's signed and dealt with, we will be able to have obviously much more detailed and fulsome conversations with the clinicians, and that is certainly our intention. We are very acutely aware of the private service provision in the hospital and the desire for a number of our medical officer colleagues to continue. And I just wanted to make that bit clear. So it's not that we're not wanting to sit down with them right now on the detail, it's just that we've got to work through the contract.
Isn't there a significant risk that because of the delay in providing certainty to these doctors, that they may make alternative arrangements about practice and then simply not be available to continue providing services at Northern Beaches Hospital?
Matthew, did you want to perhaps respond to that? I don't think
I think, and Anthony is living it as closely as what I have been with him for the last
3 months, where I've got to just publicly call out the way his team has turned this process around. One that was contracted in the original deed to occur over 3 years has now occurred over 4 months. And that lack of uncertainty, there'll be some small businessmen and women to support their own practice will opt for certainty. Does that generate any concern for the public component of it? No, it doesn't. If we were to lose clinicians, it's a very attractive part of Sydney to work in, and I'm extremely confident, particularly talking to clinicians there, that there would be no problem us maintaining rosters in terms of the public component. For the private component, which I think is more to your point, that will probably need to go through, once the clinical service plan is finalised, it may well need to go to market for procurement. We've got an expert, government supported us in getting an expert, independent expert advisor in around public-private
Sorry,
interfaces.
can I just stop you there, just so I can understand exactly what you're saying? When you say for the private services you go to market for procurement, you're not intending to continue existing relationships with existing private providers?
Yeah, from day one, there will be no change to the clinical profile of that hospital.
But will there be a change to the people providing the clinical services in the hospital?
If they chose to leave, there's nothing we can do about that.
If they have no certainty, why as a rational human being wouldn't they choose to leave?
Well, we've given them certainty and government has come out publicly to said that no beds will close.
Sorry, what I don't understand, you said you've given the provider certainty, but then you're saying you're going out to market for
Mrs.
procurement.
Carter, I just have to restate, we cannot comment further about the specifics on this, other than what we've already said, because we haven't signed the contract. At the point in which that is all signed and secured, because those negotiations have been intense, and they've been going on over a number of months, and Mr. D'Amato, Mr. Daly and Mr. Shemry have been knee-deep in them for some time. We will be in a much better position to give certainty, and we do appreciate that it's difficult. I think Minister Park has certainly been to a round table up at the hospital with the clinicians only in the last few weeks. I know that he continues to talk to the relevant representative groups in respect of the clinicians there. We're just not able at this point in time to talk about specifics because we do not have the contractual ability to do so.
I fear I know the answer to this question. Do you have an anticipated cost of taking over all 494 beds at the Northern Beaches Hospital?
We will take that on notice.
All right, thank you very much. And some questions, I think, to perhaps Mr. D'Amato and to you, Ms. Pearce, flowing from the 2024-25 annual health report. At Liverpool Hospital, non-urgent surgery wait times rose to a median wait of 145 days in June quarter 2023, but they've now blown out to 381 days. Why are patients at Liverpool Hospital waiting an additional 236 days from 2023?
Mr. Daly probably will be able to provide more detail on this, but
great,
if I could, because I think he's had a limited opportunity today to demonstrate his
No, thank you,
knowledge.
Mr. Daly. I'd be delighted to get an answer.
But what I would like to say to commence, though, so we're clear, you'll be aware that after the pandemic, we were left with a very significant number of overdue patients. And that number, which has been publicly reported, was a very substantial effort on behalf of the system to bring that number down over the years. So it does affect that 23 year because of Omicron and the peak, and then the bringing back to pre-pandemic levels. The effect of dealing with the number of overdues that we had is that it does impact median wait time. And I need to be very clear about that. So obviously we want no one waiting longer than they ought to for their surgery. I think it's been an enormous credit to the staff of the New South Wales health system that they have been able to wrestle those numbers down in the manner in which they have. But it requires us to do more than 100% of our usual work to get them down. Matthew and his team have led that work. We've got a surgical services task force, and that's probably all I need to say on the matter.
And so just before I leave you, Ms Pearce, just for clarity, that would be the same in relation to my earlier question in Westmead.
Indeed, yes. And I did want to come back to that, so thank you, because
Thank you.
I think it is reasonable. And Western Sydney, as Ms Larkin said, did end the last financial year with 000. It is also incumbent on me to say, with some degree of pride, and it's not often that you get that opportunity in this job, that New South Wales Health is the best performing jurisdiction in Australia in respect of elective surgery. And even the Grattan report has said that in the last couple of weeks. I've got some embargoed information that I can't provide to the committee today that will be coming out in the next week, which will also demonstrate our very strong capability on our surgery performance. But over to you, Matthew.
Yeah, I'm sorry, I should have been a bit more assertive when you were asking the same question of Amanda, so as not to waste the committee's time. But in relation to median, we measure the median wait time at the time that the admission actually occurs for the surgery. So as a result, when we take patients off the list who are waiting longest, which is obviously the objective, what we're measuring is measuring long waits in order to report a median wait time. So the real measure, and so we don't use median wait times, nor do the districts, in terms of managing surgery, because what we do, and the AMA is very supportive of this, is to ensure patients are treated within their clinically recommended time. So when a median wait time goes up, that demonstrates that we are taking the patients with the longest wait times off first, principally those that have reached their clinically recommended time.
And that's why the number of overdues is important to this
But just
response.
in terms of, you say you don't report median wait times, it's in your annual report, so why are you
we focus on the clinical categorisation of patients, I think, is what Matthew is saying.
And that's all the clinical advice is, to be treating patients within their clinically recommended time. And so that is the measure, and that's the measure we measure the health system on. It's the national measure that the Australian Institute of Health and Welfare report nationally us on, and how we compete against other states in that regard.
Perhaps, Mr Daly, you can help me with hospital access targets and ED wait times. Would that be you? So, as I understand it, the hospital access targets provide a more clinically meaningful and accountable measure of patient flow through the ED. Given that performance under these new measures was generally worse than last year, are these benchmarks more demanding than the old 4-hour rule, or has system performance simply declined?
No, those set of targets were targets that we developed in on advice from the Australasian College of Emergency Medicine, who we have a partnership with and we work through. They demonstrated some research around how those wait times best translate to preferred patient outcomes. We accepted that research. We're the only jurisdiction in the country that took it. Yes, it is more demanding. We took the view that it was an opportunity, and we've got some chiefs around the table who may have a view as well, that this was another opportunity for us to engage more closely with our ED physician colleagues, because these are their college's targets. And
so put simply, we are using a more demanding target, and that's why the figures look worse.
It is, yeah, and no other state uses them, but we place ourselves. We're already the best performer, and we want to keep it that way, and this is a way of constantly improving.
Can you help me with capital spend, or would that be Mr D'Amato?
I can try.
So I understand that 2.6 billion was spent on capital in 2024-25, around 7.7% of the health asset base. How does that compare to what Treasury regards as a sustainable replacement rate?
I'll ask Mrs. Granda to
Thank you.
I will have to take that on notice in terms of Treasury's rate. It's a long way to walk to tell you that, sorry.
All right. Sorry to drag you up.
But I will take that on notice.
All right, thank you very much.
She could have signed that, just hold up and say I don't have an answer.
Who can help me with increasing VMO costs? Maybe I'll read the question and we can tender
that's
for an
probably a
answer.
good idea,
Yes. Visiting medical officer costs increased by more than 120 million this year, from 1.19 billion to 1.317 billion. Is there a reason for this? Is this the psychiatric dispute? What's the reason for this increase? This is no takers. No takers.
No, we're
We're
working on it.
workshopping. Okay.
You answer it. No, you answer it. No, you answer it. I'll answer
Well, I think it's probably because we needed more VMOs to replace the psychiatrists on
Well,
strike. I don't know. What is
Definitely
it?
that. Apparently it's $700 million.
Can I just make the point while Mr Griffiths is taking his seat? I think one thing, I need to be clear about VMOs. I think at times there's a conflation with VMOs and locums.
No. I'm very clear on the difference between
Okay, because
staff
I think-
specialist, visiting
Great.
medical officer and locum. Very
Terrific.
clear on that.
What I would say, broadly speaking, is that staff do have a right to choose how they wish to work.
Yep.
And what we are experiencing across some of our medical professions, and this is not just peculiar to New South Wales, I'm the chair of the Health Workforce Task Force that reports to health ministers, and one of the experiences that is occurring across the country is that medical professionals in many cases are choosing to work in a different way. But
Just trying to understand the budget,
Yep.
that's all.
Yep.
Yeah, thank you. Ms. Carter, that you're right. There's definitely an element related to the psychiatry matter. Obviously, not to the full amount that you've quoted, but there's also been a higher reliance on VMOs associated with the locum workforce. For specialist locums, as you know, remunerated as VMOs, and so that is also factored into the overall expense. As we're proceeding through the industrial matter, so the wages are being arbitrated as we speak this week. It will be some time before we receive a decision from the IRC, but there's been, as Ms Pearce has indicated, a bit of a movement towards VMO arrangements, particularly pending the outcome of the IRC hearing.
Thank you. I've got several questions coming back to Albury-Wodonga Health. I'm going to start with Ms Pearce, but could Ms Skew-Langender and Mr McTaggart come up to the table in the interest of time in the interim, please? Thank you. Ms Pearce, I wanted to put to you the transition of cancer care from the Albury-Wodonga Regional Cancer Centre, which is run by Ramsay, to Albury-Wodonga Health. It's my understanding that staff as senior as the chief executive only found out about the transition from the media, and also that Albury-Wodonga Health hasn't yet offered the current cancer centre staff jobs in the transition, and as a result people are actually leaving and taking employment elsewhere. What action are you able to take on behalf of the New South Wales patients and families who rely on the Cancer Centre?
Yeah, look, very happy to look into it. I'll have to take it on notice unless one of my colleagues can assist here, but it's not, no. I'll need to take that on notice, but very happy to look into it.
Thank you. I anticipate you'll also take this on notice, but have you seen or been involved in the independent review or the so-called NOUS review of cancer care in the border region?
I haven't. No.
Thank you.
Not
My
to my
related
knowledge,
question,
anyway.
which speaks to the governance issues at Albury-Wodonga Health, the Senior Staff Medical Association has had a more than 90% vote of no confidence in the current board chair and CEO. That sentiment has been shared by the local branch of the Nurses and Midwives Association, the Health Services Union, and the HACSU on the Victorian side. It's obviously very difficult to run a health service without the support of your frontline staff. Similarly, what avenues, if any, are available to you on behalf of the New South Wales residents who rely on this service?
Yeah, look, again, and I'm not sidestepping your question because it is important for us to advocate and raise issues given residents of New South Wales access those services. The hospital is run by Victoria Health, so clearly that is something that they would be well aware of. I'm happy to give you a commitment that I will raise that with the Victorian Health Secretary next week. I have indicated to Ms Atta that I'm hearing a range of concerns with respect to Albury Wodonga Hospital or Health Service, and that I would seek to discuss those with her next week, and I will.
Thank you very much. Coming to Ms Gulander, while you were on leave at the previous hearing, I had asked Troy Harvey about the issue of poor soil being detected at the Albury Hospital site, and I got a very high-level answer at that stage that there are allowance for things like geotech and an ability to adapt in terms of design. At this stage, now that design has progressed even further, what changes have had to be made as a result of that poor soil result?
I'm just checking the notes because the team has provided me with an update on that. As part of the REF planning application, which we prepare across all our projects that require it, we do provide a number of technical documents. I think from the information that I've got in front of me here, there is no unusual sort of finding that would cause us to do anything different on this project in relation to the soil condition. So yes, as part of the initial investigation, we would have found some, quality issues in the soil, but certainly they get dealt with through the construction processes.
Sure. So I put this to your colleague at the previous hearing because those initial investigations got a P result for poor soil quality.
Mm-hmm.
Are you saying that that doesn't impact the project as planned at all, and you're going to go ahead and build as if that result hadn't been found?
We wouldn't build as if the result wasn't there. We deal with the result on the way through the construction process. So we would be providing, when the building contractor prices the project, we'd provide available information to ensure that they had appropriate cost allocation, I guess, and methodology to enable them to deal with that soil condition on the way through. I will say every single site, probably without exception, that we build on, when we're building on a brownfield site or a greenfield site, depending on the previous use of the site, will encounter something in the soil, either geotechnical or contamination. It really is a business as usual find.
Okay. And so when you go to the through the tender process for construction, if that does come back higher than anticipated as a result of the poor quality soil, how will that impact the project? Will you be able to build what's actually been planned?
We will have a really good cost estimate on it based on the investigations that we've done. So the building contractors will price for that in what they do. Sometimes on the way through in a project we encounter additional contamination that may not have been able to be foreseen. But again, that happens on every project. So no, it wouldn't preclude us from doing anything on this site.
Just coming to Mr McTaggart, because otherwise you would have gone another session without getting any questions. I saw that you visited Albury at the start of October, and it was good to see you in town. So I'm referring to, there were two social media posts, one by Albury Wodonga Health and one by the local member, saying that you'd met with Albury Wodonga Health. The posts were about how pleased they were to welcome senior leaders from the Ministry of Health. What did you discuss in those meetings?
Basically, it was a visit with my colleague from Rural Health. She hadn't been to the Albury Hospital site. Basically taking her through the new emergency department short stay unit and key worker accommodation site and the site for the new clinical services building.
Okay. And who else did you, or the other attendees from the Ministry of Health, did you meet with anyone else while you were in Albury?
No.
Okay. Only with Albury Wodonga Health?
That's correct.
Okay, thank you. With my remaining time, I might go to Mr. Sloan. Thank you. I've previously asked some questions around the IPTAS scheme for travel and accommodation reimbursement, and I understand that that's currently being reviewed or considered. I'd asked previously specifically about the opportunity to access GP specialists, particularly when that may be the closest available service. Has there been any progress with that work?
Yeah, so we have been working on that. It forms part of an ongoing policy review and consideration for that with regards to the budget going forward, the inclusion of those services into the policy for IPTAS. Where they are the specialist referral site, we do include that, and we do provide IPTAS in order for people to seek that support, as long as it complies with the other areas around the policy, like travelling over 100 kilometres or 200 kilometres cumulatively during the week.
Thank you. It's very good to hear. So is that reflected in the policy document now?
Not at the moment, no.
Okay.
We're still working through how we factor that in because there's been several other inclusions. Of course, we have a finite budget for IPTAS and being able to offer that equity of access for people from rural and regional and remote areas. We need to just make sure that the budget lines up with the policy and vice versa with regards to that going forward.
Thank you. It's good to hear that there's been progress in that regard. Yep. I also wanted to ask about access to dental services under IPTAS. So it's my understanding that oral surgery, oral and maxillofacial surgery, cleft lip, cleft palate service, and only certain dental services in highly specialised oral health clinics are funded. Given that it's significantly cheaper to treat dental issues early before they become complicated, obviously, as well as better for people's dental health outcomes. Has there been any consideration of including general dental services under IPTAS too, in those rare instances where people are required to travel that far?
Yeah, again, it comes back to how people access their specialty services and over what distance of they are travel. We're trying to make sure that there's equity of access for people that do have to travel distances from rural, regional and remote areas. And where we can, we're looking at those within the policy as it evolves into the future as well. Yeah.
Okay. Thank you. I'll finally come back to Ms. Pearce in my last minute because I sort of touched on this morning and then I think we ran out of time. I was asking about the mould at the Calvary Mater, but I think it speaks to this broader sort of accountability question when services are managed through a public-private partnership. What oversight mechanisms or what safeguards do you actually have in place under these agreements to ensure patient safety?
Yeah, look, it is a very serious matter, and I think that I want to be clear with you as well, because we did run out of time on this morning. The district certainly, the local health district, has inserted itself into those discussions many, many months ago. And so has New South Wales Health more broadly. There are requirements, obviously, on the PPP providers to deliver upon the services that they provide. And I can't go into all of the specifics about Calvary, for example, but what I can tell you, given our experience in other quarters, is that, there are abatement regimes and so on that get applied when they fail to live up to what they are required to do. We have certainly had to work very hard, and the district, I'd like to acknowledge, has worked very hard on this, to bring them to the table to complete what is required of them in terms of their contract. And the issue I mentioned this morning with respect to the cladding and the water supply was a very substantial part of that problem. And that work continues, but we have now seen some progress, but we are very keen for all of those providers to live up to what is, in our view, their contractual requirements.
Thank you. Ms. Fairley.
Thank you. I just wanted to turn to the human health risk assessment. I've asked about this before, that was undertaken by NRISKs for the Bowden Silver Mine. Dr. McAnulty, I might ask you some questions about this because it's some emails in relation to from the Health Protection Unit. So it starts on page 66 that I handed out, goes through to page 77. There's also documents that I've a few more documents to be circulated as well. So one of the documents to be circulated is something that I asked about before, which is it's from the Tim Brokenshire, which is Western and Far Western Public Health Unit. This was basically the assessment from the LHD from New South Wales Health that says that they've noted the human health risk assessment. and it finds no potential impact on community health. This email, I understand, is part of what makes up New South Wales Health's assessment of the human health and risk assessment. I think you're aware of this, Dr. McAnulty and Dr. Chan, is that correct?
Yes.
Because I've asked questions about it before.
Yes.
So there is part of an email where in page 66 there's concerns expressed from Health Protection New South Wales to Tim Brokenshire, saying that there are concerns from the community and asking Tim whether a full reading of the health risk assessment was undertaken, including modelled exposure pathways and health risks associated with potential exposures. Dr. McAnulty, do you know just exactly how much was undertaken by New South Wales Health in terms of assessing the human health and risk assessment than NRISCs did in relation to Bowden Silver Mine?
Could you just repeat that? Who did? Sorry, apologies.
Do you know, have you undertaken your own investigational research or inquiries to understand just how much assessment the New South Wales Health official, which is Tim Brokenshire, I think, how much assessment they undertook themselves of NRISC's human health and risk assessment?
My team liaised, as you note from the email, with Mr. Brokenshire to understand what happened. I'll have to get back to you at exactly what the outcome of that conversation was.
Okay.
But I think, but I'll have to confirm that he reviewed the documents that were presented to him, but we'll get back to you on that.
There is another email on page 74 where the acting director at the time, Dr. Paul Bileveld, so he says that he discussed, let's just call it the HERA for time, with Neil Heim, who read the full report. I reviewed the conclusions and other key sections of the HERA. So that's what the Health Protection New South Wales branch says.
Yeah, good, thank you.
So then what I handed out as well, just the new information that I handed out to you, I do want to get your view on this. This is the NRISCs. You can see that there's a page there at the top. It's got Bowden Silver Proprietary Limited. It's Specialist Consultant Studies. Can you see that? It's one page of NRISCs. It's the new document.
The last page?
Yes.
Yeah.
So that page is and that first dot point is the only reference to Broken Hill in the human health and risk assessment that NRISCs undertook for a lead, silver and zinc open cut mine near Mudgee, which is 2 kilometres from a primary school. Now, what NRISCs said in relation to the Broken Hill operations was that they're very different and that historical operations at these sites have meant that there has been a long time where dust management measures and pollution control technology were not available or used. This means there has been a long history of dust deposition within the towns, and the communities are exposed to both naturally elevated levels of lead and historical deposition. Full stop. Is the Broken Hill community exposed to anything else in terms of lead? You're on the Health Expert Advisory Panel for lead. What else are they exposed to?
So there's existing mines,
exactly.
There's historical
That's enough.
addition, and there's
Exactly.
also old paint.
Yes. So there's emissions from existing lead mining. This is the human health risk assessment undertaken by NRISCs for a new lead, silver and zinc mine at Mudgee, 2 kilometres from a school, and they've got here that Broken Hill there are no issues to mention in terms of current lead mining.
I think the way I read this is that Broken Hill is different because of that historical deposition of lead from mines which operated without the modern licences and controls in place, which means, as well as the natural lead near the surface, which means it's a very different environment, and modern controls over mining can have a very different
Why
impact
aren't there
to
the
the
modern
historical.
controls of mining being used then? So Broken Hill has underground mining, let's be clear. Mudgee is going to be open cut. Why would a human health and risk assessment not mention the fact that current mining activities is poisoning the blood of children? 33% of children under 5 in Broken Hill have blood lead levels over 5, 69% of Aboriginal children. The human health and risk assessment here doesn't mention it. Do you think this needs to be redone?
The review was reviewed by external, the risk assessment was reviewed by external expert reviewers, two external reviewers who are well qualified, Professor Drew and Professor Priestley, who reviewed the contents of them as I understand it and were satisfied that they had addressed the concerns. It was also reviewed by the Independent Planning Commission processes.
But how, from the New South Wales health perspective, so there are concerns. There's another email within here. I don't know why all this bit is redacted, but I do want to assure you that I'm going to try and get it unredacted, where there are concerns raised. This is page 72 and 73 that says in relation to that same human health and risk assessment, I mean, there's been ministerial briefs about whether that human health and risk assessment was adequate. In fact, the ministerial brief, which I handed out in the second round, also states that the assessment was not comprehensive. So that's also in here as well. So my question is, the community has been asking for and pointing out their extreme concerns about this human health and risk assessment that seems to, doesn't seem to, just completely disregards the fact that the New South Wales government cannot get the lead in children in Broken Hill under control, and current mining activity, that's what Mark Taylor's report said very clearly, is a big part of it. And they're frustrated and have been requesting for a new human health and risk assessment to be undertaken with Mark Taylor's research in mind. Is New South Wales Health going to...
So perhaps we could just address the issues, because I know that this was raised previously, and there was
Not
also
all of this.
multiple of this, and we also met with representatives of the group. So we have gone back over it, both Dr. McAnulty and myself, and I think it's probably important to just highlight a couple of things. There were concerns that, as you rightly pointed out in the correspondence before, that Professor Mark Taylor had raised concerns that the human health risk assessment did not follow the N-Health guidelines for health risk assessment, used thresholds of toxicity reference values for assessing lead impacts that were too high, and underestimated soil lead concentrations and dust deposition. We reviewed the planning process, and we can confirm we went back through the planning process to see if those issues were salient, and we can confirm that the HERA has followed the N-Health guidelines for health risk assessments. The TRVs, the toxicity reference values, were 3.5 micrograms per decilitre, and the air modelling has followed the New South Wales EPO's approved methods for modelling and the assessment of air pollutants in New South Wales. There is a point that we have engaged with Professor Taylor in conversations, and we do note that he's got particular concerns about deposition and whether that needs to be incorporated into any other components. And we are working, and we've raised that issue with the EPA, and we know that EPA is in discussions with Mr. Taylor. It was important to note that Mr. Taylor had actually presented to the Planning Commission, so the evidence of Mr. Taylor, Professor Taylor, was presented to the Planning Assessment Commission. The Planning Assessment Report indicates that the HERA was peer-reviewed by Professor Brian Priestley and subsequently by DPHI hired Dr. Roger Drew, both of who we would see as preeminent in the area of toxicology. They were satisfied that the revised HERA and accepted the risks from the mine are low. In relation to Professor Taylor's comments, as I said, there is a point he's making in relation to deposited dust. And as I said, we are really keen that we work with EPA to understand how that might be factored into future aspects and what that means and how that compares to relying on air modelling. But that's really the technical issues that need to be worked through with EPA. We also do note, and we did follow up with Professor Taylor, and he himself has highlighted the different constructs between Broken Hill and this setting. So I just wanted to indicate that we have been conscious of the issues that the community have raised. We've been following them up to get to the bottom of it. And I just wanted to say that we will continue to engage. We note that the current process is that there is it's going back to the Planning Assessment Commission because there was something around a transmission line that was not considered in the initial EIS. So we're really happy to continue to do this, but as you can see, we have done our due diligence in going back and checking on some of the elements that the community has raised with us.
Thank you.
Are there any questions from the government?
Yes, there are. Just got a few questions, Dr. Chan. In regards to the New South Wales Voluntary Assisting Dying Board annual reports, what role does New South Wales Health itself have in terms of the preparation, review, commentary on those reports? Does it have any at all?
So it is a report of the board. We do provide some, so within one of my branches, there's a section which is the Voluntary Assisted Dying Board Secretariat, and that's the group that supports the board as well as processes the applications. We also have some support for the board through the Centre for Epidemiology and Evidence, who does a couple of pieces of work which looks at some data matching, and the website that supports the board's operation requires data to be extracted so that it can be used in a usable form and displayed, so that the Centre for Epidemiology and Evidence has got a funding to support the development of the board's report. You can see that this year's report form was very much similar format to last year's. But apart from those issues, it's very much a board process.
So the content of the document is ultimately the responsibility of the board?
That's correct.
Yep.
That's correct. Yeah.
I'd like to ask a follow-up question in regard to the 2023-2024 and the 2024-2025 annual reports. So through the Secretariat, if I could. Now, what I've done, Dr. Chan, I've just got extracts from both of the reports. And first of all, if we could deal with the 2023-2024 report. And that should be the one on the top that you've got. Yep. Now, if you just open up to the page, the first page after the cover is page 13. Is that what you've got? Yes.
Got 13, yeah.
So this heading is Voluntary Assisted Dying Process. And then there's a heading, First and Consulting Assessments. Can you see that?
Yes, I can.
Yeah. If you turn over the page, you've got Table 9 and Table 10. Now, Table 9 is headed Reasons for Ineligibility at First Assessment for voluntary assisted dying New South Wales, 28 November 2023 to 30 June 2024, which is obviously not a full 12-month period. And then the second table, table 10, reasons for ineligibility at consulting assessment for voluntary assisted dying New South Wales. Same window time, 28 November 2023, 30th June 2024. Now, in those respective tables, they've got listed reasons for ineligibility. And if we just take table number 9, for example, and I won't read them all, but if I could just nominate 2 or 3 of them. In terms of, this is a tabulation of data, there are, looking at the first one, does not have a diagnosis that meets the eligibility criteria, there's 64. Does not have decision-making capacity, 19. If you jump down 2, which particularly caught my attention, is acting because of pressure or duress, and there's 3 in that category. And if you total out that column, there's a total of 80. You then go to the next table.
Probably just to alert you to, just under that table, there's a little section called notes, which says a patient may be ineligible for more than one reason.
Yes, no, I understand that. But nevertheless, if we look at that first table, table 9, we've got prima facie 3 individuals identified as is acting because of pressure or duress. That's in the board's report. We go to the next table, which is table 10. I won't read out the heading again because I've done that already. But if we look at the first line item, does not have decision-making capacity, 11. Does not have a diagnosis that meets the eligibility criteria, 9. If we jump down to, is not acting voluntarily, and the next one is is acting because of pressure and duress. So it's a total of 4 prima facie in those 2 line items. Can I take you now to the report for 24-25, which is the second extract document I've given you. Now with 2024-25, you have in front of you the cover page. We then turn to page number 15. Is that what you have in front of you?
That's correct.
Yes. So with page 15, you've got the heading voluntary assisted dying process. Then you've got the subheading, the same as the previous year's report, first and consulting assessments.
Yes.
You've got table 9 and table 10. And on the bottom of the page, you've got some summary commentary, which is equivalent to, if we take you back to the previous report, on the bottom of page 14. So if you go to the previous summary extract, page 14. So it's just a couple of paras of, I'll let you read it, a couple of paras of commentary. Different words, but it's the commentary around the matter of eligibility. If it helps, my questions aren't going to go to the wording per se, I'm just drawing them to your attention.
Okay, no, that's fine.
Yeah. So then if you continue on the top of page 16 of the latest report, you've got the heading final requests.
Yes.
See that?
Yes.
Now, what is sticks out like the proverbial is if we go back to last year's report, 23-24, the 2 very significant tables that deal with ineligibility, the reasons for the ineligibility, have been set aside, not included. In other words, in the 24-25 report, the board has deliberately, I would submit, excluded 2 critical tables which provide very significant pieces of information with respect to the practice of voluntary assisted dying in New South Wales. Now, I submit, Dr. Chant, that this is very critical and significant information for the public at large. There is a statutory review with respect to the Act underway. Parliamentarians themselves are entitled, who participated in the debate and what might be subsequent debates on VAD, are entitled to know this type of information. Academics are, those practising in the law, and the medical profession at large. Now, I find it extraordinary that the board could set out, because there could be no other reason, to delete this information. It's not as if they have any problems with photocopying costs. These are two tables which are rich with information and very significant with respect to what they provide in terms of insight with respect to ineligibility, particularly with respect to matters of duress and not acting voluntarily, which, as you would be aware, Dr. Chant, was debated in great detail when the Act was when the bill was before the Parliament. So I'll put it to you, Dr. Chant, and I'll ask you the question: were you aware that these two tables had been deleted from the latest report?
Look, obviously this report went through the approval pathway. I glanced at the executive summary of the report, but didn't particularly notice the additions. I would like to just draw your attention, though, just to be clear, and I would have to seek advice from the board about their thinking and rationale, but if I could just highlight one point to you, which is in my reading of this, that when, and it's in page 16 at the top of that page, it says a small number of cases where a patient was found to not have decision-making capacity in relation to voluntary assisted dying.
Yeah.
Practitioners were unable to confirm that the patient was not acting because of pressure and duress due to their loss of capacity. So we have noticed that the way some of the questions were put into the program, like put into the forms, could be misleading because actually.
But if I can
they're
interrupt you,
saying
Dr.
they
Chan, on
can't
page
access
14 of the previous report, the 23-24, the bottom of page 14, the penultimate paragraph on page 14, if you read it, contains basically the same messaging and the same language. In other words, it talks about the matter of unable to fully assess all criteria because the patient has lost decision-making capacity. So we know that. We know that. But that's not the point I'm making. I'm saying there has been a deliberate exclusion from the latest annual report of two highly significant tables that detail some very critical pieces of information in regard to eligibility with respect to that in this state, and we're about to enter into the statutory review of this legislation. So what I'd like to find out through you is who authorised those tables to be deleted.
So I'm happy to take on that on notice, noting that the board will be the people that answer in relation to the report. But can I just also say, in reading it myself, one of the issues could have been that that was considered misleading because, in essence, perhaps it might more correctly would have said is acting because it can't be determined whether they were acting due to pressure and duress because of loss of capacity. So it may have been colouring the views of the
well,
Mr.
Dr.
Donnelly, I will
Dr.
take
Chan,
that
as
on
I said, the issue is not the verbiage but the tables.
Yeah, so I will take that on notice
So
and
just to be very clear,
yes,
the verbiage on the bottom of page 14 of the 23-24 is essentially analogous to 24-25, essentially analogous. So we won't quibble with the content, but I want to know why the tables have been deleted and why did the board decide to delete those tables?
I will seek an answer, a response. So I've just been, provided advice that the data was easily misinterpreted in the table, so it's included in the text so we could describe in more detail, but I will confirm that position of the board. That's my advice from the head of the area, but I will seek a response from the board.
Well, can I just follow it up then? I mean, it's the wonders of instant technology and instant answers. I would like a detailed response why each and every one of these items, so in other words, you've got two tables here, table 9 and table 10, and you've got line items, so in the first
Mr.
table 9
Donnelly,
you've
I'm
got...
sorry, I do apologise, but it is almost the end of the session. Can I just suggest Dr. Chant has already responded to say she will take this on notice. I think it's unreasonable to be asking us questions that have been, of decisions that have been made by the VAD board.
No, please, I'm entitled to ask this question.
Well, I feel like you've asked it,
no, I
and
have
we've
not
given you a response.
No. I've just been given a response that's come through via text message, and that's fair enough. But just to be very, very clear, if you count the items in table 9, there's 1, 2, 3, 4, 5,
Mr. Donnelly, your
7,
question's
8.
been taken on notice, and government members made points of order this morning when opposition members were repeating questions that had been taken on notice.
No, what the answer given is it may be misleading, if I'm not misquoting Dr. Chant, that the representation of the tables may be misleading. I want to know, Dr. Chant, through you, through the Secretary, the reasons why each one of these are potentially misleading. Because on the plain reading of it, for example, not an adult, well, that clearly can't be an issue of misreading or sort of being vague. I mean, either a person's 18 or not. So if the argument is that there's potential for confusion or potential misleading interpretation, I'd like the explanation through you on the answers on questions on notice, why these items are misleading. Thanks.
That brings us to the end of today's hearing. Thank you again to all of our witnesses. I acknowledge again there are very many of you in the room today, and this was a supplementary hearing. We're very grateful on behalf of the communities that we represent that you've provided that time to give evidence today. And I acknowledge that many of you won't get a rest over the holidays, of course, particularly at Health, but have a safe and happy holiday season.
Thank you very much.